Hello my dear doctors, now we are going to begin with the histology rapid revision. And in histology, in your exams, whether it is NEET PG, INA-SET or FMG exam, most of the time, like the most common things that they are being asking is about the epithelium as well as about the cartilages. So in our rapid revision session, we are going to discuss or revise rapidly about the epithelium and as well as about the cartilages. And as of course, you know very well, apart from the classification, the most important thing is learning the examples here. So I'll tell you rapidly about all these things here. So let's go ahead first of all with the epithelium. Now, we know that our epithelium is divided into two categories here. One will be the simple epithelium and another one will be the stratified epithelium. Simple means which is like having a single layer of cells, whereas stratified, it is having the multiple layer of cells. So simple means it is just having a single layer of the cells. Stratified means it is be having multiple layer of the cells. Now, based on the shape of the cell, again it is divided into three categories. That is your squamous, cuboidal, and the columnar. Squamous, cuboidal, and the columnar. So similarly, we'll be having simple squamous, stratified squamous, simple cuboidal, stratified cuboidal, and similarly the simple columnar and the stratified columnar. After telling you about all this epithelium, then I'll tell you some special categories also. So let's first start with the simple squamous epithelium. How to identify? You can very clearly see in this diagram here, the cells will be flattened. Flattened cells here in the simple squamous, and you can clearly see even the nucleus is also like very much flattened over here. That is the way how you identify the simple squamous epithelium. Mostly that will be present where? In the alveoli, number one example. Number two, our body cavities will be lined by the simple squamous epithelium. Apart from that, the Bowman's capsule, and even the loop of Henle will also have the simple squamous epithelium as well as the blood vessels. Blood vessels are also lined by simple squamous epithelium. Clear with this one here? So these are all the examples that you have to remember for the simple squamous epithelium. Number two, about the simple cuboidal epithelium. First, how to identify this one? Yes, in this one, the length of the cell and the breadth of the cell, I mean to say the height and the breadth, the length and the breadth of the cell is absolutely equal. They are cuboidal. And you can see the round and central nucleus there. That is the way how you identify this one here. And mostly simple cuboidal epithelium will be at those places which are concerned with secretions. Okay, so number one, it will be in the thyroid follicles, the follicular cells that we study a lot of time, which are going to secrete the T3 and T4. Fine. So thyroid follicles will have simple cuboidal epithelium. Number two, kidney tubules, proximal convoluted tubule, distal convoluted tubule, and even the collecting ducts, all of them, they will be having the simple cuboidal epithelium. And then germinal epithelium of the ovaries, that will also have the simple cuboidal epithelium. Then the next category here will be the simple columnar epithelium. How to identify? Again the same thing. Here the length of the cell will be longer when compared to the width of the cell. And you can see it will be like oval shaped nucleus. Oval nucleus will be present. So these are the points by which you can easily identify simple columnar cells. Now, where are they located? They are located in the stomach as well as the large intestine as well as the uterus. Okay. Now, that is like something simple, but the most important thing, which is like a repeated question in your exams, many a times they are asking this one here, simple columnar epithelium with microvilli. What is the purpose of microvilli? Try to learn with the purpose, try to learn with the action. What is the purpose of microvilli? Microvilli are going to increase the surface area for absorption. There are like multiple folds present there, increasing the surface area for absorption. And where do you require this one? Of course, in the intestine as well as the gallbladder. Intestine and the gallbladder. In the intestine for absorption, yes, surface area has to be increased, as well as in the gallbladder, what is going to happen? There will be concentration of the bile. So for that absorption also, what do you require? Microvilli. So in the exam, if they mention simple columnar epithelium with microvilli, remember two examples, small intestine and gallbladder. Similarly, the simple columnar epithelium with cilia, already given in the exam, sir, with cilia, and this will be required in those places where you have to deal with the movements, because the cilia are concerned with the movement. Number one, fallopian tube, and then the eustachian tube. Number three, the middle ear, and then the ependyma of the ventricles. There you have ciliated columnar. With microvilli will be present in gallbladder, asked in your exams. Clear? And by this, we have completed the simple epithelium, which will be just single layered. Now welcome to the stratified epithelium. Again the same thing, first it will be stratified squamous. Now my dear doctors, if you observe here, the cells in the lower layers here, they will be either cuboidal or columnar, fine. The cells in the middle layers here, they will be actually polygonal. And then the cells in the topmost layer here, they will be actually the flattened. So therefore remember, in the stratified multiple layers, the shape of the cells will differ. It will be having different shape. But how will you decide the name? The name will be decided only by the topmost layer. So that is why it is stratified squamous. Now how to remember the examples? Always try to make some trick here. Stratified means they are having multiple layers and it is like flattened. Okay. Most of the time this will be present in those places where there will be wear and tear, you know, like it has to be again replenished back. Okay, so therefore that stratified squamous epithelium, again we are dividing into two categories here, one which is keratinized and one which is non-keratinized. Stratified squamous keratinized, that will be present in our skin. Okay, and if you want to learn it in more depth, it will be present in the thick skin wala part, and of course in the anal canal, but not the entire anal canal, only in the lower part of the anal canal. And this is extremely important nowadays, and that is also present in filiform papillae of the tongue. In tongue topic, previously they used to ask the questions from the muscles of tongue and nerve supply, and nowadays in the PG exam they are asking a lot of questions about the papillae of the tongue. So please remember, out of all the papillae, filiform papillae are the one which will be having keratinized stratified squamous epithelium. Similarly, what about the non-keratinized? Non-keratinized will be present in the skin, but which type of skin, sir? Thin skin. Non-keratinized one. In the oral cavity, as I told you, wear and tear, remember. And then the tongue will also have the stratified squamous non-keratinized one, and then tonsils, esophagus, as well as the vagina. So all these parts where there will be like wear and tear will be having multiple layers, and here this will be non-keratinized. I hope it is very much clear here. Now moving on to the next one, stratified cuboidal epithelium, and this will be present in the ducts of exocrine as well as the sweat glands. So in the ducts of exocrine and sweat glands, you'll be having stratified cuboidal epithelium. Stratified columnar epithelium, columnar, please remember very carefully, it will be present in membranous urethra and the penile urethra. Now we know very well that urethra in the males is divided into how many categories? 3 categories or 3 parts. One will be prostatic urethra, then membranous urethra, then the penile urethra. Out of that, membranous and penile urethra will have stratified columnar epithelium, not the prostatic. There you will be having transitional epithelium, very much important. I'll tell you later on how to identify that one. Clear? Now moving ahead with the pseudo stratified epithelium. What do you understand from the name? Pseudo means false and stratified multilayered. So falsely it is appearing as multilayered. Why like this? Even though it is like single layer only, but falsely it is appearing like multilayer. Why it is appearing like this? Because of, yes, uneven arrangement of the nuclei. Nuclei are present up and down. That is the reason why it is appearing multiple layer, even though it is just a single layer. So if you look into this diagram here, in this diagram, all the cells are actually present on this basement membrane. That is all like single layered. But some of the nuclei are present below, some of the nuclei are present above here. That is the reason why it is giving the appearance as of pseudo stratified epithelium. Now, pseudo-stratified ciliated epithelium will be present in your respiratory tract. That will be in the trachea and the bronchus. Pseudo-stratified ciliated epithelium will be present in respiratory tract. Okay. Moving ahead with another special one, that is transitional epithelium. And I cannot stress on this one how much important is this one for your exams. How to identify the transitional epithelium? Again, there will be like multiple layer of cells, but you should look at the topmost layer here. In the topmost layer, you will be having cells which are actually going to cover multiple cells beneath them. So if you just look at one cell over here, any one cell over here, now that cell is actually going to cover like multiple cells beneath that. That is the reason why that is appearing to be like an umbrella cell, like an umbrella. Are you understanding me? So in this one, the topmost cells are like umbrella shaped. That is how you have to identify the transitional epithelium. And transitional epithelium will be present in urinary tract. Yes, it will be present in the bladder, urinary bladder. And then number 2 in the ureter also. as well as in the urethra, but only which one? Prostatic urethra, up to prostatic urethra. The urinary bladder and the ureter and prostatic urethra, you will be having transitional epithelium multiple times, has been asked in your exam. Is it okay? So in this manner, my dear friends, we are actually done with the epithelium. Okay. So how to learn about the epithelium? Divide into simple and the stratified. Simple again will have squamous cuboidal columnar. Stratified again will have squamous cuboidal columnar. And then you learn about the two special categories. One is pseudo-stratified, another one is transitional epithelium. That is the best way to revise quickly in our rapid revision session. Okay. Then next one. In your exams, they are asking about the cartilage. In our body, we are having three types of cartilages here. One will be the hyaline cartilage, and one will be the elastic cartilage, and then you'll be having the fibrous cartilage. How to identify? In the cartilage, you'll be having cells, and those cells are known as chondrocytes. And you can very clearly see here, the chondrocytes are actually arranged in groups here. Chondrocytes are arranged in groups, number one. And then after seeing the cells, look at the matrix here. The matrix will appear like a glass. Actual meaning of hyalose itself is glass. It looks like glass. It looks like clean, glass-like. So that is the reason why, that is how you identify the hyaline cartilage. So look for the cell and look for the matrix. Okay. So the cells are actually chondrocytes arranged in groups, and the matrix will be the, yes, hyalose, like a glass. Where exactly do you find the hyaline cartilage? Remember all the embryonic cartilages. Articular cartilages. Articular means what? For example, if this is the end of the bone here, at the joint, articulation, there it will be covered by a cartilage. And that cartilage will be the articular cartilage, the end of the bone. That is also an example of hyaline cartilage. Number three, costal cartilages, the one which are going to connect the rib with the sternum. That is also an example of hyaline cartilage. And then epiphyseal cartilage, the cartilage between the epiphysis and the diaphysis, the end of the bone and shaft of the bone. Epiphyseal cartilage is also an example of hyaline cartilage. And then the respiratory cartilages. All these are the examples of hyaline cartilages. Clear? Then the next one will be the elastic cartilage. Again the same thing. First, how to identify, because in the exam they are giving the image based question. Again the same thing here. You will be able to appreciate that the chondrocytes are actually in the group. But here, apart from these cells, if you look into the matrix, in the matrix you will be clearly able to see the fibers there. Those are nothing but your elastic fibers. It is not at all like hyalose, like glass-like. It's not like hyaline cartilage. Remember, here you'll be having fibers, that is your elastic fibers. Now, what are the examples of elastic cartilages? The best way to remember is, remember with E, eustachian tube and the ear lobe. Eustachian tube, elastic cartilage, and the lobe of the ear. This one here will also be an example of elastic cartilage. And apart from that, whatever examples are given here, you can very clearly see here, all these are present in the larynx. Now, when I taught you about the larynx topic, we divided the cartilages into two categories, unpaired and paired. Unpaired cartilages will be, one will be thyroid, another one will be cricoid, another one is epiglottis. So one will be the thyroid cartilage, and then the cricoid cartilage, and then the epiglottis. Okay. And then unpaired ones will be the arytenoid cartilage. Then we have got the corniculate and cuneiform. Corniculate and cuneiform. In this one, the thyroid cartilage and the cricoid cartilage, and in this arytenoid you'll be having two things. One will be the apex, another one is the base. And then out of these two, remember the base of the arytenoid. Clear? So whatever I'm marking here, I repeat again, thyroid, cricoid and base of arytenoid, this will be hyaline cartilage. This will be an example of your hyaline cartilage here, sir. And leaving this, remaining all will be the elastic cartilage. Let us cross check. Corniculate cartilage, yes, elastic. And then cuneiform cartilage, yes, elastic. Apex of the arytenoid cartilage, elastic. And then epiglottis is also an example of elastic cartilages. So in this manner, you can easily remember the examples of hyaline as well as elastic cartilages if you have learned the topic of larynx. Clear? Then after that, the last and final one will be the fibrous cartilage. How to identify first of all? Here, the chondrocytes, the cells, are not arranged in groups. They are actually arranged in rows. The chondrocytes are arranged in rows. And in the middle of that, you'll be able to find the fibers properly arranged over there. What are the examples of fibrous cartilages here? Number one, there will be meniscus, and then the articular disc, and then the glenoid labrum, and the intervertebral disc. All these are the examples of your fibrous cartilage. Fibrous cartilage, sir. Clear? So in this manner, we are also done with the histology part here, sir. And I want you to please rapidly revise about the epithelium and the cartilage before going to the exam. I think this is the best thing to be revised in our rapid revision session. Yes, of course, in our main videos, we have done with the in detail histology of other systems also. But just before going to the exam, this is the high yield part that you should revise before going to the exam, sir. Okay, I hope this will help you in your exam. Thank you, my dear friends. All the best. Hello, my dear doctors. Now we are going to start with the rapid revision of embryology. And of course, embryology is very much important for your exam. You know that very well. You know? So already embryology we have done in detail in our complete videos. And now in this revision session, we are going to revise all the high yield topics. Along with the high yield topics of embryology, we are also going to revise the previously asked questions also. Fine. So with this, let us get started with embryology. First, I'll tell you about the general embryology part, and then later on, we're going to see all the systems one by one, like development of the nervous system, then head and neck, then CVS embryology and gut embryology. Everything I'll teach you at once in a proper conceptual manner. Fine. So first, let us start with the general embryology part. Now, what is the meaning of pre-embryonic period? We'll call the pre-embryonic period up to 2 weeks of development. Then from 3rd week up to the 8th week, it is known as the embryonic period. And from the 9th week up to the birth, it will be known as the fetal period. Just some introduction to start with. Now, in gametogenesis, remember, first you'll be having the primordial germ cells. Primordial germ cells will be formed where? They will be formed in the epiblast. Primordial germ cells will be produced by epiblast, and that will be produced by 2nd week. And after the formation, they will be migrating from the epiblast to the yolk sac. And in the yolk sac, they will be migrating up to 4th week. And then from there, they will migrate to the genital ridge, from where the gonads are going to form, and that will be, they'll be reaching the gonads, they'll be reaching the genital ridge by 5th week. So you got to remember the time period. Primordial germ cells are forming in epiblast by 2nd week, and then they'll migrate to the yolk sac by 4th week, and then from there, they'll be going to the genital ridge, the gonads, by 5th week. Fine. Now, sometimes what will happen, instead of this normal migration, if they abnormally migrate to the neck, that is nothing but leading to craniopharyngeal teratoma. Craniopharyngeal teratoma. So what is craniopharyngeal teratoma? Nothing but abnormal migration of primordial germ cells to the neck region. Now, sometimes abnormally they'll be migrating to the sacrum and coccyx, and that will lead to sacrococcygeal teratoma. Sacrococcygeal teratoma, sir. Now, after this, now what is going to happen? Let us see the spermatogenesis first. Now, spermatogenesis, we know very well, it will be taking place in seminiferous tubule, and the duration of spermatogenesis will be like 72 to 74 days. Please don't forget the days, it is days. Now, spermatogenesis begins with spermatogonium cells, and these spermatogonium cells will first undergo mitosis. Almost like 5 to 7 cycles of mitosis to form primary spermatocyte. And primary spermatocyte will be still diploid. Why? Because still only mitosis has taken place. So still the cells are actually diploid. Now this primary spermatocyte will start undergoing meiosis, and of course meiosis 1. And in meiosis 1, what is going to happen? Yes, number of chromosomes are reduced to half. That is why the primary spermatocyte will be diploid, whereas secondary spermatocyte will be haploid. Now, the secondary spermatocyte will actually undergo meiosis 2 to complete the meiosis, and it is going to form spermatid. Now, till the formation of the spermatid, remember the cell will be like a normal cell with a cell membrane, cytoplasm, and the nucleus over there. Now, this spermatid will undergo structural modification to form spermatozoa with the head, neck, middle piece, and the tail. And this morphological or the structural changes which are taking place here, it is known as spermiogenesis. It is spermiogenesis. Be very careful here. It is not spermatogenesis. It is actually spermiogenesis. Fine. And finally, the spermatozoa is formed here. Now, after the formation of the spermatozoa, yes, right now they'll be at the tip of the Sertoli cells. From there, they'll be actually released. The process of release of the spermatozoa from the Sertoli cell is known as spermiation. And once the spermiation will occur, now the spermatozoa will travel, migrate, and finally go to epididymis. And you cannot forget this epididymis for your exam. Why? Because storage of spermatozoa will take place in epididymis. Maturation of spermatozoa answer epididymis, and even the spermatozoa is gaining motility in epididymis only. Okay. And spermatogenesis, or the duration of this one, I already told you, 72 to 74 days. Okay. So in one of the exams, they've actually asked about, arranging all this in order. So please remember all these structures, you have to remember them in order. So first you'll be having spermatogonium cells. They are going to become primary spermatocyte, then secondary spermatocyte, and then there'll be spermatid, and then spermatozoa. Perfect. So all these things you have to actually learn in detail. Now, once you are done with this introduction here in the embryology, now let's start with something really important. The picture that you're able to see on the screen here, it is the transverse section of embryo. And exactly the same diagram was given in the exam recently. So let us try to understand everything in this diagram here. Now this is the transverse section, and it is actually in which week right now, sir? It is in third week. In third week, it is a week of gastrulation. Gastrulation means formation of all the three germ layers. So this one here will be the ectoderm, and this here will be the endoderm, and this one here will be the mesoderms. First week and second week, most of the students will be normally knowing it very easily. Fertilization will be taking place in ampulla. Then there'll be formation of morula with the 16 cells. Then the late morula with 32 cells. It will enter into the uterus on 4th day. And implantation, all these things, most of the students will be commonly knowing it. So in this rapid revision session, I'm directly starting with the third week. This is the place where most of the students will be actually confused. Now, in third week, gastrulation will take place. Gastrulation means formation of all three germ layers. And remember, all the three germ layers are actually formed from primitive streak. Okay, so all these three germ layers are formed from primitive streaks. Okay, now primitive streak is going to form all three germ layers, but in which order? That is also important. The first germ layer to be formed will be endoderm, and the second one will be the mesoderm, and the third one will be the ectoderm. The first endoderm will be formed, then mesoderm, then ectoderm will be formed. Now in this diagram, this structure that you're able to see here, this is notochord, so this green colored one, notochord. And remember, notochord will be derived from where? It is derived from the primitive knot. So primitive knot is the one which is going to form the notochord, sir. Primitive knot, it is also known as the Hensen's knot. Okay. Now above the notochord, this tube-like structure that you're able to see here, that is the neural tube. Don't worry, I'll also teach you the formation of the entire neural tube in detail. For now, we are just trying to understand all the structures over here. So above the notochord, there will be formation of neural tube. And just adjacent to the neural tube, there will be neural crest cells. Just adjacent to the neural tube, there will be neural crest cells. And that was actually marked in one of the exam recently. So exactly the same image was given, and there was arrow mark over there. Just adjacent to the neural tube, in this region, you will be able to appreciate the neural crest cells on either side. Now let us focus on to the mesoderm right now, sir. Now the mesoderm that is present over here, it's actually intra-embryonic mesoderm. There'll be like two types of mesoderm, extra-embryonic and intra-embryonic. Extra-embryonic mesoderm will be seen in second week. But right now, this one here is the intra-embryonic mesoderm. Now, intra-embryonic mesoderm is in turn divided into three parts here. The one which is along the axis here, this one will be known as the para-axial mesoderm. It is along with the central axis, paraxial mesoderm. Then this red colored one here, this will be the intermediate mesoderm. The name is very much meaningful here. It's in the middle, intermediate mesoderm. And then this one here will be the lateral plate mesoderm. This is lateral plate mesoderm here. Okay. So intra-embryonic mesoderm is actually again divided into three parts here: paraxial, intermediate, and the lateral plate mesoderm. Now, once you are familiar with all this terminology here, in this diagram, you're able to identify all the structures here. Let us discuss about them in detail one by one, sir. So now first, let us discuss about the intra-embryonic mesoderm. So as I told you, this one here will be the paraxial mesoderm here, paraxial mesoderm here. This one will be the intermediate mesoderm here, and this is the lateral plate mesoderm. Now out of these three, first let us deal with the intermediate mesoderm. Intermediate mesoderm is in turn going to form two structures. Number one, nephrogenic cord, nephrogenic cord, sir. And number two, it is going to form the genital ridge, genital ridge. Okay. So intermediate mesoderm is going to form nephrogenic cord as well as genital ridge. Now out of these two, we know very well, genital ridge is the one which is going to form gonads. Genital ridge will form what's a gonads. Okay. And nephrogenic cord, from the name itself we can understand nephros, genic, formation. So it is the one which is actually going to form your kidney. So basically what we can say here is that intermediate mesoderm is the one which is going to form your entire urogenital system. Intermediate mesoderm is the one which is going to form kidney, uro, and then genital system. Okay. So nephrogenic cord is the one which is going to form your kidneys, whereas the genital ridge is going to form the gonads. Now once you learn about this one, now what you do is learn about the paraxial as well as the lateral plate mesoderm together. How? I'll tell you here. First of all, this paraxial mesoderm, it's going to form your spherical ball-like structures known as somites. Paraxial mesoderm is going to form what? Somites. Now that is the reason why I have given you this diagram here. In this diagram, in the center, you're actually able to see, yes, this one here will be the central axis, your notochord in the middle. Notochord and that neural tube above that which is forming there in the middle. On either side, actually, there will be paraxial mesoderm here. And this one also is the paraxial mesoderm, sir. Now, this paraxial mesoderm is the one which is going to form spherical ball-like structures over here. And this one will be the somites. Okay. So, paraxial mesoderm is going to form your somites. Now, this somites are in turn actually having three parts, sir. Somites are spherical ball-like structures like this. Now, this somite will in turn have three parts. Number one, they will be, just I'm drawing a schematic diagram here, not exactly like this. Number one, there will be dermatome. It will have dermatome. And number two, there will be sclerotome. And then there will be myotomes. Dermatome, myotome, and the sclerotome. These are the three parts of your somites. Okay. Now, out of these three parts, from the name itself, we can understand dermatome. Dermatome, it is going to form what? Dermis. And then remember, it is going to form the dermis of back of the body. Dermatome is going to form the dermis of back of the body. Sclerotome, it is actually going to form the skeleton, but remember, it is going to form only the axial skeleton. Axial skeleton, okay? The vertebrae in the middle, the ribs and all, axial skeleton will be formed by sclerotome. Myotome, from the name itself, we can understand myo, muscle, it is going to form the muscle. But this is again divided into two categories. One is epiaxial myotome. Another one will be the hypoaxial myotome, sir. One is epiaxial myotome and hypoaxial. Now, epiaxial myotome, in that embryo, remember, it is the one which is going to form your back muscles. Okay. The epiaxial is going to form back muscle, whereas hypoaxial myotome, it is the one which is going to form the muscles of your upper limb and the lower limb. Then abdominal, intercostal, all these muscles in the front are formed by hypoaxial. Epiaxial is going to form back muscle, whereas hypoaxial is going to form the remaining. So epiaxial is going to form the true back muscles. True back muscles. Okay. For example, in one of the exams they have given erector spinae muscle. So erector spinae muscle is actually derived from epiaxial myotome. Hypoaxial myotome is the one which is going to form your limb muscles. And then it is also going to form the abdominal muscles. And as well as it is also going to form the intercostal muscles. This is the thing that you have to learn about the paraxial mesoderm. The paraxial mesoderm is first going to form spherical ball-like structures known as somites, and somites will in turn have three parts: dermatome, sclerotome, and the myotome. Now, once you learn about this one, whatever is actually corresponding, the remaining, that will be derived from the lateral plate mesoderm. So it is very easy to remember right now in this manner. So dermis of the back is formed from here. So dermis of the front will be from lateral plate mesoderm. Similarly, axial skeleton is formed from paraxial mesoderm. Appendicular skeleton will be derived from lateral plate mesoderm. Similarly, if you are looking at all these muscles over here, those muscles like back muscles, the limb muscles, all of them are skeletal muscle. So in our body, we are having three types of muscle: skeletal, smooth, and cardiac muscle. So skeletal muscle, if it is derived from paraxial mesoderm, then smooth and cardiac muscles should be derived from lateral plate mesoderm. Are you understanding the way how you have to learn? So first you learn everything derived from the paraxial mesoderm, then the remaining everything will be coming from the lateral plate mesoderm. So that is the best way to actually approach this topic, sir, to learn this topic. Now let us go a little bit in more depth here. For example, if this one here will be the lateral plate mesoderm, you can clearly see here inside the lateral plate mesoderm there will be a cavity, and that coelom will be the intra-embryonic coelom. Now, because of this intra-embryonic coelom, the lateral plate mesoderm is actually divided into two parts. The one which is along with the ectoderm, it is somatopleuric lateral plate mesoderm, and the one which is along with the endoderm, that is nothing but splanchno, that is splanchnopleuric lateral plate mesoderm. Okay. So intra-embryonic coelom is actually going to divide the lateral plate mesoderm into two parts. One will be the somatopleuric, another one is the splanchnopleuric. Fine. Now what are they going to form? Makes sense. Intra-embryonic coelom is the one which is going to form the cavities present inside our body. So number one, we have got the pericardial cavity. Number two, there is a pleural cavity. And number three, there will be peritoneal cavity. So all these cavities which are present inside our body will be derived from intra-embryonic coelom. Now think about this like this. All the cavities present inside our body has got like two layers. The outer one parietal, inner one will be the visceral one. All the parietal layers are derived from somatopleuric lateral plate mesoderm. And all the visceral layers will be derived from splanchnopleuric lateral plate mesoderm. It's very, very conceptual here. If you learn in this manner, please don't try to mug up this one here. Okay. So all the cavities inside our body should be derived from intra-embryonic coelom. And then whatever parietal layers are there, they are derived from somatopleuric lateral plate mesoderm. And whatever visceral layers are there, they are derived from splanchnopleuric lateral plate mesoderm. Then, after learning this, I told you very clearly, compare the paraxial mesoderm with the lateral plate mesoderm. So here there is a dermis of back. There should be dermis of front. Here it is axial skeleton. There should be appendicular skeleton. Now, dermis of the front and then appendicular skeleton, they should be derived from splanchno or somato. So obviously, when it is about the dermis, when it is about the skeleton, it's all derived from somatopleuric lateral plate mesoderm. Perfect. And then there we have already learned that skeletal muscles are derived from the paraxial mesoderm, that to myotome part of the somites. Fine. So which muscles are left out right now? We are left out with the smooth muscle and the cardiac muscle. So remember, the smooth and cardiac muscles are derived from splanchnopleuric lateral plate mesoderm. So therefore, remember my dear friends, if I am writing smooth muscles and cardiac muscles here, that means our heart will be derived from where? To be very, very specific, our heart is actually derived from splanchnopleuric lateral plate mesoderm. So in this manner, what you do is learn in exactly the same manner which I have taught you here. So, okay. The first you are going to learn about intermediate mesoderm. Intermediate mesoderm is the one which is going to form urogenital system. Then what you do is you learn about the paraxial mesoderm. It is going to form somite, and a somite will actually have three parts: dermatome, sclerotome, and myotome. Then whatever is left out, you actually dump it under lateral plate mesoderm. But be careful with the somatopleuric and the splanchnopleuric. Somatopleuric lateral plate mesoderm is going to form, yes, the dermis of the front as well as the appendicular skeleton. Whereas splanchnopleuric lateral plate mesoderm, it is the one which is going to form the smooth muscles and the cardiac muscles. Makes sense. Now, after learning all this, what is the septum transversum here, sir? This is something very much important nowadays. Remember, septum transversum is undifferentiated lateral plate mesoderm. I told you that the lateral plate mesoderm is divided by the coelom into splanchnopleuric and somatopleuric, but there will be a certain region in the embryo where these two are not differentiated. We cannot differentiate the somatopleuric and splanchnopleuric. So for example, if this is the embryo here, in the embryo, exactly in the center, you're actually having the notochord here like this. This is the notochord here. On either side, paraxial, paraxial, then intermediate, intermediate. Then you'll be having the lateral plate and lateral plate. Now this lateral plate mesoderm will be again differentiated into somatopleuric and splanchnopluric. But when you go more cranially, the somato and splanchnopluric will not be differentiated. And that undifferentiated lateral plate mesoderm is known as septum transversum. Septum transversum. So it is present where, sir? Cranially. And number two, second thing is that it is the cranial most structure in the embryo before folding. We know very well the embryo will undergo craniocaudal fold. So before folding, just before the folding, which is the cranial most structure, that is septum transversum, already asked in your exam. Now, what are the derivatives from the septum transversum? There are totally 4 derivatives you have to remember. Number 1, the central tendon of diaphragm. The central tendon of diaphragm. Number 2, the fibrous pericardium. The fibrous pericardium around the heart. And then the stroma of the liver. And then the ventral mesentery of the stomach, which is also known as ventral mesogastrium. Okay. Now try to understand like this, or try to remember like this here. Septum transversum is going to form all the structures over here. So number 1, it is going to form the central tendon of the diaphragm. Above that, the heart covered by fibrous pericardium. Then the stroma of the liver here and the ventral mesentery of the stomach. These structures over here. Now I think my 2 statements are like contradicting each other. I told you just now, septum transversum is the cranial most structure before the fold. And now I'm telling you it is going to form these structures over here. So in the embryo, what is going to happen? The cranial most structure is septum transversum. And when it is folded, after folding, that structure will be coming over here. That is the reason why septum transversum is going to form all these structures present over here. I hope now it is making sense. Okay, now. So septum transversum is the cranial most structure in the embryo before the fold, but after folding, what is going to happen? It is going to form all these 4 structures over here. So, okay. So by this, we are done with the concept of septum transversum also. Now after completing this one here, yes, we have discussed in detail about the paraxial mesoderm, as well as the intermediate mesoderm, as well as the lateral plate mesoderm. Okay, that topic is completed. Now let us see the other cells also, other structures also here. Now in this diagram, I told you very clearly, this green colored structure here is notochord. Now, what is the function of notochord? Notochord is going to actually induce the overlying ectoderm here to form the neural tube. So, notochord is actually helping in the formation of neural tube. And how is that neural tube forming and all? I'll tell you in the next topic. Don't worry about that. For now, let's study what will happen to the notochord after the formation of neural tube. Neural tube is already formed there. Then after the formation, what is the end result of this notochord? The notochord will actually degenerate. But we do have certain remnants of the notochord. Number 1, that is nucleus pulposus. Where is this present? Intervertebral disc. So between the 2 vertebrae, you'll be having intervertebral disc. In the center, you'll be actually having nucleus pulposus. It is a remnant of notochord. Apical ligament of dens, and then the membrana tectoria or tectorial membrane. Okay, all these 3 structures are the remnant of notochord, sir. Then I told you above the notochord there is a formation of this neural tube. Now let us see what is this neural tube forming. Neural tube is the one which is going to form your central nervous system, that is your brain and the spinal cord. Along with that, they're also going to form oligodendrocytes, astrocytes, as well as ependymal cells. All these are nothing but the glial cells, neuroglial cells, the supporting cells. And along with that, I request you all to remember retina. Even retina is also derived from the neural tube. It's an extension of the diencephalon only. Okay. Then after that, these cells here will be the neural crest cells. And neural crest cells derivatives very much important. Of course, it has to form the components of peripheral nervous system. So it is going to form all the ganglions present in our body, along with the Schwann cells as well as the enteric plexus, the plexus present inside the intestinal wall. I hope you have learned about that myenteric plexus, Auerbach's plexus and all. So that is actually derived from neural crest cells, a part of your peripheral nervous system. Apart from that, it is also going to form adrenal medulla. In the adrenal gland, you'll be having 2 parts. The outer part will be cortex, inner part is medulla. And adrenal medulla itself is referred to as a modified ganglion only. So even that is also derived from the neural crest cells. Parafollicular cells or C cells, which are present in the thyroid gland, are also derived from the neural crest cells. Melanocytes are also derived from the neural crest cells. Yes, most of the skull bones as well as the pharyngeal arch cartilages, and yes, the most important one, conotruncal septum. Conotruncal septum is made up of two septums, and number one, spiral septum, and number two, there will be bulbar septum. So I hope you people have learned about this spiral septum and bulbar septum in the CVS embryology, cardiovascular system embryology, development of the heart. Okay, so these two septum together it is known as conotruncal septum, and that is also derived from neural crest cells. Perfectly done. So by this we are done about the notochord here, the neural tube here, as well as the neural crest cells. Now once we have completed all these topics over here, let us go ahead with the development of diaphragm. When you learn about the development of the diaphragm, remember diaphragm will be actually derived from the four components. Out of that, almost like two components you know very well. Apply a little bit of common sense. Number one, septum transversum. This C here is actually the septum transversum. I told you it is the one which is going to form central tendon of diaphragm. Number two, the body wall mesoderm, nothing but your somites. Somites are the one which are going to form skeletal muscles. The somites are the one which are also going to form the muscles of diaphragm. You remember that? Sclerotome, myotome, dermatome and all. So myotome is going to form the muscle part. But in exams, the confusing part will be the cervical. So please underline this or highlight. Cervical somites are going to contribute for the formation of muscles of diaphragm. Cervical somites. So how come cervical somites are contributing these muscles here? Remember, with the help of nerve supply. What is the nerve supply to the muscles of diaphragm? Phrenic nerve. And phrenic nerve is originating from where? C3, C4 and C5. So that is why these are the somites which are going to contribute. So in exam, what will happen? You'll get confused. Ke diaphragm yahan hota hai. Diaphragm will be present over here. How come cervical will contribute? So please remember the trick, the phrenic nerve. Phrenic nerve is coming from here and supplying. Next, after that, in the middle, there'll be passage of esophagus. And then this will be surrounded by the peritoneum. So it will be coming here and going back. And whenever you have this double layer of peritoneum, that is known as, in general, mesentery. And that is the mesentery for esophagus. That is why it is known as mesoesophagus. And it is present on which side? Dorsal side. Dorsal mesoesophagus. Dorsal mesoesophagus. After that, suppose if diaphragm is present over here, above you'll be having the pleura and below you'll be having the peritoneum. So there'll be pleuroperitoneal membrane, pleuroperitoneal membrane. Okay. And this D here will be the pleuroperitoneal membranes. So all these four structures are together going to help in the formation of diaphragm. So let us revise again right now. Diaphragm will be derived from four structures. Number one, septum transversum. Number two, the body wall mesoderm, nothing but cervical somites. Number three, yes, the pleuroperitoneal membrane. And number four will be the dorsal mesoesophagus. So all these four structures are going to form your entire diaphragm. Now sometimes in some unfortunate babies, what is going to happen? Pleuroperitoneal membrane will not be formed. Pleuroperitoneal membrane will not be formed. When this pleuroperitoneal membrane is not formed, then what is going to happen? During development, the pressure is more in the abdomen. So abdominal organs are actually going to herniate into the thorax, compressing the lungs. Lung hypoplasia will occur, and that condition is known as congenital diaphragmatic hernia. So congenital diaphragmatic hernia will occur due to what? Due to the absence of pleuroperitoneal membrane. Please remember that. So out of the four structures, which structure is defective here? Pleuroperitoneal membrane. So if this membrane is absent, then it will lead to congenital diaphragmatic hernia. Recently in the FMG exam, this image was given, and in this image you can very clearly observe here the loops of the intestine will be herniating into the lung. Acha. In the congenital diaphragmatic hernia, which is like most common type, Bogdalak hernia. The Bogdalak hernia is like most common type here, and remember, most commonly it will be appearing towards the left side when compared to the right one. So yes, the most common congenital hernia will be the congenital diaphragmatic hernia will be Bogdalak hernia, most commonly towards the left side. So by this, one more topic completed here. And I hope you people are actually understanding my planning here. Why did I teach you about the development of diaphragm here itself? Yes, just now we have learned about septum transversum, undifferentiated lateral plate mesoderm, and just now we have even learned about the somoids, which is going to form the muscle part. So in this manner, easily you can remember the topic here itself. Okay, so one more topic completed here, sir. Now moving on to the next one, as I told you, we are going to learn about neurulation. Now, what is the meaning of neurulation? Remember, formation of neural tube. So formation of neural tube is nothing but neurulation, sir. When it is happening, remember, neural tube formation begins in 3rd week. So it is going to begin in which week, sir? It begins in 3rd week. Now, the moment you look at this diagram here, I hope you're clearly able to understand it is the transverse section of embryo. Now, in this transverse section of the embryo, this one is ectoderm here. This one will be the endoderm here. And this is actually the intra-embryonic mesoderm. And no doubt about that, this is notochord here, sir. Now, this notochord is going to induce the overlying ectoderm. So once it induces the overlying ectoderm, this is going to become a plate which is known as neural plate. This is going to become the neural plate. Now the ends of the neural plate are actually folded here, and these folds here are known as the neural folds. And these neural folds are coming closer. That is the reason why in the middle there is a formation of groove here. And this groove here will be the neural groove. Okay, so there will be a neural plate. The ends will be folded neural folds, and the folds are coming closer. In the middle there will be a groove. That groove is known as neural groove there. Perfect. And one fine day, what is going to happen? The neural folds are coming closer, and they will fuse together, and that results in the formation of neural tube here. So neural tube is formed in such an easy manner here. So perfect. Now what is going to happen? The neural folds are going to multiply and differentiate certain cells over here. And these cells, which are actually separated apart here on either side of the neural tube, these are the ones which are going to form neural crest cells. Perfect. And I think I don't even have to tell you again and again what are the derivatives of all this, sir. I already taught you the derivatives of neural tube as well as neural crest cells, as well as I taught you about the notochord also. That's all completed. Now, one important MCQ here is that the neural folds are coming closer and they will merge together and they will start forming the neural tube actually. Now, the question in the exam was neural tube formation begins from which region? I mean to say the neural fold and neural fold are going to fuse together. And once they fuse together, it's like a zipping mechanism. They will start closing cranially also and it will start closing caudally also. But the closure begins from where? The neural tube formation begins from which region? So please remember, the neural tube formation begins from cervical region. The closure begins from which region? Cervical region, already asked in your NEET PG exam, sir. Neural tube formation begins in the cervical region. Okay. Now after that, please look at this diagram here. This is how exactly the neural tube looks like. Now in this neural tube, first there will be two pores here, sir. There will be one anterior neuropore and then there will be a posterior neuropore here, sir. This anterior, it is also known as the cranial neuropore, or else it is also known as a rostral neuropore. This word was used in FMG exam. So cranial neuropore or rostral neuropore or anterior neuropore. And similarly, this one here will be the posterior or caudal neuropore. Now, in the normal healthy people like you and me here, what should happen? The neuropore should normally close. Why? Because we know very well, neural tube is the one which is going to form your central nervous system. So cranial part is going to become the brain and the caudal part is going to form spinal cord. Now we don't have any opening here in the brain. We don't have any opening in the spinal cord. It is completely closed there. So remember, the cranial neuropore will be closed on 25th day. So cranial neuropore closes exactly on which day? 25th day. Caudal neuropore closes on 27th or 28th day. If both the options are given in the exam, better option will be 28th day, sir. Okay. So the cranial neuropore will normally close on 25th day. Caudal neuropore should be closing on 28th day, sir. But in some unfortunate babies, if they fail to close, then what will happen? If the cranial neuropore does not close, if it fails to close, then it will lead to a condition, and this condition is known as anencephaly. This is anencephaly condition. Okay. Recently in the FMG exam, almost every exam, there is one question from the defects in the neural tube, sir. So please remember, this image was actually given in the exam. So failure of closure of cranial neuropore results in anencephaly. Fine. Similarly, if the posterior neuropore or the caudal neuropore fails to close, it will lead to spina bifida. This condition will be known as spina bifida. If the cranial neuropore fails to close, anencephaly, and if the caudal neuropore fails to close, spina bifida. Now, just last year, this image was given in the FMG exam where you have anencephaly. Along with the anencephaly, there is a defect of the spines also. The bony defect of spine. I mean to say, in the vertebral column, you'll be having transverse and transverse process, and then you'll be having spinous process. Now, the spinous process will also fail to fuse together. And once the spinous process will fail to fuse together, if they are not fused together, then the spinal cord will be exposed outside, and all that, CSF will be leaking outside. Now, this condition is referred to as cranial rachis or craniorachis. So what is this craniorachis? It is anencephaly plus the bony defect of spine. Anencephaly along with the bony defect of spines. That is craniorachis. This slide on the screen here, extremely important, my dear friends. Extremely important. Always you can expect a question from this slide on the screen here. So you should remember, normally when should the neuropore close, and if it doesn't close, then what is going to happen? Okay, perfectly done, sir. Now, after completing the development of the neural tube and all the neural tube defects, now let us go ahead with the head and neck embryology. And in head and neck embryology, we are going to learn about the pharyngeal cleft and the pharyngeal pouches and the pharyngeal arches. Okay. So in this diagram, first you are able to see the ectoderm, and ectoderm will actually invaginate. And this invagination here will be known as the ectodermal cleft. Actual name is actually the pharyngeal cleft, but I'm wantedly using the name here as ectodermal cleft so that my students should be able to remember that clefts will be derived from ectoderm. Similarly, endoderm will actually evaginate, and this evagination here will be known as the pouches. So pouches are actually derived from the endoderm. Now remember that there are totally 4 ectodermal clefts. Similarly, you'll be having the 4 endodermal pouches. Fine. So clefts will be derived from ectoderm and the pouches will be derived from the endoderm. Now what about the mesoderm in the middle? Remember, the mesoderm in the middle is the one which is going to form your pharyngeal arches. So pharyngeal arches will be derived from the mesoderm. In total, there will be like 6 pharyngeal arches initially, but later on during development, the 5th arch will degenerate. That is the reason why you're having 1, then 2, then 3, then 4, and then finally there will be 6th pharyngeal arch. The 5th one will actually degenerate here. So 1, 2, 3, 4, and then 6. And then the remnant of that one here will be the ultimobranchial body. So there will be a remnant here, and that remnant will be known as the ultimobranchial body. Ultimobranchial body. Okay. Now, once you are done with the cleft and the pouches and the arches, from where are they actually derived? Now let us see what are the derivatives of this one. And I'm going to complete all these things in one diagram here, sir. Now, the first ectodermal cleft. Actually, I told you the best way to learn this one is actually apply this on your body here. So in this region, this is the ectoderm here. Ectoderm will invaginate inside here. So you can just look at my finger over here. The first ectodermal cleft is going to form external acoustic meatus along with the outer layer of tympanic membrane. And then the second and the third and the fourth ectodermal cleft will be completely obliterated. It will be closed. Why? Because the second arch, arch is nothing but formed from mesoderm. That second arch is growing faster, and it is actually going to overlap the second and the third and the fourth cleft. Because of this reason, the second, third and the fourth cleft will be obliterated. That's all. This topic is completed here. Now, when the second arch is growing faster over here, there will be formation of one space here, sinus here. That sinus is known as the cervical sinus. In healthy individuals like you and me right now, that cervical sinus is completely closed here. It is completely closed. But in some people, unfortunately, the cervical sinus will persist here. Persistence of cervical sinus will lead to the formation of branchial cyst, or else if it is having the communication with outside, it is known as branchial fistula. So what is branchial cyst or branchial fistula? It is nothing but persistent cervical sinus. Okay, that's all about the ectodermal cleft. Now what about the endodermal pouches here? The first pouch is going to form the middle ear, because it is the one which is coming and joining with the external ear over there. Okay, so it is going to form middle ear cavity along with the auditory tube as well as inner layer of tympanic membrane. Inner layer of tympanic membrane. Second pouch, it is the one which is going to form your palatine tonsils here. But it is not going to form the entire palatine tonsil. It is just going to form epithelium of the palatine tonsil. Now the third pouch here, it is the one which is going to form thymus. So remember, with the rhyming word, third pouch is going to form thymus. Along with the thymus, it is going to form inferior parathyroid gland, whereas the fourth pouch is the one which is going to form superior parathyroid gland. Now can you see there, it is looking like kind of opposite there. Third pouch is above, it is going to form inferior parathyroid gland. Fourth pouch is actually present below, but it is going to form superior parathyroid gland. Why it is happening like this here? Why? Because remember, my dear friends, third pouch is going to form thymus, and thymus, after the formation, it has to migrate down. So while it is migrating down, it is going to carry the parathyroid gland also along with that one. So it is going to become your inferior parathyroid gland. So try to remember in this manner. Okay. So remember, third pouch is going to form thymus. And once you remember thymus, it's going to migrate down. So therefore, along with that, inferior parathyroid gland is formed. Whereas fourth pouch is the one which is going to form superior parathyroid gland. Now, this question is like repeatedly asked in your exams, especially in INA-SET exams is asked, DiGeorge syndrome. DiGeorge syndrome is actually a deletion syndrome, 22nd chromosome, 22q11 deletion syndrome. And in DiGeorge syndrome, yes, third and fourth pouch will be actually involved. But out of these two, if you want the best answer, remember third pouch. So the third pouch fails to develop here. Of course, thymus will not be formed. Along with that, even the parathyroid gland is also not formed there. So parathyroid gland is actually concerned with regulation of blood calcium level. So therefore, they will lead into hypocalcemia, as well as thymus gland is also not formed there. So therefore, there will be thymic hypoplasia will occur. Okay. So thymic hypoplasia as well as the hypocalcemia here. Apart from this, there are like so many other signs and symptoms of this DiGeorge syndrome. But right now, I'm just telling you pertaining to anatomy part. Okay. Done. Now, after completing about the ectodermal cleft and the endodermal pouches, now let us go towards the mesoderm, which is going to form your pharyngeal arches. Before going to the pharyngeal arch, I hope all of you know about the tympanic membrane. Between the external ear and the middle ear, there will be tympanic membrane. Tympanic membrane will be derived from which germ layer? And I hope all of you have learned very well, it is derived from all the three germ layers, ectoderm, endoderm, as well as the mesoderm. You can very clearly see here in embryology, ectoderm is going to form the outer layer of tympanic membrane. Endoderm is the one which is going to form inner layer of tympanic membrane, and in the middle you'll be having the mesoderm. So tympanic membrane will be derived from all three germ layers. Now let us learn about the pharyngeal arches. Pharyngeal arches, they are derived from mesoderm. And mesoderm is the one which is going to form your cartilage, it is going to form the bone, it is also going to form the muscles and all. So let us see first about the bones and the cartilages. And to learn the derivatives of the pharyngeal arches, this is one of the best diagram to learn there. Now in this diagram, you can clearly see there that it is forming a layer by layer. So whatever is highlighted there in the orange color there is all that structures are derived from the first arch. Similarly, after that, whatever is highlighted in the blue color there, it is actually derived from the second arch. So let us try to see one by one. In the ear, there will be like three ear ossicles. Three bones will be there. One is your malleus, incus and stapes. Malleus, incus and stapes. Remember, S for stapes, S for second arch. S for stapes, S for second arch. So what is remaining there? Malleus and incus. That will be derived from the first arch. So in this diagram, we can very clearly see here, malleus and incus will be derived from the first arch. Along with that, there will be anterior ligament of malleus. Deep inside will be having the sphenoid bone. Then from the sphenoid bone to the mandible, sphenomandibular ligament. And then the mandible, and then from here itself even the maxilla will be formed. All this will be actually derived from the first arch. I repeat again, malleus and incus, along with the anterior ligament of the malleus, along with that sphenomandibular ligament, and then mandible and the maxilla. All this will be actually derived from the first arch. Now what will be derived from second arch, sir? Yes, we already know very well, stapes will be derived from here. And along with that, there will be styloid process. And from the styloid process, there is a ligament going towards the hyoid bone, stylohyoid ligament. And then in the hyoid bone, only the lesser horn and upper part of the body. Lesser horn and upper part of the body. All this will be derived from the second arch. Okay. So I hope you all know about the hyoid bone. Hyoid bone will be something like this here. Greater horn, lesser horn, which is also known as the lesser cornua and greater cornua. So in this lesser horn and only the upper part of the body, this much part will be derived from the second arch. Then now you know the trick how to remember this one here. Greater horn and lower part of the body. Obviously that should be derived from which arch? Third arch. Third arch is going to form the greater horn and lower part of the body. And after the hyoid bone here, you'll be having your larynx. And larynx is made up of cartilages. Remember, all the cartilages of larynx are derived from fourth and sixth arch. Except which one here? Except the epiglottis. Okay. All the cartilages of larynx are derived from fourth and sixth arch except epiglottis. Epiglottis will be derived from hypobranchial eminence. I'll tell you that later on. It comes in development of the tongue. That is the reason why I was telling you this is like the best diagram. To learn all that structures, you cannot just make a list and just simply mug up like that. So try to apply this one on your body here. So it's forming like layer by layer by layer. First arch, second arch, third arch, fourth arch and sixth arch. It's easy to remember. Now in this diagram, if you are observing there, we are done with bones and ligaments. Now let us see the muscles which are derived from all these pharyngeal arches. Okay. Now to learn about the muscles, I will tell you a beautiful trick here. The golden rule here is that what are the nerves which are supplying to the pharyngeal arches? Pharyngeal arch number 1 will be supplied by mandibular nerve, that is your 5-3. Arch number 2 will be supplied by facial nerve, that is your 7th nerve. Arch number 3 is supplied by glossopharyngeal nerve, 9th one. And arch number 4 and 6th will be supplied by superior laryngeal nerve and recurrent laryngeal nerve. It should be actually the 6th one here, not the 5th. Yeah. And both of them are actually the branches of vagus only. Okay. Now, how to remember or memorize all these nerves right now? My dear friends, remember 5, 7, 9, 10. That is the best way to remember. 5, 7, 9, 10. Now, why I'm asking you to remember in this manner here? In our entire medicine, we actually have this 7, 9, 10. When you study about the parasympathetic nervous system is craniosacral outflow. Which cranial nerves are involved in the parasympathetic nervous system? 3, 7, 9, 10. That will be involved in the formation of parasympathetic nervous system. And I hope people will have learned biochemistry. In biochemistry, vitamin K dependent clotting factors. The vitamin K dependent clotting factors will be 2, 7, 9, 10. And here we are actually having 5, 7, 9, 10. So remember parasympathetic nervous system, 3, 7, 9, 10 cranial nerves, vitamin K dependent clotting factors, 2, 7, 9, 10. And then in embryology here, pharyngeal arch nerve supply will be 5, 7, 9, 10. Okay, that is the best way to remember. Now, once you learn these nerves, what is the use of this one? So remember, for example, the first arch is supplied by 5-3, that is mandibular nerve. Mandibular nerve is supplying to whichever muscles. Mandibular nerve is supplying to whichever muscles. All those muscles are derived from first arch. Now you just try to recall the rapid revision session that we have done for head and neck topic. In head and neck topic, during the rapid revision itself, I told you very, very clearly about the mandibular nerve. Mandibular nerve is the one which will be supplying to all the muscles of mastication. So therefore, muscles of mastication will be derived from which arch? First arch. Mandibular nerve, the trunk itself is supplying to two tensors, tensor veli palatini and tensor tympani. Both of them are supplied by mandibular nerve, therefore derived from first arch. Then mandibular nerve is the one which is also supplying to anterior belly of digastric along with mylohyoid. We learned about this one in Ali branches, ALI. In that I told you I, inferior alveolar nerve, it is giving a branch which will be going and supplying to mylohyoid as well as the anterior belly of digastric. It's so simple, so simple. Try to understand the trick here. So it's all about the nerve. Similarly, the arch number 2 will be supplied by which nerve here? Facial nerve. Facial nerve is supplying to whichever muscles, all those muscles will be derived from second arch. I told you again in detail in the head and neck topic about the facial nerve also. Now facial nerve will be supplying to all the muscles of facial expression here. So muscles of facial expression are derived from second arch. Apart from that, I told you facial nerve will also supply to one of the muscle in the middle ear, that is stapedius muscle, derived from second arch. Then the posterior belly of digastric along with the stylohyoid will also be derived from the second arch. That is a way how you actually learn about all the muscles derived from the pharyngeal arches. Similarly, third arch will be supplied by glossopharyngeal nerve, 5, 7, 9, 10. The third arch is supplied by ninth nerve. And ninth nerve, glossopharyngeal nerve, will be supplying to only and only one muscle, that is stylopharyngeus muscle. Stylopharyngeus muscle. Okay. And after that, the fourth and sixth arch will be supplied by recurrent laryngeal, superior laryngeal nerve, which is a branch of vagus only. And vagus nerve will be supplying to which muscles? All the muscles of your larynx, pharynx, and palate. Larynx, pharynx, and palate, all this will be derived from fourth and sixth arch. I hope it is crystal clear now. So in this manner, we are done with the derivatives of ectodermal cleft, endodermal pouches, and the mesodermal arches. Pharyngeal arches are also done. We are done with the bones, the ligaments, as well as the muscles derived from the pharyngeal arches here. Okay. Now after completing all this here, let us go ahead with nowadays the hot favorite topic, that is development of face. Along with the development of the face, we are also going to learn about the cleft lip. You know, upper lip and the lower lip. Many a times they are asking the questions from here. I'll just give you one simple trick here, one simple diagram. Everything else will become easy. In fact, you can answer this one without even, simply, mugging up like that. First, you try to understand that our entire face will be derived from where? Remember, our entire face will be derived from only two sources. Number one, this one here will be the mandibular process. This is mandibular process. And this one here will be the frontonasal process. Please look at me here right now. This one here, this much part of the face will be formed from mandibular process. And remember, mandibular process itself is going to form the maxillary process and the maxillary process. This mandibular process itself is going to form the maxillary and the maxillary process here, sir. Then, if this much face is already formed here, the mandibular process itself is going to form maxillary and maxillary. Then what is remaining right now? We are remaining with the frontal and the nasal part, frontonasal process. And after forming this one, join them together. That's all. Your face is ready. Okay. So our face will be actually derived from only two sources, mandibular process and the frontonasal process. Okay. And because it is like frontonasal process here, of course, it will be having the nasal pit here, the nasal pit here, and this nasal pit on either side, it will be having medial nasal process and the lateral nasal process. Let me show you all these names in this diagram here. So in this diagram, you're able to see below here, there is mandibular process. And that mandibular process itself is giving rise to maxillary process here, sir. And above here, this is the frontonasal process, which will be actually having those nasal pits with medial nasal process and the lateral nasal process. Okay. So now let me show you all these conditions here and what is the problem happening here, sir. Condition number 1. Please look at this condition here, sir. Condition number 1. Okay, now we are going to start in this direction now. Now in this diagram, you are clearly able to see here, it is midline, cleft, lower lip. It is midline, cleft, lower lip. Everything is there in the name itself. See, normally, how is this lower lip forming, sir? How is the lower lip normally forming? Normally, the lower lip is formed by fusion of mandibular process. Fusion of mandibular process here. If this mandibular process fails to fuse in the middle, midline, cleft, lower lip. That's all. So the question in the exam will be, in the given image, what is the defect? It is due to non-fusion of mandibular process. Simple. Now learn, normally how is this upper lip will be formed, sir? Upper lip will be normally formed by the fusion of maxillary process with the medial nasal process. Be careful, not the lateral. You can clearly see in this diagram here, the maxillary process fuses with the medial nasal process here. The maxillary process is going to fuse with the medial nasal process here. That's how your upper lip will be actually formed there. And then in the upper lip, one more thing here is that in the middle, you'll be actually having philtrum. Now this philtrum here will be formed by the fusion of medial nasal process on both the sides. So medial nasal process, both the sides will fuse here. Perfect. Now the condition number 1 here is midline, cleft, upper lip. Please look at this diagram here now. Midline, cleft, upper lip. How is this midline cleft formed here? Yes, due to the non-fusion of medial nasal process. Medial nasal process is not fusing here. Only the medial nasal process and the medial nasal process will not be fused here. Midline. Now in this diagram, you're actually able to see the unilateral cleft upper lip, sir. This is unilateral cleft upper lip on one side only. So therefore, it is due to the non-fusion of maxillary process with the medial nasal process, sir. Maxillary process with the medial nasal process. Okay. Now in this diagram, you're able to see the bilateral cleft upper lip. Bilateral cleft is there. Then non-fusion of both the maxillary process with both the medial nasal process. With both the maxillary nasal process with the maxillary process with both the medial nasal process. Okay. Now in this diagram, the last and final one, you are able to see the oblique cleft in the face. So not only the unilateral cleft lip over here, along with that, it is also extending further. And that is nothing but oblique facial cleft. And that will occur due to the non-fusion of lateral nasal process. Here, the lateral nasal process is also not fused, leading to oblique facial cleft there. I hope all the points are very clear in this one. So the only thing is, keep on playing with this diagram, you'll get everything here. Let us just summarize all the things over here now. Number 1, if there is a non-fusion of mandibular process, if the mandibular process will not fuse, midline, cleft, lower lip. If there is a non-fusion of medial nasal process, midline, cleft, upper lip. Perfect. Non-fusion of maxillary with the medial nasal process, unilateral cleft upper lip. Non-fusion of both the maxillary with both the medial nasal process, bilateral cleft upper lip. That is also known as the hare's lip. I hope you know the hare, rabbits. In the rabbits also there will be like bilateral cleft will be there. And then the last and final one will be the oblique facial cleft, where even the lateral nasal process is also not fused there. Perfectly done. So by this we are done with all the defects only with one diagram here, sir. Done and done. Now after completing this head and neck embryology, now let us go ahead with the cardiovascular system embryology, CVS embryology, where you can always expect one question in your exam definitely, sir. Okay. Now in this diagram we are able to see the developing embryo here. In the cardiovascular system embryology, we can actually divide that into 3 parts. Here you can appreciate the developing heart here. And then we have to even learn about the development of the venous system. And we have got to learn about the development of arterial system. Now, my dear doctors, out of all this, remember the development of arterial system is very much important here. We are going to discuss about the development of arterial system in detail here. Okay. So let's see this one by one, because every point is an important question here, sir. Now starting with the first thing, in this diagram, are you all able to appreciate that there is an aorta here? And this aorta here will be the dorsal aorta. What is the name of this aorta? That is your dorsal aorta. Now this dorsal aorta is actually communicating with aortic sac. Aortic sac is present ventrally and this dorsal aorta is actually present behind. And these two are joined together with the help of arch arteries. Now let me show you exactly how it is arranged here on my body here, sir. So for example, you just imagine myself to be an embryo here. Now, remember that in this diagram, you're able to see only one dorsal aorta. Why? Because you are looking at the embryo from a side view. But if you look at the embryo from the front, there will be one right dorsal aorta and there will be another left dorsal aorta. There will be actually two dorsal aorta, right and left. Then in the front, ventrally here, there will be aortic sac. Aortic sac hota hai. And just now we have learned head and neck embryology. How many arches do you have initially? 6 arches. And in those arches, I told you just now about the nerve supply. 5, 7, 9, 10. Apart from the nerve supply, it also has the blood supply, right? Yes. So therefore, those arteries are actually known as the arch arteries. Now let us join all of them together. Ventrally, there will be aortic sac. Dorsally, there will be right dorsal aorta and the left dorsal aorta. And they are joined from on one side by 6 arch arteries and on the other side by 6 arch arteries here. Completely like this here. Now that diagram is something like this here. I hope you have seen this diagram many times in your textbooks, embryology textbooks and all. Now this one here will be the aortic sac in the front having 2 horns, a right horn and the left horn. And then this one here will be the dorsal aorta. There will be a right dorsal aorta and the left dorsal aorta. And they are joined by the 6 arch arteries on either side. Now this entire thing is going to form your entire arterial system. It is going to form the entire arterial system, sir. But the problem is that if you are going to learn with this diagram here, we'll not be able to understand the things clearly. So let us make our simple diagram here, sir. So it is the same diagram, but I'm just drawing here in dotted lines here. This one here will be the right dorsal aorta. And this one here will be the left dorsal aorta. Perfect. This here will be the aortic sac with the 2 horns, the right and left horn. And yes, of course, in the middle, you'll be having your arch arteries. There are totally 6 arch arteries on either side. Now we are going to see how this entire arch arteries are going to form your entire arterial system, sir. I'll tell you slowly one by one. Okay. So first, let us start with the largest one. That is your arch of aorta here. So remember, arch of aorta will be actually derived from here, sir. That is your left horn of aortic sac. Then the left 4th arch artery here. And the left dorsal aorta here. So all this together, they are going to form your arch of aorta. So arch of aorta will be derived from left horn of the aortic sac. Okay. Left horn of the aortic sac. And then the left 4th arch artery and the left dorsal aorta. All of them together, they are going to form your arch of aorta. Perfectly correct. That is the reason why I'm telling you here. Look at this table on the screen here. In this table, it's really difficult to memorize all these things here. So the best diagram to learn this is this diagram here, sir. So we can easily learn here that arch of aorta is derived from left horn of aortic sac, left 4th arch artery and left dorsal aorta. Already the left 4th arch artery has been asked in your exam. Now we all know that arch of aorta will give how many branches? It will be giving like 3 branches. Brachiocephalic trunk here on the right side, and then left common carotid artery and left subclavian artery to the left upper limb. Now brachiocephalic trunk should be derived from where? It is derived from the right horn of aortic sac. So brachiocephalic trunk will be derived from the right horn of aortic sac. It is going to form brachiocephalic trunk. Then after that, the next one here will be the common carotid artery. That is the left common carotid artery. Now many times the students are learning that common carotid artery will bifurcate into internal external carotid artery. Absolutely wrong. Common carotid artery, it's not dividing into 2 arteries there, sir. Common carotid artery will ascend up, give a branch external carotid artery, and itself will continue as your internal carotid artery. Okay. So imagine here, this is your left common carotid artery. It's giving rise to a bud-like structure here, which is going to form external carotid artery. And then this will further continue as your internal carotid artery here. So this one here will be the common carotid artery. This is external carotid artery and this is internal carotid artery. Now just by looking at this diagram, you yourself can answer me here. Okay, common carotid artery will be derived from where? 3rd arch artery. Is it the complete 3rd arch artery? No, only the proximal part. Proximal part of the 3rd arch artery. This one. Internal carotid artery is formed from distal part of the third arch artery as well as dorsal aorta. Let's cross check here. Common carotid artery is derived from proximal part of third arch artery. Perfectly right. Internal carotid artery is derived from distal part of the third arch artery as well as the upper part of the dorsal aorta, cervical part of the dorsal aorta. Perfectly correct. Now, we don't have to write down here like right or left because it is absolutely the same on the right side also. So brachiocephalic trunk will give rise to common carotid artery, which is giving a bud to form external carotid artery, and that itself will continue here to form your internal carotid artery. It's the same on both the sides. No need to draw it separately. Perfect. Now welcome to the most confusing thing in the development of arterial system. And that question has been like repeatedly asked in your exams many a times, along with the defect also. That is about the development of subclavian artery. Actually, what happens here is that this dorsal aorta will also have like many arteries on this side here. And those arteries are known as the intersegmental arteries. Actually, in this diagram, I did not draw those segmental arteries. Why? Because our diagram will become like very much cluttered here. Okay. So there will be intersegmental arteries. And I told you that there will be like many of them. And we are actually learning in which region here? Cervical region. So the complete name will be the cervical intersegmental artery. And because there are many of them, somewhere here will be the 7th cervical intersegmental artery. I repeat the name, 7th cervical intersegmental artery. And this is on which side here? Left side. Obviously, the complete name will be the left 7th cervical intersegmental artery. Left 7th cervical intersegmental artery. And you can very clearly see that it is a branch coming from your arch of aorta, and it has to be definitely the left subclavian artery. Okay. So left subclavian artery is derived from where? The left subclavian artery is derived from left 7th cervical intersegmental artery. So please look here. The left subclavian artery is derived from left 7th cervical intersegmental artery. Perfectly correct. Now what about the right subclavian artery? Right subclavian artery is a branch of brachiocephalic trunk. So therefore it should actually begin from here. So this brachiocephalic trunk will give rise to right subclavian artery from here, then even from this part as well as from here. Now let us just write down few numbers here. This is number 1 here. What is this? Right 4th arch artery. And this is number 2 here. That is right dorsal aorta. And this is number 3 here. And that one will be the right 7th cervical intersegmental artery. I hope now you are understanding why this is repeatedly asked in your exam. Why? Because development of the right subclavian artery and left subclavian artery is different. It's not the same. Okay. So right subclavian artery will be derived from where? Right 4th arch artery, right dorsal aorta, as well as the right 7th cervical intersegmental artery. It is the one which is going to form your right subclavian artery. I hope it is very clear now. Now after that, my dear friends, what is going to happen here? Please look into this diagram here. After the formation of this arch of aorta and all, how is the descending aorta forming here? You can clearly see in this diagram, this dorsal aorta here and this dorsal aorta here, both of them will be fused together. Okay. So the left dorsal aorta is actually going to form arch of aorta. It is going to descend down and combines with the right one, and together it is going to form your descending aorta. So left dorsal aorta along with the fused dorsal aorta, together it is going to form the descending aorta. Perfectly correct. Now, meanwhile, when all this development is taking place, at the same time, I told you the orientation, right? Aortic sac, arch, arteries, dorsal aorta. At the same time, even lungs are also going to form here. So if the lung is forming here, for example, the right lung here and the left lung here, lungs will be supplied by pulmonary arteries. Right pulmonary artery and the left pulmonary artery will be derived from here. And now you are completely well aware about how to learn this topic. Pulmonary arteries are derived from 6th arch artery. Are they derived from the entire 6th arch artery? No, only the proximal part of the 6th arch artery. So proximal part of the 6th arch artery is going to form pulmonary arteries. Now, recently asked in the FMG exam as well as the PG exams also, ductus arteriosus. Ductus arteriosus will be derived from where? Just try to recall in your mind, ductus arteriosus is between which parts, sir? It is between the pulmonary artery and the arch of aorta. So now you apply the common sense and tell me, can it be present towards the right side? Ductus arteriosus, can it be present towards the right? Absolutely no. Ductus arteriosus is between the pulmonary artery and arch of aorta. Arch of aorta is towards the left side. So definitely this should be present towards the left side, between the pulmonary artery and arch of aorta here. So this is the one which is going to form your ductus arteriosus. So please look at the diagram and try to understand. Ductus arteriosus will be derived from where? Distal part of left sixth arch artery. Distal part of the left sixth arch artery. Okay, it is the one which is going to form your ductus arteriosus. And later on, after development, what is going to happen? Ductus arteriosus will be completely closed, and that obliterated ductus arteriosus is the one which is going to become ligamentum arteriosum. It is going to form ligamentum arteriosum. So in this manner, the entire table becomes easy with the help of this diagram here, sir. Otherwise, there is no way that you can simply mug up that one. So right, left, third, fourth, and all, you'll go mad. So the best thing is learning with the help of this diagram here, sir. Okay. Now, after learning the formation of all these arch arteries, what they're going to form, you might be wondering, sir, what about the first one and the second one and the fifth one? Why did you leave that? Remember, nothing will be derived from the fifth arch artery. Why? Because I told you very, very clearly that the fifth arch will completely degenerate. The fifth arch will completely degenerate. So nothing will be derived from the fifth arch artery. Okay, leave it. Then what about the first and second one? The first arch artery, remember, it is not going to form any artery, sir, but there is a remnant of that one. And what is the remnant of the first arch artery? It is maxillary artery. Oh my God. I hope you all remember in head and neck topic, maxillary artery is the largest branch of external carotid artery, and that itself in turn is giving rise to 16 branches. Even though it is such a big artery, remember it is not a derivative, it is just a remnant, and it is the remnant of first arch artery. Similarly, what is the remnant of second arch artery? Second arch artery is going to form stapedial artery, and the hyoid artery, sir. Stapedial artery and hyoid artery, it is the remnant of second arch artery. That's all. By this, all the arch arteries are actually completed here, sir. Okay. Now let us see the defects here. So one by one, once completing the normal development, after completing, let's see the defect right now. Now what about the abnormal right subclavian artery? How is abnormal right subclavian artery forming here? Just now I told you that right subclavian artery is derived from three sources. Right fourth arch artery, and then even the right dorsal aorta, and then the right seventh cervical intersegmental artery. That is going to form a right subclavian artery. Now sometimes what is going to happen, the fourth arch artery will obliterate. It is gone. And even the caudal part of the right dorsal aorta will persist. It will remain. Normally it should not remain. Normally it should be gone. Why? Because only the fused part is remaining here. But the caudal part will remain here, whereas right fourth arch artery will obliterate. And that will result in the formation of abnormal right subclavian artery. I hope now it makes sense. You don't have to actually separately learn this one. The obliteration of the right fourth arch artery and persistence of the caudal part of the right dorsal aorta will lead to abnormal right subclavian artery. Now, when you have this abnormal right subclavian artery, it's actually going behind the trachea and esophagus in this manner. And this condition is known as dysphagia lusoria. So dysphagia lusoria, why? Because dysphagia, difficulty swallowing. Dysphagia lusoria is due to abnormal right subclavian artery. And why is this right subclavian artery becoming abnormal here, sir? Obliteration of the right fourth arch artery and then persistence of caudal part of the right dorsal aorta. Now please look at this diagram here. In this diagram, already what is happening, sir? We have already learned about the formation of arch of aorta here from the left fourth arch artery. And then descending aorta is formed from here, sir, left dorsal aorta as well as the fused part. Normally in the normal individual, this caudal part should not be there. But if that caudal part persists, if that is persisting here, then you can clearly see there is a formation of like double arch of aorta. So this condition here, you are able to see that there is a double arch of aorta over here, sir. Next one. This is exactly the same diagram which we have actually drawn in a simplified format. The first arch artery remnant will be maxillary artery. Second arch artery remnant will be the stapedial artery and hyoid artery. Third arch artery is the one which is going to form the common carotid, external and internal carotid. Fourth arch artery on left side, it is going to form arch of aorta. On the right side, it is going to form the right subclavian artery. Fifth arch artery is not going to form anything. It will completely degenerate. Sixth arch artery is going to form the right and left pulmonary artery. And on the left side, the distal part is going to form ductus arteriosus. Perfectly correct. This is what we have just learned right now. Now, after learning this one here, let me tell you about the recurrent laryngeal nerve. This is another interesting question which is asked recently in the exam. There will be a right recurrent laryngeal nerve and the left one. And we know very well the left recurrent laryngeal nerve will be longer. Why? The left recurrent laryngeal nerve has a longer course than the right recurrent laryngeal nerve. Why? Why? Because the left recurrent laryngeal nerve, you can clearly see it's a branch of vagus and it is going to take a turn around this sixth arch artery. And left side sixth arch artery is going to form ductus arteriosus. Therefore, it cannot move above that one. But on the right side, the distal part is gone completely. And even the fifth arch artery is also gone completely. So on the right side, this recurrent laryngeal nerve is going to come up, and then it is going to wind around or turn around the right subclavian artery. That is the reason why the left recurrent laryngeal nerve is longer when compared to the right one. Why? Because it is going to take a turn around the left sixth arch artery. It turns around the left sixth arch artery. Therefore, after birth, in your body and my body right now, the left recurrent laryngeal nerve is taking a turn around the arch of aorta, whereas the right recurrent laryngeal nerve is taking a turn around the right subclavian artery. Right subclavian artery, sir. Clear? So in this manner, if you learn embryology properly, right, these type of questions you can easily solve in the exam, sir. So exactly the same thing as I told you here. Left recurrent laryngeal nerve is longer. Why? Because it is going to wind around the arch of aorta. If you see embryologically, it is winding around the sixth arch artery. That is why it is longer, sir. Perfect. Now, after learning about the development of arterial system, now let us learn about the development of venous system, sir. Now let us see the venous system. Now during development, you are having three sets of veins. Number one, the vein which is going to collect the blood from the entire body of the embryo. You will be having your cardinal vein, anterior cardinal vein, and then there will be the posterior cardinal vein, and both of them will combine together. Together they are going to form the common cardinal vein. And the vein which is going to collect the blood from yolk sac, this one here will be the vitelline vein. Vitelline vein is going to collect the blood from yolk sac. Similarly, the vein which is going to bring the blood from the mother to the fetus, that one will be your umbilical vein here. So during development, there are like three sets of veins. Cardinal vein, umbilical vein, and the vitelline vein. Okay. Out of these three of them, umbilical vein everyone knows very well. Before birth, you'll be having two umbilical veins. There will be a right umbilical vein and then you'll be having the left umbilical vein. Out of these two umbilical veins, which one will regress? Remember, the right umbilical vein will completely regress and only the left umbilical vein is left. Okay. So the best way to remember is right regress, left is left. Right umbilical vein will completely regress, whereas left is left. That is the reason why, remember, only the left umbilical vein is going to carry oxygenated blood from the mother to the developing fetus. Fine. That is all happening throughout the entire term of pregnancy and all. Now at the time of delivery, we doctors are going to cut the umbilical cord. And once you cut the umbilical cord, now there is no connection between the mother and the baby. Then what is going to happen to left umbilical vein after birth? So after birth, the left umbilical vein will obliterate, it will be closed, and it is going to remain in our body in the form of a ligament. And that is known as ligamentum teres. So ligamentum teres is actually representing the remnant of or obliterated left umbilical vein, sir. That is all about the story regarding the umbilical vein. Okay. So let us repeat this once more here. It is worth repeating. Many a times a question has been asked from here. Okay. So before birth, you're actually having two umbilical vein. One is the right umbilical vein, another one is the left umbilical vein. But out of these two, right umbilical vein will completely regress. Completely regress. Only left is left. It is going to carry oxygenated blood from mother to the fetus. But after birth, what is going to happen? The left umbilical vein, there is no use of that. That will be completely obliterated and it is remaining as a ligament in your body and my body. And that ligament will be the ligamentum teres. Therefore, they'll be asking the question in the exam vice versa. Ligamentum teres is representing what? It is obliterated left umbilical vein. Obliterated left umbilical vein, sir. Done. Vitelline vein is the one which is going to collect the blood from yolk sac. Yolk sac is going to become the future gut. And who is going to collect the blood from the gut? From the gut, the blood is collected by portal vein. So remember, portal vein should be normally derived from where, sir? From the vitelline vein. So vitelline vein is the one which is going to form your portal vein, sir. So it is going to form the portal vein as well as the right and left branches of the portal vein, as well as that portal vein is actually going to drain the blood into the sinusoids, even the sinusoids inside the liver, and then the central vein, and from there the hepatic vein. All of them will be actually derived from the vitelline vein only. So that entire portal, portal vein, right and left branch of that one, the sinusoids, all those will be derived from the vitelline vein. Now, once you are done with the umbilical vein and the vitelline vein, now let us learn about the cardinal veins in detail right now, sir. Now, in this diagram, you are able to see that there is one anterior cardinal vein here and then the posterior cardinal vein here, sir. But don't think that in this diagram, you're able to see one and one, there is only one. No, there'll be actually two of them. One on the right side, another one on the left side. Then again, the same thing with the posterior one also, the right and the left. So there will be right and left anterior cardinal vein, and there will be right and left posterior cardinal veins. And they will combine to form the common cardinal vein. Now this diagram of the embryo we are actually seeing from the side view. Now let us look at the embryo from the front and try to understand how it is going to form the superior vena cava and the inferior vena cava. Okay, let's go ahead now. So first let us see the formation of superior vena cava here. So this is what I was actually speaking you about. Don't think that we have only one cardinal vein. We're actually having two of them on the right as well as on the left side. So in this diagram, you can appreciate that there is a right anterior cardinal vein and then there will be the left anterior cardinal vein. Similarly, you have the right posterior cardinal vein and the left posterior cardinal vein. And both of them will combine to form the right common cardinal vein and the left common cardinal vein. And finally, these cardinal veins are going to drain into sinus venosus. Sinus venosus. Now, the moment you look at this diagram here, you yourself can easily tell me, okay, superior vena cava should be definitely derived from where? Should be derived from the anterior cardinal vein. Okay, whereas the inferior vena cava should be obviously derived from the posterior cardinal vein. But of course, it is not that easy. I will tell you step by step. First, let us learn about the superior vena cava formation. Now, let me just draw a simple diagram here. For example, if this one here will be the right anterior cardinal vein and this one here will be the left anterior cardinal vein. I'm not drawing the posterior one here, sir. So this is the right anterior cardinal vein and this one here will be the left anterior cardinal vein. Right. From our diagram, we at least understood this much. Of course, superior vena cava should be derived from here. But right now, can you please tell me, superior vena cava, is it present exactly in the middle of the body? No. Superior vena cava is little towards the right side. Okay, fine. So from here we understand that, okay, from the right side the blood is being collected. Now what about the left side, the left anterior cardinal vein? Even that blood has to come into superior vena cava, right? So therefore we are now going to connect these two. That is the reason why there is a formation of oblique vein here. So this one here will be the oblique vein. Okay. Now it makes sense, okay, from the right side as well as from the left side, the blood is coming into the superior vena cava. So now, my dear doctors, superior vena cava will be derived from where? Remember, the superior vena cava is derived from, I'm writing the number 1 here and number 2 here, sir. Now it is derived from 1 and this 2 here. What is that 1 here? It is the right common cardinal vein. It is the right common cardinal vein. And what is it 2 here? It is the right anterior cardinal vein. So these two together, it is going to form your superior vena cava. Okay. So this one here will be the right common cardinal vein, and this one here is the right anterior cardinal vein. These two together, they're actually going to form your superior vena cava. Now superior vena cava is formed by right brachiocephalic and the left brachiocephalic. Wow, it makes sense. Therefore, this right anterior cardinal vein, this one should form your right brachiocephalic vein. And this part here will actually should be gone, because already the blood from the left side has been going towards the right side. So this part should be actually diminished. It should be gone. See, embryology is all about what is forming, what is getting degenerated, and then what is remaining. And whatever is remaining is you and me right now. Understanding? So this part has to actually degenerate there. It's gone. So whatever is left out here, left anterior cardinal vein and this oblique vein, these two together are going to form your left brachiocephalic vein. Perfectly done. This is the easiest way of learning the development of the superior vena cava and even the brachiocephalic veins also. Okay. So superior vena cava and the brachiocephalic vein development has been completed. Now in one of the recent exams in the PG, they have given this diagram here, sir. So already we have learned the normal development of superior vena cava as well as the right and left brachiocephalic vein completed. Fine. But in the exam, they have given this diagram. In this diagram, we are actually able to see the right superior vena cava here. No problem with that one. Now we are also able to see the left one. So the right and left superior vena cava we are able to see there. This diagram represents you the double superior vena cava. Double superior vena cava. Now, before I tell you the reason, can you people decide why is this happening? Why do we have like double superior vena cava? So, double superior vena cava is due to the persistence of left anterior cardinal vein. If this part is going to persist, it is going to remain. And no formation of oblique vein. So, we will be having double superior vena cava if there is a persistence of left anterior cardinal vein and absence of oblique vein. Persistence of left anterior cardinal vein and absence of oblique vein. If this happens, then it will be leading to the formation of double superior vena cava. So that was the answer in the exam for this one. Now once we are done with this one here, let us go ahead with the development of inferior vena cava. So now after learning the development of superior vena cava, now let us see the development of inferior vena cava. Now don't panic by looking at this diagram. I'll tell you slowly one by one. Now in this diagram, you can clearly see here, this one will be the posterior cardinal vein. So the right posterior cardinal vein and this one is the left posterior cardinal vein. Now what is going to happen is this posterior cardinal vein, further anastomosis will be formed, sir. Further veins are going to form. Now in this one here will be the subcardinal vein. So this one here will be the subcardinal vein, the right and left of course. And this one here will be the supracardinal vein. Supracardinal vein. And the same thing can be seen on the other side also. So on the other side also you'll be having the right and left one. Okay. Now whatever I have written here, the small part here, this is the hepatocardiac channel. The right hepatocardiac channel. From the name itself, you are able to understand it is a connection between the hepatocardiac, between the heart and the liver. Hepatocardiac channel. Now, development of inferior vena cava will not be a very simple one, sir. It is like the epitome of the entire embryology. Inferior vena cava is derived from totally 6 structures. Totally 6 structures, sir. Okay. Now what is going to happen between this supracardinal vein and subcardinal vein, there is a formation of anastomosis. Similarly, between the subcardinal and hepatocardiac channel, again there is a formation of anastomosis here. Now our inferior vena cava will be derived from number 1, right posterior cardinal vein. Number 2, it is derived from the right supracardinal vein. Number 3, this anastomosis between supra and subcardinal vein. Number 4, it is derived from the right subcardinal vein. Number 5, again there will be anastomosis And number 6, the hepatocardiac channel. So let me just highlight this part here right now. So remember, inferior vena cava will be derived from right posterior cardinal vein, right supracardinal vein, and then the anastomosis here, and then the right subcardinal vein, and then again the anastomosis here, and then finally the hepatocardiac channel. Whatever I have highlighted, that is the one which is going to form your inferior vena cava. Okay, so inferior vena cava is derived from all these structures. So in the very beginning, we just told simply that superior vena cava is coming from anterior cardinal vein and inferior vena cava is coming from posterior cardinal vein. This is how it is actually formed here. So, okay. Now, after completing the entire cardiovascular system embryology, all the difficult parts has been made easy for you people. Now let us go ahead with the gut embryology. Okay, let us see the gut embryology right now. Now, for example, if this one is your embryo after the craniocaudal fold, now this is the body wall of the embryo here, and then this one here will be the yolk sac. Now this body wall will be actually derived from ectoderm. Then endoderm is the one which is going to form your entire gut, the foregut and the midgut, and finally the hindgut. So this is the entire gut here, and gut will be derived from endoderm. So this one here is the foregut, then the midgut and the hindgut. Midgut will be forming an extension here. This extension is known as vitello-intestinal duct. And hindgut is going to form an extension here that is known as allantois. Okay, the midgut is going to form an extension known as vitello-intestinal duct, whereas hindgut is going to form one more extension here that is allantois. Now, normally what should happen, the vitello-intestinal duct should completely be closed, obliterated. But suppose if that vitello-intestinal duct proximal part is going to remain, persistence of proximal part of the vitello-intestinal duct, then what is going to happen? It will lead to the formation of Meckel's diverticulum. And in some individuals, unfortunately what will happen, the vitello-intestinal duct itself will completely persist. Then you will observe that the meconium actually will be present here in the gut. Instead of going out, it will be actually coming out from the vitello-intestinal duct here. And you will be able to see the meconium around the umbilicus. And that condition is due to persistence of vitello-intestinal duct, sir. Already given recently in the exam. So I repeat again, only if the proximal part of the vitello-intestinal duct is persisting, then it is Meckel's diverticulum. And if the entire vitello-intestinal duct persists, then you can see meconium coming out of the umbilicus. And that condition is due to what? Persistence of vitello-intestinal duct. Which duct? Vitello-intestinal duct. So after this, let me tell you something important about the hindgut, which is given recently here. Now this one here will be the hindgut. Hindgut will give an extension known as allantois here, and this part here will be known as the cloaca. That part is known as cloaca. Now I told you the body wall is actually derived from where? Ectoderm. Gut is derived from where? Endoderm. And in the middle, what is going to happen right now? You'll be having mesoderm. Now this mesoderm is going to extend further, and after extending further, it is going to separate the hindgut from the allantois. So let me draw only that last one apart. So you imagine this one here is like hindgut here. We know that hindgut is going to form your rectum and anal canal. Okay, further. Now allantois is the one which is going to form urogenital sinus. Urogenital sinus. And these two are separated because of the mesoderm present in the middle here. So I repeat again, it is worth repeating, sir. The mesoderm in the middle is going to further, separate the hindgut from the allantois. So hindgut is the one which is going to become your rectum, anal canal and all. Allantois is the one which is going to form urogenital sinus. Now the cranial part of this urogenital sinus, this part is known as the urachus. Now you have seen the sagittal section of the male pelvis and female pelvis many a times. In the pelvic region, what should happen normally? In front of the rectum, right in front of the rectum, what do you have there? Urinary bladder. The urogenital sinus should definitely develop into what? Urinary bladder. Urogenital sinus should be forming what? Urinary bladder. Then what is going to happen at the apex of this urinary bladder? The urachus will be actually closed, sir. The urachus will be obliterated. And this obliterated urachus, it is the one which is going to form median umbilical ligament. Be careful with the spelling there. It is not medial, it is median umbilical ligament. So in the normal people like you and me, for example, if this is the urinary bladder here, this urinary bladder will be derived from urogenital sinus, and near the apex of this one there will be a ligament, and that is nothing but the median umbilical ligament that will go and join with the umbilicus. So that is actually derived from where? It is nothing but after the closure of the urachus. So please look at this diagram here. This diagram explains everything there. So urinary bladder will be derived from where? It is derived from urogenital sinus. Okay, it is the one which is going to form urinary bladder. Then urachus ka kya hoga? What will happen to the urachus? It will be completely closed, and that is going to form the median umbilical ligament. Now in some individual, unfortunately, urachus will not be closed. If urachus is not closed, whatever urine will be there in the urinary bladder, now this urine in the urinary bladder will start coming out from the umbilicus. The urine will start coming out, dribbling out from the umbilicus. That condition is known as weeping umbilicus. And weeping umbilicus is due to what? It is due to persistence of urachus. Urachus is persisting, it is not closing. Understanding? So please try to remember these two conditions right now. If you are able to see urine coming out of the umbilicus, that condition is due to persistence of urachus. And if you see meconium coming out of the umbilicus, that condition is due to persistence of vitellointestinal duct. I hope these two concepts are very, very clear. Now let me tell you one more thing here itself, sir. Urinary bladder entirely will be derived from where? Urogenital sinus. But except what here? Trigone. Except the trigone of the urinary bladder. Only one point you have to remember here. And this trigone will be obviously derived from the mesonephric duct, the Wolffian duct. So this was a direct question asked in the exam, in FMG exam also. Okay. So the entire urinary bladder will be derived from urogenital sinus except the trigone, and the trigone will be derived from the absorbed part of the mesonephric duct. Absorbed part of the mesonephric duct, sir. I hope this concept is very clear now. Now after clearing these concepts here, let us go ahead with the foregut right now, sir. In the foregut, you are able to see here, there will be esophagus, followed by the stomach here, and then followed by the duodenum. Up to second part of duodenum, you'll be having a foregut. Right in front of the foregut, there will be a double layer of peritoneum known as mesentery. So this will be your ventral mesentery here, and behind you'll be having the dorsal mesentery here, sir. Mesentery is just the double layer of peritoneum which is going to connect the parietal peritoneum with the visceral peritoneum. Okay. So now we need to learn what are the structures which are derived from the ventral mesentery, and then what are derived from the dorsal mesentery. And mesentery is actually a general term, sir. Whichever organ it is holding, according to that organ the name changes, and because it is holding the stomach over here, it is known as mesogastrium. Okay, so whatever it is, mesentery is nothing but double layer of peritoneum here. Now first thing, what is developing in the ventral mesentery here, yes, you are able to see the liver develops in ventral mesentery. Listen to my English very carefully here. I am not telling from ventral mesentery. No. Liver is developing in ventral mesentery. Liver is actually formed from the foregut. There is a hepatic bud forming from the foregut. So liver is not developing from the ventral mesentery. Remember, liver develops in ventral mesentery. Now, once the liver is forming here, what is the ligament right in front of the liver? This ligament here will be the falciform ligament. What do you have behind the liver? This will be the lesser omentum between the liver and the stomach, and between the liver and the duodenum. First part of the duodenum, that is your lesser omentum. And this liver is actually covered by these ligaments also here, that is your triangular ligament as well as the coronary ligament. All this will be derived from the ventral mesentery. Now what will be the derivatives from the dorsal mesentery? Remember, even spleen is also derived from dorsal mesentery. If spleen is derived from the dorsal mesentery, what is the ligament between the stomach and the spleen here? This ligament here will be the gastrosplenic ligament. And this ligament between the stomach and the diaphragm here, this one will be the gastrophrenic ligament. And then after that, the greater curvature of the stomach will be attached to omentum, and this omentum here will be the greater omentum. Then if you see dorsal part of the spleen here, behind the spleen, you'll be able to appreciate the splenorenal ligament. Splenorenal ligament or lenorenal ligament. All this will be actually derived from the dorsal mesentery. So in one simple diagram, you can remember all these structures here, sir. So the structures which are derived from the ventral mesentery as well as dorsal mesentery. So remember, liver develops in ventral mesentery, whereas the spleen is developing from the dorsal mesentery. Now, if you compare this diagram with our body right now, from last 5 minutes, I'm telling you that liver develops in ventral mesentery. Do we have our liver in the front here? No. Do we have our spleen behind here? No. Then what is going to happen? It is going to rotate. And this is your foregut, and foregut is going to rotate 90 degrees in clockwise direction. And it is going to rotate in such a way that the liver in the front will be coming towards the right and the spleen will be going towards the left, sir. Okay. That means foregut is going to rotate 90 degrees in clockwise direction. Foregut will rotate 90 degrees in clockwise direction. Okay. Whereas midgut will be rotating 270 degrees in anti-clockwise direction. In anti-clockwise direction, sir. And hindgut will not rotate, sir. Okay. So after telling you about this ventral mesentery and dorsal mesentery, hope you are able to easily understand here. Okay, liver is not developing in the front here. There should be something happening here. So what is happening here? The foregut is going to rotate 90 degrees in clockwise direction. Whereas midgut is going to rotate 270 degrees in anti-clockwise direction. But now try to understand here. Midgut will include the remaining duodenum, jejunum, ileum, and then the cecum, and then ascending colon and transverse colon. Up to the right 2/3 of the transverse colon. Now this entire midgut with that long coils of jejunum and the long coils of ileum cannot be accommodated here. Because all this rotation is taking place during the 6th week of development. And during the 6th week of development, we don't have enough space to accommodate all these long coils of jejunum and ileum here. That is the reason why what is going to happen, the midgut is now going to come out. So duodenum, jejunum, ileum, cecum, appendix and colon, all this is going to come out. And it is going to come out from this opening, and this opening will be the umbilical opening. And after coming out here, your midgut is going to rotate 270 degrees in anti-clockwise direction. And what is the artery which will be supplying to the midgut? It is superior mesenteric artery. Even this question has been asked in the exam, that the midgut is going to rotate 270 degrees anti-clockwise around which artery? That is superior mesenteric artery. Around superior mesenteric artery, sir. Perfectly done. Now during this rotation, what is going to happen? It's not like at once 270 degrees, sir. It's actually 90 degrees and then 90 degrees and then 90 degrees. Okay, now the first rotation, it will be 90 degrees. Okay, the first rotation will be actually the 90 degrees. And in this 90 degrees rotation, what is going to happen? Because of that superior mesenteric artery is present over there, this part is actually known as the pre-arterial segment and the post-arterial segment, before the artery and after the artery. Before the artery, the pre-arterial segment, it is the one which is going to form your small intestine, and post-arterial segment is the one which is going to form your large intestine. Okay. Now, the first 90 degrees, what is going to happen? The first 90 degrees, what is going to happen? The pre-arterial segment, the first 90 degrees in anti-clockwise direction. Anti-clockwise direction, sir. So the pre-arterial segment will be coming towards the, rotating anti-clockwise, guys. And then further in the second rotation, what is going to happen? Further it is going to rotate 90 degrees in anti-clockwise direction, as well as it is also going to reduce back into the abdomen. It will start regressing back into the abdomen. Okay. And then further in the third rotation, what is going to happen? After reducing back into the abdomen, what will happen? The cecum will be actually coming in the, in the subhepatic region. And then further rotation, the cecum will actually go into the right iliac fossa. So all these things we have actually learned in detail in our main videos. I think you have observed that one. You have seen that one, sir. So first rotation, 90 degrees in anti-clockwise direction. Then the second rotation and then the third rotation. Understanding? So altogether it will be 270 degrees anti-clockwise. Now, if this midgut is coming out of the umbilical opening here, can I call this one as hernia? Of course, it is hernia here. Is it pathological or physiological hernia? So remember, it is not pathological, it is physiological hernia. And that was the question asked in the exam. When will this physiological hernia occur? Remember, this physiological hernia will occur during sixth week. And for all this rotation to occur, and again it is going to reduce back, it will take almost 4 weeks of time. So when will this physiological hernia reduce back? It is going to reduce back by 10th week. So when is this physiological hernia taking place, sir? By 6th week. And when it is going to reduce back, sir? By 10th week. Now in some unfortunate babies, what is going to happen? The physiological hernia will occur, but it will not be able to reduce back. It fails to reduce back. If it fails to reduce back, then that baby will take birth with all the coils of intestines lying outside only, and that condition is known as omphalocele. What is that condition? Omphalocele. So what is omphalocele? The failure of reduction of physiological hernia. The physiological hernia will actually fail to reduce back, so therefore that baby will take birth with all that coils of intestines lying outside. That condition is known as omphalocele. Already asked in the exam. Recently, exactly the same picture was given here, sir. Understanding? So remember, foregut will rotate 90 degrees in clockwise direction. Midgut will rotate 270 degrees in anti-clockwise direction. And I told you, all the three, rotations are like 90 degrees, 90 degrees, and 90 degrees. The first rotation, 90 degrees anti-clockwise. And then second, 90 degrees, it will be anti-clockwise as well as start reducing back into the abdomen. And the fourth, anti-clockwise 90 degrees rotation is to actually place the cecum into the right iliac fossa over there. So suppose if this physiological hernia does not reduce back, then will lead to the condition omphalocele. Even remember when it will take place. When will physiological hernia occur? It will occur by 6th week. When it will reduce back, it will reduce back by 10th week, sir. And by this, we have actually revised all the high topics in the gut embryology also, sir. Is it okay? So if you people have observed here, we started with actually the general embryology part here. The 3rd week, all that intraembryonic mesoderm, everything. Then we discussed about the nervous system embryology, new relation, development of neural tube and all. Then we learned about head and neck embryology, the pharyngeal arches, pouches, cleft and all. Then CVS embryology, the gut embryology, venous system, arterial system. Everything has been revised in a short span of time. I think this part of the embryology will actually help you guys. So please keep revising, study well, come out in the exams with the flying colors. So all the best. Thank you for this one. Hello my dear doctors. Now we are actually going to start with pelvis and perineum topic. And in this topic, we are going to rapidly revise all the higher topics. And yes, even though it is like a small topic here, don't ignore this topic here. Why? Because in every exam, there is one question coming from extravasation of urine. So you should have a crystal clear concept regarding the perineal pouches. That is your superficial perineal pouch and deep perineal pouch. And then if there is an injury to the urethra, how to identify whether it is bulbar urethra or membranous urethra, and how to identify where the urine will be getting extravasated out. So one question is definitely coming from here. Let's go ahead with this one. I'll make the topic like easy for you. Now in this diagram, you're able to see this is the sagittal section of the female pelvis. You have seen this diagram many a times. And this will be the sagittal section of the male pelvis here, sir. Yes, we have seen this diagram a lot of times here. Now, my dear doctors, what we are going to do is from this pelvis here, I am actually going to remove off this much part out from here, sir. So let us remove this part out from here. So if you are going to remove this part out here, this is how it looks like here. So first you concentrate on the diagram. I will tell you about the deep perineal pouch and superficial perineal pouch in the easiest way possible here. Okay. Now first look at this diagram here. In this diagram you are able to see here, this is actually the deep perineal pouch. This will be the deep perineal pouch. How to identify this one here? In this deep perineal pouch there will be one fascia above here. That is the superior fascia. Please understand and listen to my words very carefully here. It's not superficial fascia, it is superior fascia. And then below here you'll be actually having the inferior fascia. The inferior fascia of urogenital diaphragm, it is also known as the perineal membrane. It is also known as perineal membrane. Okay. Now similarly, if you just come out here, okay, come out similarly here, there will be one more fascia in this region, and that fascia will be the superficial fascia. the superficial fascia in the perineum region. And this superficial fascia is having a special name. It is also known as the Colles fascia. So let us try to read all the three fascia names once more here from inside out. So inside you'll be actually having the superior fascia of the deep perineal pouch. And then you're having the inferior fascia here. And that inferior fascia is also known as perineal membrane. Please remember that word carefully. It was actually asked in your NEET PG exam, perineal membrane. And then similarly, if you're going to come out from here, this will be the superficial fascia here. Superficial fascia, also known as the Colles fascia. Now, my dear doctors, try to make the concept very simple in your mind. We're having how many fascia here? 3 fascia. If you're having 3 fascia here, how many pouches will be there in between them? There'll be only 2 pouches. The outer one being very superficial perineal pouch here, and this one here will be the deep perineal pouch. That's all. That's all. So if you remember the 3 fascia and the 2 pouches in between them, that will make your life easy for you. Understanding? So there'll be like 3 fascia, there'll be superior fascia and then inferior fascia, and then you'll be actually having the superficial fascia. Between them, you'll be having 2 pouches. So similarly, let us see in the males also. Here you're able to see the superior fascia, and this one here will be the inferior fascia. That is also known as the perineal membrane. And then here you'll be actually having the superficial fascia. Perfect. So therefore, this is going to be the superficial perineal pouch, and this will be the deep perineal pouch. Similarly here, this is the superficial perineal pouch, and this one here will be the deep perineal pouch. I hope the concept is very, very clear. Okay, just the 3 fascia and the 2 pouches. Now let us learn first about the deep perineal pouch. Now, what are the contents? In the deep perineal pouch, you are able to appreciate here that there is membranous urethra. So in males, this urethra here passing through the prostate gland will be the prostatic urethra, and this one here will be the membranous urethra, and the remaining will be in the penis, and that will be the penile urethra. Of course, in the bulb of the penis, it is specifically known as bulbar urethra. So which urethra do you have in the deep perineal pouch? So in the deep perineal pouch, you're able to appreciate the membranous urethra here, number 1. Perfect. Along with that, surrounding the urethra, you'll be actually having the external urethral sphincter muscle. And in the deep perineal pouch, you'll also have the deep transverse perineal muscle. Deep transverse perineal, transversely going transverse perineal muscle. Then, apart from that, you're also able to appreciate a gland here, that is bulbourethral gland of Cowper, Cowper's gland. Bulbourethral gland of Cowper, Cowper's gland in the males here. Understanding? But remember, my dear doctors, the membranous urethra will be present in males here, and bulbourethral gland of Cowper will also be there in only in males here. Okay, so remaining things will be the same in the females also. Now let us see in the superficial perineal pouch. You know very well now, I don't have to tell you the boundaries again. It is between the perineal membrane here and the superficial fascia. Between the perineal membrane and the superficial fascia, that is superficial perineal pouch. Now in the superficial perineal pouch, you are able to appreciate the bulb of the penis here, and just adjacent to the bulb of the penis, there will be crus of the penis also. So the bulb and the crus. Bulb will be surrounded by a muscle. That muscle is known as bulbospongiosus muscle, and the crus will be surrounded by a muscle, that is ischio-cavernous muscle. So bulb of the penis will be surrounded by bulbospongiosus muscle, and the crus will be surrounded by ischio-cavernous muscle. Now, just now I told you, in the deep perineal pouch, we'll be having deep transverse perineal muscle. Similarly, in the superficial perineal pouch, we'll be having superficial transverse perineal muscle. Superficial transverse perineal muscle. Apart from that, in the females, you are able to see this gland here, and this gland will be the greater vestibular gland. And greater vestibular gland is very famously known as the Bartholin's gland. So in the females, you'll be having the Bartholin's gland in the superficial perineal pouch. So in males, the Cowper gland will be present in deep perineal pouch, and in the female, the Bartholin gland will be present in superficial perineal pouch here. That is about this pouches here. Now, once you are clear about this perineal pouches, where exactly they are located, and now, my dear friends, let's see here what will happen if there is a rupture of this urethra. Now, in the exams, they're giving like 2 clinical cases here. Number 1, riding a bicycle on a bumpy road. So when you are riding on a bicycle on a bumpy road, what can happen? The urethra can get injured, and that injury is actually known as straddle injury. That was a recent FMG exam question. And suppose a man falls inside the manhole, okay, a clinical question given like that, and if the man falls in the manhole, there are chances of the pelvic fracture. This question about the pelvic fracture was given in NEET PG exam. Okay. Now, first thing that every student should remember, that in straddle injury, yes, which urethra will be damaged? That will be bulbar urethra. Whereas in the pelvic fracture, which urethra will be damaged? So that is the membranous urethra. Okay, so let me just take you back to the same picture over here. In straddle injury, what is going to happen? Like when you are riding the bicycle on a bumpy road, what is going to happen? Bulbar urethra will be ruptured here. Whereas in pelvic fracture, if you see that word in the clinical question, in the NEET PG exam, when this clinical question was given to you, it was clearly mentioned that the pelvic has been fractured. In the pelvic fracture, the membranous urethra will be ruptured. When membranous urethra will be ruptured here, the urine will extravasate out into which pouch? Of course, the deep perineal pouch. Deep perineal pouch. Apart from that, the urine can also, go through this fascia. This fascia can also get ruptured. And then the urine can pass around the prostate gland, around that urinary bladder. That space is actually known as the space of Ritzius. So just behind the pubic symphysis and beneath that, the urinary bladder, that space over there here, it is known as the space of Ritzius. So urine can go into the deep perineal pouch as well as the space of Ritzius around the bladder and the prostate gland. Perfectly right. In the pelvic fracture cases. Now, when a person is riding a bicycle on a bumpy road, straddle injury, which urethra will be damaged? Bulbar urethra. And when bulbar urethra is getting damaged here, the urine will be going like hell in every place over here. So the urine will be going out into the superficial perineal pouch. The urine will also extravasate out into the scrotum. The urine will also go into the penile shaft, the shaft of the penis, and the urine will also go into the anterior abdominal wall. Anterior abdominal wall also. So this will be happening in the bulbar urethra injury. Extravasation of urine will be into superficial perineal pouch, in the scrotum, into the penile shaft, as well as anterior abdominal wall. So this is an important concept, my dear friends. Nowadays in your exam, they're asking a lot of questions based on this concept only. So please revise this concept carefully, and it is not that difficult also. Just remember the 3 fascia and the 2 pouches in between them. And for understanding this, hell lot of headache during the first year MBBS days, perineal pouches, exactly where they are located and what are the boundaries of that, what are the contents. It's very easy. Now, once you are done with this one, let us go ahead with another important concept, that is perineal body. Now, in this diagram, you are able to see the female perineum, and in the female perineum, between the vaginal opening and the anal canal opening, there will be a dense, tough, fibrous body here. This body is known as the perineal body. Now, this perineal body is also found in the males here. This here will be the perineal body here. Fine. Now we need to learn what are all the muscles which are going to join at this perineal body. Remember, there are totally 10 muscles which are going to join at the perineal body. Out of the 10 muscles, 4 will be paired and 2 will be unpaired. Okay. So 4 paired muscles will be there and 2 unpaired. Now in this diagram, I told you here, this is the bulb of the penis, and bulb of the penis is surrounded by a muscle, that is bulbospongiosus muscle. And you can clearly see bulbospongiosus muscle is going to meet at the perineal body. Is it a single muscle or a paired muscle? Remember, it's actually a paired muscle, sir. So we got the first pair here, bulbospongiosus. Now in the same diagram, you're able to see the muscle coming transversely here, and there is a muscle coming transversely here. Superficial transverse perineal muscle. Superficial transverse perineal muscle. If this is superficial, obviously there will be one more muscle deep to that one. So there will be a deep transverse perineal muscle also, and deep transverse perineal muscle also present here. But in this diagram, we are not able to see that one, sir, because it is in the deep perineal pouch. Then this muscle which is actually sloping down from here, this will be the levator ani muscle. Levator ani muscle. That's all. So if you just look at this diagram here, you will be easily able to learn all the 4 paired muscle here itself, sir. So number 1, there will be bulbospongiosus. Let us just cross check here. Number 1, there will be bulbospongiosus. Number 2, there will be STP, then DTP, and then the levator ani, the 4 paired muscle. Then what about the 2 unpaired muscle here? You can very clearly see the anal canal is surrounded by the external anal sphincter. External anal sphincter. An external anal sphincter will be actually a single muscle. It's not paired. Okay. So anal sphincter will be a single muscle, and yes, of course, you can clearly see even that external anal sphincter is also going to join at the perineal body. It's going to join at the perineal body, sir. Apart from that, inside the anal canal, you'll be having even the longitudinal muscles also. The longitudinal muscles of the anal canal will also join at the perineal body. So therefore, external anal sphincter and the longitudinal muscles of anal canal. These 2 are the unpaired muscles joining at the perineal body. So they are like 4 paired muscles, and there will be 2 unpaired muscles joining at the perineal body, sir. Perfect. Okay. So there is one more topic completed here. Kul milakar, in totally you are having how many muscles here? Totally 10 muscles here. Okay. Now moving ahead with the next topic, that is ischiorectal fossa. Ischiorectal fossa. First of all, you try to understand the name here. That is between the ischium bone here and the rectum. There is a fossa, that is ischiorectal fossa. Or else it is also known as the ischioanal fossa. So in this diagram, the ischium bone will be here. That is the ischial tuberosity on which you and me we are sitting right now. This is the ischial tuberosity, and then there will be a rectum here, sir. So this is actually the ischiorectal fossa on either side. Okay. Or else this is the ischium here, and this one is the anal canal here. So that is the reason why it is also known as ischioanal fossa. So ischiorectal fossa or ischioanal fossa. Now we got to learn the boundaries. The moment you look at this diagram here, you can clearly see what is there on the lateral side, sir. Lateral side of the ischiorectal fossa, you are able to appreciate a muscle here, and that muscle will be the obturator internus muscle. Obturator internus muscle is going to form the lateral boundary. Yes, laterally obturator internus. Then on the medial side, you are able to see here the muscle which is sloping down. This one will be the levator ani. Then apart from that, you're also able to appreciate the external anal sphincter here. External anal sphincter muscle here. These 2 are going to form the medial boundary. So medially, there will be, yes, external anal sphincter and the levator ani muscle. External anal sphincter and the levator ani muscle. Perfect. And then after that, what do you have? Anterior and posterior. See, in this diagram, there is actually a coronal section here, sir. Now, in this coronal section, you are able to see only the lateral boundary and the medial boundary. Then what about the anterior and posterior? To see these boundaries, we are actually going to lift it and see from inferior view. We are going to see this ischiorectal fossa from below. So when you look at this ischiorectal fossa from below, yes, what is forming the anterior boundary here? This membrane here will be the perineal membrane. Then what do you have posteriorly? Posteriorly, there will be a sacrum here, and from the sacrum to ischial tuberosity, there will be a ligament here, sir. And that ligament will be the sacrotuberous ligament. Sacrotuberous ligament, and along with that gluteus maximus muscle is also present over there. So all these are the boundaries of ischiorectal fossa. Let us repeat the boundaries once more here. Laterally, there will be obturator internus muscle. Medially, there will be levator ani and the external anal sphincter. Anteriorly, there will be perineal membrane, and posteriorly, there will be, yes, the sacrotuberous ligament along with the gluteus maximus. Now, what is the content of the ischiorectal fossa? You can very clearly see in our diagram over here, ischiorectal fossa is filled with fat. It will consist of fat. Along with that, you'll also be able to appreciate here, there is a pudendal canal. And in that pudendal canal, you will be able to find the pudendal nerve, internal pudendal artery, and then internal pudendal vein. Again, the same thing. I repeat again, pudendal nerve, internal pudendal artery, and then vein. All these are the contents of pudendal canal along with the fat. Perfect. Now welcome to one more topic that we have to revise here in this, pelvis and perineum. That is about the internal iliac artery. Now in this diagram, this one here will be the common iliac artery. And common iliac artery will divide to external, internal. This one here will be the internal iliac artery. And this is again dividing into two divisions. One is anterior, another one is the posterior division. I request all my students to just remember the branches given by the posterior division. Posterior division will just give like 3 branches here, and remember this one as SIL, SIL branches. S stands for superior gluteal artery, I stands for the iliolumbar artery, L stands for the lateral sacral artery. Superior gluteal artery, iliolumbar artery, and then L stands for the lateral sacral artery. If you remember these 3 branches, remember in the options, if any of the branches given, they're all coming from your anterior division. Anterior division, there are like so many branches there. So you don't have to worry about all these branches, my dear friends. Remember, just the 3 branches coming from the posterior division. Why? Because always in your exam, they're asking the same question again and again. All of the following are the branches of posterior division except one. So you can easily eliminate the option over there. So just reduce your burden. Don't try to worry about all the remaining. All the remaining branches will be taking care of the viscera present in the pelvic region. So therefore, remember about the SIL branches. Superior gluteal artery, iliolumbar artery, and the lateral sacral artery. That's all. By this, we are done with all the branches given by internal iliac artery. And yes, my dear friends, by this, we are actually done with all the high yield topics to be revised in pelvis and perineum topics. And please remember that don't ignore this topic thinking that it is a simple topic or easy topic or, a small topic, why to revise and all, giving more time to neuro, head and neck and embryology. Yes, of course, they're important, but one mark will obviously matter. And yes, of course, from this small topic, you're able to score 1 mark always. They're asking the questions from extravasation of urine nowadays. That is a trending thing in the exams. Okay. So by this, we finish about the pelvis and perineum also. Hope this will help you. All the best. Hello, my dear doctors. Now we are going to see the rapid revision of abdomen topic. Okay. In this topic, we are going to revise all the high yield topics. Along with that, we are also going to discuss almost all the previous year questions also. Okay. So first, let's get started with this small topic here. They are asking a lot of times in the exams nowadays about the planes, the imaginary planes of the abdomen, and they are at which level. You need to remember their levels actually. Okay. So number 1, you're able to see here that there is a transpyloric plane here. Name itself is telling you transpyloric. That plane is going to pass through the pylorus part of the stomach. And that is also known as the Addison's plane. And transpyloric plane will be at the level of L1. At the level of L1. Now remember, transpyloric plane is going to pass through the pylorus part of the stomach. And there itself you'll be able to appreciate the origin of superior mesenteric artery. I hope you know the 3 arteries. Celiac trunk is the superior mesenteric artery and inferior mesenteric artery. Celiac trunk will be at the level of T12. And that is the artery of foregut. Superior mesenteric artery will be at the level of L1, and that will be the artery of midgut. So even transpyloric plane is also present at the level of L1. And then even the hilum of the hilum of the kidney is also at the same level. So transpyloric plane is very much important, sir. After that, the next one will be the subcostal plane. From the name, we can understand that that plane is going to touch the lowermost part of the costal margin. So that is why the name is given as subcostal plane. Subcostal plane will be at the level of L3. Then after that, this is the ilium bone. Ilium bone, the highest point here will be known as the iliac crest. And iliac crest will be at the level of L4. And this point was given in the exam. Supracristal plane. Supracristal plane passes at the level of highest point of iliac crest. That is nothing but L4. Then this ilium bone will be having tubercles, the transtubercular plane or intertubercular plane that is present at the level of L5. Transtubercular or intertubercular plane at the level of L5. So you have to remember the name of the plane and the level. Apart from that, you are able to appreciate here that there is umbilicus here. Now umbilicus, what is the location of this one? You can very clearly see in the diagram here, it is between L3 and L4. That is the location. Now, most of the students have a habit of learning the dermatome of umbilicus, and that is T10. Please be very careful here. Location is different and dermatome is different. Recently in the exam, what happened? Most of the students are having a habit of learning T10, umbilicus T10, dermatome. But in the exam, they have given about the location. Location is between L3 and L4, sir. Take care about that one. Okay. Now, Now let us discuss few points regarding the inguinal ligament. This one is ASIS and this one is a pubic tubercle. Between these two you'll be able to appreciate the inguinal ligament. Now inguinal ligament is also known as the Paupert's ligament or ligament of Paupert. Now this inguinal ligament is present between what, sir? Between ASIS and the pubic tubercle. Fine. Remember, what is this inguinal ligament actually representing? It is nothing but the thickening of aponeurosis of external oblique muscle. So in the anterior abdominal wall, you're having three muscles: external oblique, internal oblique, and transverse abdominis. External oblique aponeurosis, the thickening of that, the lower margin will be thickened to form inguinal ligament. Now there are 2 points here. One is midpoint of inguinal ligament. Another one is the mid-inguinal point. Remember, these two are not same things. They're different things. Okay. Midpoint of inguinal ligament and mid-inguinal ligament. Mid-inguinal point. These two are different things. Now, what is the midpoint of inguinal ligament? It is the midpoint between ASIS and pubic tubercle. Anterior, superior iliac spine and the pubic tubercle. Anterior, superior iliac spine and pubic tubercle, that is the midpoint. So that is the midpoint of inguinal ligament. Then what is the meaning of mid-inguinal point? Mid-inguinal point is actually between the ASIS and the pubic symphysis here. So in between them, if you draw one line, and exactly that is nothing but the mid-inguinal point. Now why is this very much important here? Why? Because just above the mid-inguinal point, 1.25 centimeters above that, you will be able to find the deep inguinal ring. So deep inguinal ring is visible 1.25 centimeters above the mid-inguinal point, not the midpoint of the inguinal ligament, mid-inguinal points. Clear with this one here? Now after learning all these simple points in the abdomen topic, we have revised them. Now welcome to one important concept, that is inguinal canal. Yes, of course, again the same thing. Always in the exam, they'll be giving the question regarding inguinal hernia. And to know about the inguinal hernia, first you have to know about the inguinal canal. Now, inguinal canal is present in our anterior abdominal wall here. Okay. Now, this diagram of the anterior abdominal wall is actually in which section here? Transverse section. So, I'm going to cut the anterior abdominal wall transversely here, remove my anterior abdominal wall, and then we are seeing from above. So, that is like seeing the anterior abdominal wall transversely here. How many layers do we have in the anterior abdominal wall? There are totally 8 layers in the anterior abdominal wall. Of course, the outermost one will be the skin here, and we have removed the skin from here. And then there will be superficial fascia. We have removed the superficial fascia also. And that superficial fascia will in turn have 2 layers. The outer fatty layer, that is nothing but your Camper's fascia. The inner fibrous layer, that is Carpa fascia. So we have removed the skin, we have removed the superficial fascia. After removing that, we'll be able to appreciate the external oblique muscle and aponeurosis, internal oblique muscle and its aponeurosis, transversus abdominis muscle and its aponeurosis. Then after that, there is one very important fascia here, there is transversalis fascia. Then extra peritoneal layer, and then you'll be having the parietal peritoneum. So in total, if you count them, there are totally 8 layers in the anterior abdominal wall. Now, once you know all these layers in the anterior abdominal wall, now let me tell you the 3 points here, sir, which are extremely important and has been given in your exam many a times. Point number 1. In transversalis fascia, in this transversalis fascia, there is an oval shaped opening here, and that opening will be known as the deep inguinal ring. So deep inguinal ring will be oval shaped defect in which layer? Transversalis fascia, already asked in the exam. Then in external oblique aponeurosis, in the aponeurosis of the external oblique, you will be able to see a triangle shaped opening over here, and that will be the superficial inguinal ring. So let us repeat this once more here. It's worth repeating, very much important, sir. Deep inguinal ring is present in transversalis fascia, whereas superficial inguinal ring is present in external oblique aponeurosis. Then what about the 2 layers in the middle, sir? Internal oblique transversus abdominis. What about these 2 layers in the middle? Remember, internal oblique will actually be arching above the inguinal canal and going on the other side. And even transversus abdominis aponeurosis will also arch above and go on the other side. And on the other side, both these aponeuroses will fuse together, and together they are going to form conjoined tendon. So therefore, conjoined tendon is formed by dash and dash. It is formed by internal oblique plus transversus abdominis. Internal oblique plus transversus abdominis. Perfectly done. Okay, so now this is what is the 3 points that I was telling you about. Let us repeat these 3 points again right now, sir. Okay, deep inguinal ring is present in transversalis fascia. Superficial inguinal ring is present in external oblique. Conjoined tendon will be actually formed by internal oblique plus transversus abdominis. Now, after learning all these points here, let us join the deep inguinal ring with the superficial inguinal ring. Let us join the deep inguinal ring with the superficial inguinal ring, and that results in the formation of a canal here, and this canal is known as the inguinal canal. What is the name of this canal? Inguinal canal here, sir. Clear? Now, after learning about the inguinal canal, how it is present, where it is present, sir, let us see the important points regarding the inguinal canal. Okay, the first thing that you have to learn here is what is the extent of the inguinal canal, sir. I told you just now it extends from deep inguinal ring to superficial inguinal ring. Number 1. Number 2, the second thing is what is the length of the inguinal canal? Approximately it will be 4 centimeter. To be very specific, 3.8 centimeter or 3.75 centimeter is also given in your exams. So what is the length of the inguinal canal? Just 4 centimeters. And now we have to learn what will be the boundaries and what is the content of the inguinal canal. Okay. Now if you look at this diagram here, my dear friends, in this diagram, this is actually the inguinal canal here. What is present in front of the inguinal canal? Remember, in front of this inguinal canal, you are able to see external oblique here as well as the internal oblique. External oblique and internal oblique. These two are forming the anterior boundary of inguinal canal. So inguinal canal anteriorly will be having external oblique, internal oblique. Then what do you have behind the inguinal canal, sir? Posteriorly. So this is the inguinal canal here. Posteriorly, you are able to see here transversalis fascia, and this one here will be the conjoined tendon. So transversalis fascia and conjoined tendon is going to form the posterior boundary. And then what is forming the roof and the floor? Remember, the roof will be formed by, I told you very clearly, what is arching above the inguinal canal. Internal oblique and transversus abdominis are arching above the inguinal canal. Then they are going on the other side and they will merge together. Together they are going to form conjoined tendon. Okay. So remember, what is going to form the roof of the inguinal canal? That is internal oblique and transversus abdominis. Okay. These two are going to form the roof of that one. Then finally, what is forming the floor of the inguinal canal? Remember, the floor will be formed by inguinal ligament. Inguinal ligament is the one which is going to form the floor. Inguinal canal is present above and medial to the inguinal ligament. So what do you have below the canal? There will be inguinal ligaments. Perfectly done. We are done with all the boundaries of the inguinal canal, sir. Now once you are done with the boundaries of inguinal canal, what is the content in male and in the female? In females, there will be round ligament of uterus along with ilioinguinal nerve. Okay. Round ligament of uterus and along with the ilioinguinal nerve, sir. Ilioinguinal nerve, we have already learned in the rapid revision session of lower limb. In the lower limb, I told you iliohypogastric and ilioinguinal nerve are coming from L1. Fine. That nerve is passing from here. Fine. But what about the round ligament of uterus? Remember, uterus has got like many supports, sir. So one of the support of the uterus will be like, broad ligament, round ligament. So round ligament will begin from the uterus, passes through the inguinal canal, then comes out and merges with the labia majora in the females. Okay. So even the round ligament of the uterus will be a content of your inguinal canal. It's a content of inguinal canal. Perfect. Then after that, in the males, you will be able to see the spermatic cord. Along with the spermatic cord, there will be ilioinguinal nerve again. Now, out of these two contents in the male and the female, we need to learn what is the true content and what is the false content. But how are we going to decide this one? For example, if this is the oval shaped deep inguinal ring and this one is a triangle shaped superficial inguinal ring, sir. Join the deep inguinal ring with the superficial inguinal ring. This is inguinal canal. If any content is going to pass or it is going to enter via deep inguinal ring and it is going to come out via the superficial inguinal ring, that's a true content. That's a true content. If any content is going to pierce through the posterior wall, then enter and come out via the superficial inguinal ring, that's a false content. And what is the false content? The nerve. Ilioinguinal nerve, both in male and in the female, ilioinguinal nerve is going to pierce through the posterior wall and then enter inside the canal. That is why it is actually the false content, sir. Whereas round ligament of the uterus in female, the spermatic cord in the male is actually a true content. Perfectly done. So by this, we are done with the topic of inguinal canal, the boundaries as well as content completed here, sir. But now let us see what is the spermatic cord made up of, sir. I just told you here the spermatic cord is present here. But what is the spermatic cord made up of? Let's see this one here. Now, no need to actually make any mnemonic here. Please don't make any mnemonic. It is like, there are so many structures which are going to form the spermatic cord. Please don't make some mnemonic and, mug up that one, sir. I'll tell you one best way to remember this one. See, normally in males, the testis will be actually formed in abdomen. After forming in the abdomen, the testis will actually descend down. Okay. Now, from where is this testis descending, sir? Remember, the descent of testis will occur from the inguinal canal only. So via the inguinal canal, the testis will actually descend down into the scrotum, and it has to descend down. Why? Because in males, we know very well, in the scrotum, the temperature will be 2 degrees less than that of the body temperature, and that is required for spermatogenesis. Okay. So testis has to descend down. Fine. But why am I telling you about this one right now? If the testis is descending from the inguinal canal, everything connecting to the testis should pass from here only, right? Of course. So remember, the artery to the testis, the vein from the testis, the nerve to the testis, and then from the testis there will be a duct, vas deferens, which is going to carry the spermatozoa. All the structures which are going to connect the testis is passing from here only. And all these contents together, it is referred to as your spermatic cord. And these contents are actually having those 3 coverings: internal spermatic fascia, in the middle you'll be having cremasteric fascia, and the external spermatic fascia. So keep this concept in mind, it will be damn easy for us. So let us see right now. So what are all the structures which are going to form the spermatic cord? Number 1, testicular artery. There will be artery supplied to the testis. What is the name? Testicular artery. The vein which is going to drain the blood from the testis, pampiniform plexus of vein. Number 3, the genital branch of genitofemoral nerve. And number 4, vas deferens or ductus deferens, the duct. And all this will be actually covered by the 3 fascia: internal spermatic fascia, external spermatic fascia, and the cremasteric fascia. And yes, of course, you also have a small artery to vas deferens. So all this together, they are going to form the contents of your spermatic cord. I hope it is very, very clear here. Now, once you are done with the entire inguinal canal is done, one more small topic, that is your spermatic cord is also completed here, sir. Now let us see the clinical application of inguinal canal, that is inguinal hernia. Inguinal hernia, there will be of 2 types, sir. One will be the indirect inguinal hernia. Another one will be the direct inguinal hernia. Now, what is the difference between the direct and indirect? Indirect inguinal hernia means the hernia which occurs via deep inguinal ring. If the herniation occurs via the deep inguinal ring, it is indirect. Direct means what, sir? This herniation will occur via a triangle. That triangle will be known as Hasselbalch's triangle. And of course, you can easily understand now, if Hasselbalch's triangle is the one from where direct inguinal hernia is occurring, we need to learn about the boundaries of that one. So now let us learn all the boundaries of Hasselbalch's triangle here. Now this one here will be the pubic tubercle and symphysis. Pubic tubercle and the symphysis here, the pubic symphysis. Exactly in the middle, you'll be having a shallow depression, a white line in the middle, that is linea alba. Now on either side of the linea alba, you'll be able to see the muscle which is going to form your six packs. Rectus abdominis muscle here and rectus abdominis muscle here. Now between the pubic tubercle and ASIS, anterior superior iliac spine, there will be a ligament, and that ligament here will be the inguinal ligament. And then finally there will be the inferior epigastric vein here, and then the inferior epigastric artery here. And between these three of them, you can very clearly see that there is a triangle formed here. And this triangle will be referred to as your Hasselbalch's triangle. Or else it is also known as inguinal triangle. And this is a triangle exactly from where the direct inguinal hernia will occur. So let's see the boundaries right now one by one, sir. What is going to form the base of this Hasselbalch's triangle? Base will be formed by inguinal ligament. This is going to form the base. What is going to form the medial boundary of Hasselbalch's triangle? That is rectus abdominis muscle. So rectus abdominis muscle is going to form the medial boundary. And then finally the inferior epigastric vessels. Inferior epigastric vessels. These are the one which are going to form the lateral boundaries. Okay. So base of the Hasselbalch's triangle will be formed by inguinal ligament. Medial boundary will be formed by rectus abdominis muscle, and laterally there will be inferior epigastric vessels. So this is all where the Hasselbalch's triangle will be present, and from here which hernia will occur? The direct inguinal hernia will occur, sir. Perfectly done. Now after completing this important concept here, we are done with one very big thing, sir. Inguinal canal, the boundaries of that, the content, and then what will be the direct and indirect inguinal hernia and Hasselbalch's triangle. So many topics are completed here. Now let us revise some simple topics also. Now spleen here, sir. Now in the spleen you'll be actually having those two surfaces. One will be the outer convex surface and the inner surface will be facing towards the visceral organs. Okay, so now what will be related to the outer convex surface? That will be related to diaphragm. And the inner surface, which is actually towards the viscera, let us see which visceral organs will be having the impressions on the spleen here, sir. Number one, there will be impression of the stomach. Number two, there will be the impression of left kidney on that one, as well as the left colic flexure. The transverse colon is going to continue down into the descending colon, and the turning is known as the left colic flexure or splenic flexure. Even that will also have an impression on that, and even the tail of pancreas. Okay, now our spleen is actually related with many ligaments over here, but recently in the exam one question was which ligament is going to prevent the downward displacement of the spleen. Okay, so the downward displacement of the spleen will be prevented by this ligament here, sir. That is phrenico-colic ligament. From the name itself we can understand phrenico, diaphragm, colic, colon. The phrenico-colic ligament is preventing the downward displacement of spleen. This is the point that you have to remember, asked recently in the exams. Then the next one that you have to remember here is about the kidney. See, we know very well what is the extent of the kidneys. Kidneys will extend from T12 to L3. But remember, both the kidneys are not at the same level. Okay, we know that the right kidney will be a bit lower when compared to the left one. Why? Because on the right side we have big bulky liver here. So because of the liver here, the right kidney will be a bit lower than compared to the left one. Now in the kidney, again the same thing, we need to learn the relations of both the kidneys, right and left kidney. Fine. Now first try to understand that right and the left kidney, both of them are actually present on the posterior abdominal wall. That means the posterior surface relations of both the kidneys will be same. Because on the right side and the left side, the posterior abdominal wall is absolutely the same only. But the anterior surface relations of both the kidneys will be different. There are like different structures in front of the right kidney. In front of the right kidney, there will be liver here and duodenum is taking a turn here. But whereas in front of the left kidney, you'll be able to see spleen here and the stomach here, as well as the pancreas is going all the way up to the spleen there. So these are all present in front of the left kidney here. So what I'm trying to tell you here is that for both the kidneys, right and left kidney, posterior surface relation is absolutely the same, whereas the anterior surface relation will be different. So let us see right now. First, let us see the posterior surface relation. It's quite easy here, sir. Just one horizontal line here and the two vertical lines here. Upper half of the kidney will be related to diaphragm. Now the question here is, how come diaphragm is coming behind the kidney? Answer is very simple. What is the shape of the diaphragm? It will be dome shaped. So this is the right and left kidney here. The dome shaped diaphragm is actually coming behind the kidney. So upper half will be related to the diaphragm. And the lower half is actually related to the three muscles which are actually going to form your posterior abdominal wall, which is the medial most one here. That is your psoas major muscle. Just lateral to that will be having the quadratus lumborum muscle. And just lateral to that there will be transversus abdominis. Psoas major, then quadratus lumborum, and then the transversus abdominis muscle. Then during the rapid revision session of lower limb, I taught you about the lumbar plexus. And in the lumbar plexus, I taught you about the minor nerves. Can you please recall which two nerves are coming out between the psoas major and quadratus lumborum? Not piercing the psoas major. Which two nerves are coming out between the psoas major and quadratus lumborum? That will be the iliohypogastric nerve and ilioinguinal nerve. Iliohypogastric nerve and ilioinguinal nerves. Now the last thing, after learning all these things here, if you still want to add something over here, of course, if this is your diaphragm here, there will be actually your T12, the 12th rib. So below the 12th rib, you'll be able to find the subcostal nerve, subcostal artery, and subcostal vein. All the three of them are present below the 12th rib here. So these will be absolutely the same for both the kidney, right and left kidney. This is absolutely the same. But yes, there is one difference here. I told you the right kidney will be a bit lower when compared to the left one. That is the reason why the right kidney is related only to the 12th rib, whereas the left kidney will be related to both 11th as well as the 12th ribs. Right kidney is a bit lower, so that is the reason why it is related only to the 12th rib, whereas left kidney is a bit up, that is why it is related to both 11th and 12th rib. That is the only difference in the posterior surface relations of both the kidneys. Perfect. Now let us see the anterior surface relations now. In the anterior surface relation, one thing which is similar here, suprarenal gland here, and here also the suprarenal gland. And below here, again you'll be having the colon and the colon here, the jejunum and the jejunum here, sir. So till here it is absolutely same for both the kidneys in the front. Why? Because both the kidneys are present over here, ascending colon, then takes a turn, transverse colon, then descending colon. So both the kidneys are related with colon and both the kidneys are also related with coils of jejunum. Till here it is absolutely the same. Now comes the difference. In front of the right kidney, there will be liver here, big bulky liver here. And then the duodenum, first part, second part, and then third and fourth. So second part is going to take a turn in front of the right kidney. So this will be the duodenal area. So right kidney is related to liver and the duodenum. Whereas left kidney, this part here will be the splenic area that is related to spleen here. And what is going all the way up to the spleen there? There is your pancreas here. And whatever area will be left out, that will be covered with the stomach here, sir. That is covered with the stomach here. And why I'm actually revising this one in the rapid revision session here? Yes, why? Because in your exam, this was given as an image-based question. The image of the liver was given, and the arrow mark, you have to identify what is the structure related to the kidney here. So now the next topic that we are going to discuss is about the openings of diaphragm. Diaphragm is another important thing, and we are going to learn the openings here. So there are three major openings in diaphragm. Number one, there is a vena cava opening here. This is the vena cava opening from where inferior vena cava is passing. And remember, the vena cava opening is located in central tendon of diaphragm. Perfect. Then the next one here will be the esophageal opening from where esophagus passes. And this esophageal opening is located in the muscular part here. And the third one here will be the aortic opening. Aortic opening is actually present between right and left crus of diaphragm. Okay. Between the right and left crus of the diaphragm. So these three openings and their location done. After that, you also have to remember the level. Remember, vena cava opening will be at the level of T8, Esophageal opening will be at the level of T10. Aortic opening will be at the level of T12. And these numbers are very easy to remember here. Remember 8, 10, 12, even numbers. But the problem in the exam, the students are remembering the numbers very well, but they're forgetting they're at which level, at which opening. So please remember that mnemonic, the very famous one, Voice of America. The Voice of America, vena cava opening at T8, esophageal opening will be at T10, aortic opening will be at T12. So once you learn the name of the opening here and the location, now let us see, yes, what are the structures passing from here? Vena cava opening, there will be inferior vena cava passing from here, sir. No one will ask you about that one. Write and forget about that one. It's vena cava opening. Obviously, inferior vena cava is passing from there. Along with that, there will be right phrenic nerve passing from here. There will be a right phrenic nerve passing from here. So your focus should be on this one here. Along with the inferior vena cava, there will be only right phrenic nerve passing, not the left one. Then esophageal opening, what is going to pass from here? There will be esophagus. And along with the esophagus, there will be vagus nerve passing from here. Vagus nerve. So just remember, like a rhyming word here, esophagus and vagus. So esophageal opening, what is passing from here? So esophagus, and along with that vagus nerve is passing. Okay. And from here, you'll also have the esophageal branches from the left gastric artery. I'll show you them in a few minutes. Now, what is going to pass from the aortic opening? Of course, aorta will pass from here. And here itself, what is going to happen? Thoracic aorta will end and abdominal aorta will begin from here. Along with aorta, even thoracic duct is also passing from here. We have learned this in the thorax topic. Along with that, even the azygous vein is also passing from here. So aortic opening, aorta, along with the thoracic duct, as well as the azygous vein is also passing from here. So that is about the openings of diaphragm. They are at which level and what are the structures passing from here. And now from here itself, let us learn about the abdominal aorta. See, abdominal aorta is going to begin from where? Of course, just now I told you, it's going to begin from T12, aortic opening. And it is going to extend all the way up to L4. So T12, L1, L2, L3, L4. Okay. Now, we need to learn what are the branches given by abdominal aorta. But in this diagram, it is looking like very much cluttered here, like all these, branches and all. So let us do one thing. Let's draw one simple diagram here. So for example, if this one is the diaphragm, this one here will be your abdominal aorta. Abdominal aorta is extending from T12 to L4. At L4, it is going to end by dividing into common iliac arteries. Perfect. Now the branches from the abdominal aorta is given in all the directions. I mean to say we are having ventral branches as well as dorsal branches as well as lateral branches also. First, let us deal with the ventral branches. Right at the level of T12, we are getting celiac trunk. Already asked in the exam. Celiac trunk is given at which level? T12. And that is the main artery supplying the blood to your entire foregut. At the level of L1, there will be superior mesenteric artery supplying to the midgut. Leave L2, then at the level of L3, there will be inferior mesenteric artery. That is supplying the blood to your hindgut. Okay. The foregut is supplied by celiac trunk. The artery of midgut will be superior mesenteric artery and the artery of hindgut will be the inferior mesenteric artery. So these three are the ventral branches of abdominal aorta. Then what about the lateral branches? There will be a branch given to diaphragm here. And this will be the inferior phrenic artery. Inferior phrenic artery. So that branch is given to diaphragm from below the diaphragm, that is inferior phrenic artery. Then of course you will also have your kidney here, and above the kidney there will be suprarenal gland here. So one of the arteries supplying to the suprarenal gland, and this is the middle suprarenal artery. Middle suprarenal artery. Then there is a branch given to the kidney. To the kidney it is renal artery, sir. And then finally there is a branch going down to the gonads, and this one will be the gonadal artery. This is gonadal artery. So the same gonadal artery in the males, that will be testicular artery, and in the female the gonads will be the ovaries, so that is ovarian artery. And this question also has been asked in the exam, that Ovarian artery is a branch of which one? Abdominal aorta. Testicular artery is a branch of which one? Of course, again, abdominal aorta. And all these four of them will be the lateral branches given from abdominal aorta. So what are the lateral branches of abdominal aorta, sir? Inferior phrenic artery, middle suprarenal artery, renal artery, and then gonadal artery. Fine. After learning about the ventral branches and the lateral branches, now let us see what will be the dorsal branches. Dorsal branches are actually given behind, so we'll not be able to draw them in the diagram here. So let us just write down. There will be 4 pairs of lumbar arteries. There will be 4 pairs of lumbar arteries, and there will be only and only one single median sacral artery. Median sacral artery. Okay. So what are the dorsal branches? There'll be like 4 pairs of lumbar arteries and there'll be one median sacral artery. So these are all the branches given from the abdominal aorta. Like simple diagram, best way to remember here, sir. Perfect. Now after this, let us learn about the celiac trunk in detail. I told you celiac trunk is the one which will be supplying the blood to your foregut. Many questions are also coming from here. So let me just tell you all these branches in a simple manner. Let's actually draw this diagram in fact. Okay. Then only you'll be able to learn it perfectly. Celiac trunk will be supplying to your entire foregut. So it will include your esophagus and the stomach here and the duodenum up to the first part and the second part. Up to the second part of the duodenum will be your foregut. Then here you'll be actually having the pancreas. Pancreas will be present in the C-shaped concavity of the duodenum, and the pancreas will be passing from behind the stomach. It is one of the stomach bed relation. And finally, the tail of the pancreas will be lying in the hilum of the spleen. Imagine that it's your spleen there. And then all this will be towards the left, and towards the right here, you just imagine this one to be your liver here. And along with the liver, this will be the gallbladder. So we're drawing just a schematic diagram here for the sake of understanding here, sir. Now, celiac trunk will be present somewhere over here. That is the hero of the story. And celiac trunk is the one which will be supplying the blood to the entire foregut here. But first try to learn here that celiac trunk will give like 3 main branches. What are the 3 branches given by celiac trunk? Number 1, there will be left gastric artery. Number 2, there will be splenic artery. And number 3, there will be the common hepatic artery. So we are going to learn about them one by one now. So left gastric artery is the easiest one, the splenic artery is like moderate one, and then finally the common hepatic artery, the most difficult one. So I'm going to teach you in the order of difficulty here. Now, celiac trunk will give rise to the first branch, that is your left gastric artery. Name itself is telling you that it is going along the lesser curvature of the stomach. Gastric going towards the stomach, going along the lesser curvature of the stomach, left gastric artery. And on the way, it will be giving the branches only and only to esophagus, esophageal branches. That's all about the left gastric artery, sir. It is the easiest one. The second one will be the splenic artery. And now the splenic artery has to go all the way to the spleen. Is it going in front of the stomach or behind the stomach? Remember, it's going behind the stomach in a zigzag manner. That means it is also one of the example of tortuous artery. Splenic artery is not going straight there, it is going in a zigzag manner. So it's an example of tortuous artery. Now this splenic artery, what are the branches given by the splenic artery here, sir? Just follow my diagram, it will be easy for you. While going towards the spleen, it is giving the branches to the pancreas. This is pancreatic branches. Okay. So splenic artery is actually going towards the spleen. While going towards the spleen, it is giving the branches to the pancreas, pancreatic branches. Then it is giving a branch along the greater curvature of the stomach. This one here will be the left gastroepiploic artery. Okay. Gastro means to the stomach, epiploic to the omentum. So it is supplying to the stomach as well as the omentum there. Then the splenic artery will also give like small branches near the fundus of the stomach. This will be the short gastric artery. And finally the splenic artery will enter into the hilum of the spleen. There it is dividing into like 10 to 15 branches, and those branches will be the hilar branches. Hilar branches. Clear? So in this manner, if you learn in the diagram here itself, you'll be easily able to remember the diagram, like all the branches. So what are the branches given by splenic artery? Number 1, pancreatic branches. Number 2, left gastroepiploic artery. Number 3, short gastric artery. And number 4 will be the hilar branches. Hilar branches, sir. Perfect. Now after learning this one, the third and the final one and the most complicated one will be your common hepatic artery. Now don't think that it's going just towards the liver there. The name is common, and common will again divide. So common hepatic artery is in turn dividing into like two branches. One which is actually going towards the liver will be the proper hepatic artery. And then one more will be given here which is going behind the the first part of the duodenum there. And this one is the gastroduodenal artery. So what I'm trying to tell you here is that common hepatic artery will in turn divide into two branches. One which is actually going towards the liver will be proper hepatic artery. Another artery is going behind the first part of duodenum, and that is looking like it is present between the stomach on one side and the duodenum on the other side. Gastroduodenal artery. Gastroduodenal artery. The name is very simple. And please remember that it is going to pass behind the first part of duodenum. Why I am stressing on that point is why? Because yes, that is one of the complication of ulcers. So when they are actually the ulcers in the duodenum, one of the complication of ulcers is ulcers will perforate. And when they perforate onto the posterior wall of the duodenum, yes, there will be hemorrhage, there will be bleeding. And that bleeding will occur from which artery? That is your gastroduodenal artery. Remember that. Okay. Now let us look at these two arteries one by one. Number 1, gastroduodenal artery is going to end here. And it is ending here by giving like two branches. One of the branch will be going along the greater curvature of the stomach. And this one will be the right gastroepiploic artery. Right gastroepiploic artery. And another branch will be going here, and that is between the pancreas and the duodenum. And that is the reason why it is superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery, sir. So gastroduodenal artery is ending by giving two branches, right gastroepiploic artery and then superior pancreatico-duodenal artery. Now let us go towards the other side, that is the proper hepatic artery. Proper hepatic artery will in turn divide into two branches here. One will be the right hepatic artery, another one is the left hepatic artery. Out of these, to remember, right hepatic artery will give a branch to the gallbladder, and this one will be the cystic artery. Cystic artery. Perfectly done. Now, just to end this concept here, my dear friends, please look at the lesser curvature of the stomach. On the lesser curvature, I told you only about left gastric artery. What about the right gastric artery? Remember, right gastric artery, according to the latest edition of Gray's Anatomy, that is 42nd edition, it's clearly mentioned there that it is a branch of proper hepatic artery. So proper hepatic artery will give a branch. This one here will be the right gastric artery, sir. Right gastric artery. So by this, we are done with the entire celiac trunk. That is the reason why I made you draw this diagram here. Why? Because if you see all the branches directly over here, it will not be easy for you to learn. The best way, practice this diagram, sir. So once you practice this, all the branches, you can easily memorize that one, sir. Perfectly done. Now moving ahead with the next concept, let us see about the peritoneum. And yes, of course, after this, the most important topic, every exam they're asking one question from there, that is your epiploic foramen, the foramen of Winslow. Okay. Now in this diagram, you're already able to see the transverse section here. In this transverse section, my dear doctors, remember, there is a small space which is enclosed behind the stomach here. Behind the stomach here, that is your lesser sac. And the remaining space present over here, this will all be the greater sac over here. And remember, the lesser sac and the greater sac are in still communication with each other via a foramen, and that foramen is known as the epiploic foramen or the foramen of Winslow. But before learning about the epiploic foramen, let me tell you about all these ligaments here. Number 1, this ligament which is connecting the liver with the anterior abdominal wall. Now this ligament here will be the falciform ligament. And already we have learned in the rapid revision session of embryology, I told you very clearly, falciform ligament will be derived from ventral mesentery. Now between the liver and the stomach, there is a omentum here. This omentum will be the lesser omentum. Fine. Then this ligament between the stomach and the spleen here, this ligament here will be the gastrosplenic ligament. Okay. And then finally, this ligament here will be the splenorenal ligament. Okay. Or else the spleen is also referred to as lean, therefore it is also known as lenorenal ligament. Sir. And these two ligaments, that is gastrosplenic and splenorenal ligament, these two are actually derived from where? These two are derived from the dorsal mesentery only. They derive from dorsal mesentery. Fine. And in fact, the spleen itself is developing from the dorsal mesentery. Now, what you have to learn here is what will be the content of these ligaments here. In this diagram, you can very clearly see here, this is the celiac trunk, and the celiac trunk is giving rise to the splenic artery. You can clearly see the splenic artery is coming from there. So that splenic artery is coming via which ligament? Splenorenal ligament only. So please remember, it will consist of splenic artery. And along with the splenic artery here, you'll also have the tail of pancreas. Splenic artery is going to enter into the spleen from the hilum. And near the hilum, you can see it is giving like many hilar branches there. And near the hilum itself, you'll also have the tail of the pancreas. So once already asked in the exam, tail of the pancreas will be located in which ligament? Remember, it is splenorenal ligament. Done. After that, what about the gastrosplenic ligament? In this gastrosplenic ligament, of course, you can clearly see here, this is your splenic artery. Just now I taught you. Now, splenic artery itself is giving the branches along the greater curvature of the stomach. Splenic artery is giving the branches along the greater curvature. Which one? The left gastroepiploic as well as the short gastric artery. So these two should be present in which ligament only? They are present in the gastrosplenic ligament. The gastrosplenic ligament will consist of short gastric artery as well as the left gastroepiploic artery. So left gastroepiploic artery. Perfectly done. Now, after completing this one, let us discuss the important concept, that is epiploic foramen. Now, epiploic foramen is the one which is going to connect your lesser sac with the greater sac. So first try to learn the other names here. Epiploic foramen, it is also known as the foramen of Winslow. One more name, it is also known as the omental foramen. Please be very careful. I'm not telling you omental bursa. It is actually omental foramen. Omental bursa is actually another name of lesser sac. This one is omental foramen here. So epiploic foramen or the foramen of Winslow or the omental foramen. Now, what are the boundaries of this one? Now, the first thing, try to understand here, many students are making a mistake that this is your lesser omentum here and this one is the liver here. The lesser omentum and the liver, they are thinking that the epiploic foramen is between these two. Absolutely wrong. This is not the epiploic foramen. Epiploic foramen is actually present behind the lesser omentum. Behind that lesser omentum. So if epiploic foramen is present behind the lesser omentum here, okay, then vice versa, what do you have in front of the epiploic foramen? If the epiploic foramen is present behind the lesser omentum, for example, if this is the free margin of the lesser omentum, epiploic foramen, it's not on the side here. Remember, it is actually present behind. If it is present behind here, then what is present in front of that one? Obviously, the free margin of lesser omentum. And that free margin of lesser omentum will actually have the portal triad. What it is having, sir? Portal triad, that is hepatic artery and the bile duct and the portal vein. Hepatic artery, bile duct and the portal vein. Then what do you have behind the epiploic foramen? That is inferior vena cava. Of course, inferior vena cava will be passing from there. So we are done with the anterior and the posterior one. And from this diagram itself, we can easily remember what do you have above the epiploic foramen. What do you have above the epiploic foramen? Of course, you are able to see the liver. Which lobe of the liver? Caudate lobe of the liver. And what you have below the epiboloic foramen here, that will be the first part of the duodenum. Okay, so above you'll be able to appreciate the caudate lobe of the liver. Be careful with this one, already given in the exam as caudate lobe. That's the wrong option. Caudate lobe of the liver. And then what you have below duodenum, which part's the first part? That is the easiest way to remember the boundaries of the epiboloic foramen. So please remember, epiboloic foramen is present behind the free margin of lesser omentum. So in that free margin, you in this diagram also, in fact, you are able to see the bile duct here, okay, as well as you are also able to see the proper hepatic artery here, as well as you are able to see the portal vein also. Clear? And with this, my dear doctors, we are done with the entire abdomen topic. These are all the higher topics to be revised in the abdomen. Thank you. All the best. Hello, my dear doctors. Welcome back. Now we are going to start with the rapid revision of upper limb topic. And it is another very, very important topic for any of the competitive exams that you're going to attend, whether it is NEET PG or INA-SET, or whether you're writing your FMG exam. Definitely, there will be a question from upper limb topic. And you know very well, it will be from the nerve injuries. Yep. So ulnar nerve, median nerve, or the radial nerve injuries, mainly they'll be giving the questions from here itself. Okay. So we are going to discuss about those nerves actually in detail, my dear friends. Don't worry about that. I'm going to tell you all the clinical cases one by one. Okay. So without any further ado, let's get started with the upper limb topic right now. And of course, we are also going to include almost all the previous year topics also. Now, the first important topic that I want you to revise right now is muscles of hand. We know that there'll be like totally 20 muscles of hand, and out of that 20 muscles of hand, there'll be 4 thenar, and then 4 hypothenar, and then 4 lumbricals, then 4 palmar interosseae, and 4 dorsal interosseae. Okay. Now, out of all these 20 muscles, you know very well, this group of muscles which are present below the thumb, this group of muscles will be the thenar muscles. So this will be the thenar muscles. And this group of muscles below the little finger here, this will be the hypothenar muscles. Now, what will be the name of this thenar and hypothenar muscles? Thenar muscles will be, number 1, they will be flexor pollicis brevis. Obviously, from the name itself, we can understand it is helping in flexion of thumb. And number 2, they will be abductor pollicis brevis. Number 3, there will be apponens pollicis. And then number 4, there will be adductor pollicis. This muscle is going to help in adduction of the thumb. Hypothenar muscles will be including flexor digiti minimi, and then there will be abductor digiti minimi, and then you'll be having the apponens digiti minimi, and the fourth one will be the palmaris brevis. Palmaris brevis. Okay. Now, the thenar and hypothenar muscle, let us repeat them once more here. Number 1, there will be muscle helping in flexion of the thumb, flexor pollicis brevis. Number 2, there will be abductor pollicis brevis, moving away from the thumb. Okay. And then there will be apponens pollicis, and then there will be the adductor pollicis. And exactly in the similar manner, in the hypothenar muscles also will be having flexor digiti minimi, abductor digiti minimi, apponens digiti minimi, and the palmaris brevis. Now, after learning the names of all the thenar muscles and hypothenar muscles, we know very well like the nerve supply. I hope you all remember the golden rule that I taught you in our main videos. Okay. All the muscles in your arm and the forearm and the hand, they are supplied by the 5 major nerves. Okay. All the muscles in the anterior compartment of the arm will be supplied by musculocutaneous nerve. All the muscles in the posterior compartment of the arm will be supplied by radial nerve. All the muscles in posterior compartment of the forearm will also be supplied by radial nerve. Anterior compartment of the forearm, all the muscles are supplied by 2 nerves. One is your ulnar, another one is median nerve. Sir. And then the muscles of hand, they will also be supplied by ulnar and median nerves. So what I'm trying to tell you here is that all these 20 muscles of hand, they'll be supplied by ulnar and the median nerves. Sir. Okay. Now in this one, my dear doctors, remember, out of all the thenar and hypothenar, we know that ulnar nerve is coming from the medial side. So ulnar nerve is the one which will be supplying to all the hypothenar muscle. Along with the hypothenar muscle, it is also supplying to one of the thenar muscle, that is your adductor pollicis, very much important for your exams nowadays. So all these nerves which I have marked in yellow color here are taken care by ulnar nerve. Okay. Similarly, the remaining three thenar muscles here, sir, flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. These three thenar muscles, they will be supplied by median nerve, sir. They will be supplied by the median nerve. I hope this is very clear now. And I also believe that most of the students will be knowing this information. Now here itself, let me tell you one important thing here, that is about the adductor pollicis, sir. How are you going to test this adductor pollicis muscle? Remember, adductor pollicis is tested by book test. Okay, book test. So for example, suppose if someone is giving me a book here, for example, if this is a book here, if someone is giving me a book here, how I'm going to hold the book? Something like this here. Something like this. Now, if you look at my thumb here, there is actually adduction of the thumb. So this book will be held by adduction here. So this is done by adductor pollicis, and adductor pollicis is supplied by ulnar nerve. The book test is done for which nerve, sir? Ulnar nerve. No doubt about that. Now, for example, you imagine that the ulnar nerve is actually gone if it is injured. If the ulnar nerve is injured, then adductor pollicis muscle is gone. Now, if you're giving a book to someone, the person is not able to adduct. Fine. But if he wants to hold the book at the same time, how is he going to hold the book? He'll be using the flexor pollicis muscle here. So therefore, he is actually going to flex the thumb and hold the book like this here. The moment you see that the thumb is bent here, understand that the ulnar nerve is gone. Okay, and this is actually known as the Froment sign, which was given in your NEET PG exam 2023. Understanding? So when the thumb is bent here, there is nothing but the Froment sign. So please remember that book test is done for ulnar nerve, and whenever you see that the thumb is bent, it indicates that the Froment sign is positive there, sir. That is an important point to remember from this here. Now, knowing these names of all these muscles and their nerve supply, I believe that most of the students might be knowing this one. Well and good, fine. But the most important thing here is learning the attachment of this muscle. Nowadays in the exam, they're giving image-based questions on attachment of this muscle. So now in the hand, we know very well there will be 8 carpal bones arranged in 2 rows. Scaphoid, lunate, triquetrum, and then there will be pisiform in the proximal row. And then you'll be having trapezium, then there will be trapezoid, and then capitate, and then hamate in the distal row. So all the 8 carpal bones are arranged in this manner. After the carpal, you'll be having metacarpal number 1, and then there will be metacarpal number 2, then metacarpal number 3, and then metacarpal number 4, and then finally metacarpal number 5 for the little finger. After the metacarpal, you'll be actually having your phalanges here, and every digit will be having like 3 phalanges here: proximal, intermediate, and distal phalange, and the thumb will just have only 2 phalanges here, sir. Okay, this is just a schematic diagram of all the bones present in your hand here, sir. Bones of the hand, fine. Now, origin, you don't have to worry about the origin here, sir. Why? Because all your thenar muscles will be originating from the scaphoid and the trapezium here. So you don't have to worry about the minor details like anterior surface of the tubercle trapezium. They will never ask you. Just remember, in short, the thenar muscles are going to begin from the scaphoid trapezium. Hypothenar muscles are going to begin from your pisiform and the hamate here. Fine. Origin is not that much important. The important thing here is the insertion. Okay. Now, how to remember the insertion? Let me tell you here. The first thing is that in the thenar muscles, I told you there will be flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. Fine. Out of these 3 muscles, keep one trick in your mind that abductor muscle should be the outermost one. The muscle which is helping in abduction of the thumb, moving the thumb away like this here, abduction, that abductor should be the outermost one. Fine. So if you are able to see in the diagram, any muscle which is the outermost one here, that should be definitely your abductor. And one thing here, all these muscles are like, abductor pollicis brevis. What is the meaning of brevis? Brevis means short. They're not very long muscles. They're short. So if they're short muscle, definitely they are not going to go beyond the proximal phalanx. So they are going to get inserted onto the proximal phalanx. Then just inside this one, you'll be having the flexor here. So this one here, my dear friends, will be the abductor pollicis brevis. And this one here will be the flexor pollicis brevis. Exactly in the same manner on the opposite side here also. Abductor digiti minimi and then there will be flexor digiti minimi. So the outer one will be the abductor digiti minimi, and just inside that will be flexor digiti minimi. Perfect. They are inserted onto the proximal phalanx. Fine. Now comes the third one, that is opponents. See, you try to think like this here. Opponents will be helping in opposition. The finger is trying to come here. We are going to oppose this one, sir. It is helping in opposition. So when it is helping in opposition, it's not just the thumb moving here. It's actually the metacarpal moving here. We are actually moving like this here. Okay. So therefore, opponents should be acting on the metacarpal. So opponent's pollicis will be inserted onto the first metacarpal here, and that too on the shaft of that one, sir. Same thing here also, the opponents will be inserted onto the metacarpal on the shaft. Okay, so this here will be the opponent's pollicis. This here will be the opponent's digiti minimi. Please remember that the opponent's muscle is getting attached onto the metacarpal and on the shaft of this one here, sir, shaft. So once in your exam, this image was given, and in the image, they have just put an arrow mark over here, and you have to identify which muscle is getting inserted here onto the shaft here. And that one will be your opponent's pollicis, sir. Perfect. Then we'll come to the last and final one here, that is adductor pollicis. Adductor pollicis will be helping in what? It is helping in, yes, if this is your thumb here, moving away from the fingers is abduction, moving towards the finger will be adduction. So adductor pollicis, the fibers are going to begin from the third metacarpal here. And along with that, some more fibers are also coming from the, yes, the capitate here. So this is how the fibers of adductor pollicis will be coming from this side. And of course, it is going to make sense here. When these muscle fibers are going to contract, it is going to help in adduction of the thumb. So this one is adductor pollicis. And I told you clearly, yes, it is supplied by ulnar nerve, sir. Ulnar nerve is supplying to this one here, not the median nerve. Then on the other side, the last and final, the fourth one which is remaining here is palmaris brevis. The name that we have written here, the fourth one remaining here is palmaris brevis. But remember, we don't have to learn the attachment of palmaris brevis. Why? Because palmaris brevis muscle is just a subcutaneous muscle present beneath the skin here. It is just a subcutaneous muscle. That's all. So in this manner, we are also done with the attachment of thenar and hypothenar. That was my main intention to revise here. Otherwise, names of this thenar and hypothenar muscle at this level, you might be already knowing this one, and even the nerve supply you might be knowing, so learn the attachments here. Now, one more thing, recently in the exam, they have put one arrow mark here near the base of the first metacarpal. Near the base of the first metacarpal. Okay. And remember there, the muscle that is getting inserted is abductor pollicis longus muscle. Abductor pollicis longus muscle. Okay. Please be very, very careful in the exam when they're giving the arrow mark, whether it is at the shaft or at the base. If they are asking you what is the muscle getting inserted onto the shaft here, that is opponent's pollicis, onto the base here, that will be abductor pollicis longus. Okay. Now, after completing about the thenar and hypothenar muscle, welcome to another important one, the lumbricals. First of all, how to identify the lumbricals? Remember, all the lumbricals will be actually originating from the tendon of flexor digitorum profundus, FDP tendon. FDP tendon. So the moment you see the muscle is originating from this FDP tendon, yes sir, it is your lumbricals. Insertion, of course, what is going to happen? The lumbrical will be actually moving from here, taking a turn and then going back. Okay. So therefore, it is getting inserted onto the common extensor tendon. Common extensor tendon here. Okay. Now, so origin will be from the FDP tendon. FDP tendon here. And the insertion will be onto the common extensor tendon. Next, after that, nerve supply. See, you are actually having 4 lumbrical. This is lumbrical number 1, then 2, then 3, and the 4. The first thing that you have to appreciate here is the first and the second lumbrical is going to originate from only one tendon. Only one tendon. That is why it is unipinnate. Whereas the third and fourth lumbrical is going to originate from the 2 adjacent tendons. That is why it is bipinnate. The first thing to learn. And second thing, I told you, all the muscles in hand, they will be supplied by ulnar nerve and the median nerve. Ulnar nerve is coming from the medial side, so it is supplying to third and fourth lumbrical. Whereas median nerve is coming from the medial side, it is supplying to first and second lumbrical. Okay. So remember, L1 and L2, the first and second lumbrical, these two are unipinnate. And these two will be supplied by median nerve. Whereas L3 and L4, these two will be bipinnate. Okay. And they will be supplied by ulnar nerves. So third and fourth lumbrical will be bipinnate, supplied by ulnar nerve. And first and second lumbrical will be unipinnate, supplied by median nerves. Now, what is the action done by lumbrical? Please remember L for lumbrical, and remember, make your hand like L shape here like this, in this manner. So once you make your hand like this L shape here, you can clearly see at the metacarpophalangeal joint, there will be flexion, and at the interphalangeal joint, there will be extension. So lumbricals are going to help in flexion at metacarpophalangeal joint, and they will be helping in extension at interphalangeal joints. Now, after discussing about the lumbricals here, sir, let us revise about the interossei. So there will be 4 palmar interossei and there will be 4 dorsal interossei. Now, the moment you look at this diagram here, you are able to see, yes, of course, the muscles are present between the bones itself. These muscles are actually present between the bones itself. So both of them are interossei. How to identify which is palmar and which is dorsal? So please look at this diagram here. In the very first diagram, you are able to see these muscles are unipinnate. Whichever is unipinnate, that is palmar interossei. And whichever muscles are bipinnate, they will be dorsal interossei. Okay. So the muscles which are originating only from one bone, they are unipinnate, and originating from 2 adjacent bones, that is bipinnate. Bipinnate one will be dorsal interossei. So therefore, in this diagram, this one is palmar interossei. Okay. And this one here will be the dorsal interossei. How to identify the palmar interossei will be unipinnate. Okay. Whereas the dorsal interossei, remember, it will be bipinnate. Sir. Now, when it comes to nerve supply, remember all the interossei are supplied by ulnar nerve, sir. All the interossei will be supplied by ulnar nerve. There is no exception in this one. So the moment you listen the word interossei, answer it is ulnar nerve. Then after that, what is the action, sir? Remember, all the palmar interossei are going to bring the fingers closer to your middle finger. And middle finger is acting like a central axis here, sir. Okay. So middle finger is like a central axis. All the fingers are coming closer to that. So therefore, remember, palmar interossei will be helping in adduction of the fingers. And we are going to remember with the mnemonic as pad. Similarly, what is the action done by dorsal interossei? Dorsal interossei will be helping in taking the fingers away from here. So therefore, it is actually helping in abduction. And we are going to remember with the mnemonic as dab. Dorsal interossei will be helping in abduction. So palmar interossei will be helping in adduction, pad. Dorsal interossei will be helping in abduction, that is dab. Now, after learning this one, nowadays what is the question that they're asking in the exam is, look at the middle finger here, sir. Do you have any palmar interossei on the middle finger? On the middle finger, is there any attachment of palmar interossei? No. Middle finger does not have any palmar interossei. Okay. And it does not require also. Why? Because palmar interossei is helping in what? It is helping in adduction, bringing all the fingers closer to the middle finger. So that itself is acting like an axis for that one. So do you have to do any adduction for the middle finger? Absolutely no. That is the reason why middle finger does not have any palmar interossei. But yes, middle finger do have dorsal interossei. Okay, now that too there will be 2 dorsal interossei. Okay, you can see the attachment of this one. It will be attached on both the sides here. Whereas the little finger and the thumb will not have any dorsal interossei inserted onto that one. So let us just tell all the statements neat and clearly here. Middle finger has 2 dorsal interossei. Middle finger does not have any palmar interossei. And remember, little finger and the thumb, they will be not having any dorsal interossei. I hope it is crystal clear now. After this, how to test them? Of course, all the interossei are supplied by ulnar nerve only. But how are we going to test them? Remember, palmar interossei, they'll be helping in adduction. So that will be tested with the help of card test. So we are going to give the card in the middle of the fingers and ask the patient to hold that one. Yes, if he is able to hold that one, yes sir, interosseous working well, ulnar nerve is well. Now similarly for the dorsal interosseous, what is the test that we have? We have Egawa test. Egawa test will ask the person to keep the hand like this here and ask to move the middle finger on either side. If he is able to move the middle finger here, that means dorsal interosseous is working properly. Yes sir, Egawa test perfect, ulnar nerve is perfect here. Okay. And by this, we are quickly done with the revision of all the information regarding the muscles of hand. So in total, how many muscles of hand do you have, sir? Totally 20 muscles in hand. 4 thenar, 4 hypothenar, 4 lumbrical, 4 palmar interosseous, 4 dorsal interosseous. I told you every point regarding that one, and we have discussed all the previous year questions also. Now, after discussing about the muscles of hand, let us see the sensory supply of the hand, sir. Now, in this diagram, we are able to see here, this is palmar surface. Now, on the palmar surface, medial 1.5 digit, this skin will be taken care by ulnar nerve, sir. Whereas the lateral 3.5 digit, this skin will be supplied by median nerve, sir. That will be supplied by median nerve. So, it's very simple on the palmar surface. Now, let us see on the dorsum of the hand, sir. Dorsal surface of the hand. Now on the dorsal surface, again the same thing, sir. Medial 1.5 digit is again supplied by ulnar nerve only. That means on the palmar surface also it is 1.5 digit, little finger and half of the ring finger. And on the dorsal surface also 1.5 digit, little finger and half of the ring finger. Ulnar nerve will be taking care of that one. It's very simple. Now, on the dorsal surface, the lateral 3.5 digits, only distal phalanges. So 1, 2, 3.5. Only distal phalanges here will be again supplied by median nerve. And the remaining everything will be taken care by the radial nerve. So this will be supplied by median nerve and whatever remaining here will be taken care by the radial nerve. Perfect. So that is about the sensory supply of the hand, and it is very simple, not that difficult here, sir. Now, after discussing about all these muscles of the hand and the sensory supply of the hand, now comes the real topic here, sir, from where you can definitely expect the question. So we are going to discuss about the ulnar nerve and the median nerve and the radial nerve one by one in detail. Along with that, I'll tell you all the injuries also, guys. So please pay attention to this part here. This is going to give you marks in the exam. Okay. So welcome here to the ulnar nerve first of all. Now ulnar nerve, it's actually originating from where, sir? It's a branch of medial cord. Ulnar nerve is a branch of medial cord of the brachial plexus. I hope you remember the mnemonic for the medial cord. In the brachial plexus, the mnemonic for the medial cord, M4U, U stands for the ulnar nerve, sir. And apart from that, what is the root value of the ulnar nerve, sir? It is C7, C8 and T1. Please remember it's an exception. In the medial cord, all the nerves will have the root value C8 and T1. Ulnar nerve will also get an additional contribution from C7. So it is C7, C8 and T1. Please remember that, already asked in the exam. Okay. Now let us see the entire course as well as the supply of the ulnar nerve. For example, if this one here will be the lower end of the humerus here. And in this lower end of the humerus, this is lateral epicondyle here and this one is medial epicondyle. Okay. Ulnar nerve is first going to begin from the medial cord. And after beginning from the medial cord, ulnar nerve is going through the arm. And then it is going to enter the forearm behind the medial epicondyle. That's extremely important. It is being asked in the exam many times. Okay. So in the arm, from the arm, ulnar nerve will enter into the forearm behind the medial epicondyle. The first point is very much important. Many times they have asking in the exam, sir. And how it is going to enter into the forearm? By passing between the two heads of a muscle here. Okay. So it is going to enter here between two heads of flexor carpi ulnaris muscle. So ulnar nerve is going to enter by passing between the two heads of flexor carpi ulnaris. Now why I am stressing a lot here? Why? Because, yes, my dear friends, remember, Between these two heads only you'll be able to find a tunnel here, and that tunnel is known as the cubital tunnel. Cubital tunnel. Okay. So sometimes what is going to happen, ulnar nerve is getting compressed in this cubital tunnel, that is known as the cubital tunnel syndrome. What is that syndrome? Cubital tunnel syndrome. Okay. Now in the arm, does ulnar nerve has any supply in the arm? So in arm, ulnar nerve is not supplying to any muscles in the arm. We know from our golden rule that I taught you in the main videos that ulnar nerve will not be supplying to any muscle in the arm here, sir. Why? Because all the muscles in the anterior compartment of the arm will be supplied by musculocutaneous nerve. All the muscles in the posterior compartment of the arm will be supplied by radial nerve. Ulnar nerve is not supplying to any muscle in the arm. Okay, now let's go ahead into the forearm. So in the forearm, ulnar nerve will be supplying to which muscles? Remember, first of all, you always go in step-by-step manner, sir. In the forearm, ulnar nerve will be supplying to the anterior compartment of the forearm. Posterior compartment is taken care by radial nerve. Anterior compartment will be supplied by ulnar nerve. But not only ulnar nerve here, two nerves are going to supply ulnar as well as median nerve. Out of these two nerves, remember, ulnar nerve will be supplying to medial 1.5 muscle. How many muscles? 1.5 muscle. And one muscle already I told you here, flexor carpi ulnaris, and one more here will be the flexor digitorum profundus. Flexor digitorum profundus. But I told you very clearly it's supplying to only 1.5. So remember, one complete muscle is flexor carpi ulnaris and half of FDP. And that to which half of FDP? Obviously the medial half of FDP. Medial half of flexor digitorum profundus. That's all. Then common sense, what about the lateral half? Lateral half will be supplied by median nerve. Why? Because all the muscles should be supplied by ulnar and median. If ulnar is not supplying, obviously it is supplied by median nerve there. Understanding? So can I call this muscle as a composite muscle? Of course. What is the definition for a composite muscle or a hybrid muscle? So remember, a composite or a hybrid muscle means the muscle supplied by two nerves. And one of the example here is your FDP. That's all in the forearm. Now from the forearm, the ulnar nerve is now going to enter into the hand. And here there is one important landmark. How it is going to enter into the hand? Remember, ulnar nerve will be actually going or entering from the forearm into the hand by crossing through the flexor retinaculum over here. Okay, our carpal bones are actually covered by a fibrous band-like structure known as flexor retinaculum. Now here you need to decide, for example, if this is the flexor retinaculum over here, if ulnar nerve is coming from the forearm, so you need to decide, is it going above the flexor retinaculum or below the flexor retinaculum? So remember, ulnar nerve will be going above the flexor retinaculum, superficial to the flexor retinaculum. Okay. So for example, if this one here will be the flexor retinaculum. Something. Just imagine there's like flexor retinaculum here. So remember, ulnar nerve will be going superficial to this flexor retinaculum here, sir. Ulnar nerve will be passing superficial to this flexor retinaculum here. Okay. And above this flexor retinaculum also it is going through a canal, and that canal here will be known as the Guyon's canal. Guyon's canal. Already this question is directly given in the exam here, sir. So remember, it is passing superficial to flexor retinaculum, sir. Through a canal, that canal will be Guyon's canal. And sometimes the ulnar nerve is even compressed here in the Guyon's canal, leading to Guyon's canal syndrome. So after entering from the forearm into the hand, in the hand, the ulnar nerve will again divide into two branches here. One is the superficial branch and another one will be the deep branch. So this is superficial branch and this one here will be the deep branch. Okay. Now in this, remember, superficial branch is the one which will be supplying to, number one, palmaris brevis muscle. I told you clearly, palmaris brevis muscle belongs to hypothenar group. And this palmaris brevis muscle is just a subcutaneous muscle, just below the skin. So that is supplied along with the skin itself. And we know very well, ulnar nerve is also supplying to the skin of medial 1.5. I'm writing here as hand. The skin of medial 1.5, hand I'm writing here. Why? Because it is supplying to 1.5 skin on the palmar surface as well as on the dorsal surface here, sir. So this complete 1.5 hand here will be taken care by superficial branch of the ulnar nerve. Now what about the deep branch? So whatever remaining muscles which are supplied in the hand, yes, by ulnar nerve will be taken care by which branch, sir? Deep branch. So deep branch will be supplying to all the remaining hypothenar muscles. Okay. Deep branch is also supplying to the lumbrical number 3 and lumbrical number 4. And then deep branch will also supply to all the interossei, the 4 palmar and the 4 dorsal interossei. Then it is going on the other side. On the other side, it will be supplying to adductor pollicis muscle. So in the thenar group, we wrote the adductor pollicis muscle. And ulnar nerve will actually go and end in this adductor pollicis muscle. That is why it is also referred to as the graveyard of ulnar nerve. So which muscle is the graveyard of ulnar nerve? That is adductor pollicis, because it is just going and ending there, sir. So this is the supply of ulnar nerve in the hand. I hope now you are understanding why I told you about the muscles of the hand in the very beginning there. So now we can easily recall, or you can actually easily remember. So this is the story regarding your ulnar nerve here, sir. Fine. So ulnar nerve is actually going to originate from which cord? The medial cord of the brachial plexus. And after originating from the medial cord of the brachial plexus, remember the root value, it is also getting the contribution from C7 in the arm. It is not supplying to any muscles in the arm. We know from our golden rule, anterior compartment is supplied by musculocutaneous, posterior compartment is taken care by radial nerve. Then the ulnar nerve is going to go behind the medial epicondyle, enter the forearm by passing between the 2 heads of flexor carpi ulnaris. And there itself you'll be able to find the cubital tunnel. If it is compressed over there, it will lead to cubital tunnel syndrome. Okay. Then in the forearm, it is supplied to medial 1.5 muscle. One complete muscle will be the flexor carpi ulnaris. Other half will be the flexor digitorum profundus, the medial half of that. Now the ulnar nerve will enter from the forearm into the hand, superficial to flexor tenaculum. And there also you have a canal. That canal is known as the Guyon's canal. After entering the hand, ulnar nerve will divide to the superficial branch and the deep branch. Out of these two, the superficial branch is the one supplying to the skin on the medial 1.5 hand here, along with the palmaris brevis muscle. And the deep branch will be supplying to all the remaining muscles here. Which remaining muscles? The remaining hypothenar, the 3rd and 4th lumbrical, and then the 4 palmar interossei, the 4 dorsal interossei, and then on the other side, the adductor pollicis. And finally, it is going and ending in adductor pollicis. That is why it is known as the graveyard of ulnar nerve. Graveyard of ulnar nerve, sir. Perfectly done. That's a complete revision of the ulnar nerve here, sir. Okay. Now, once you are done with this entire topic as well as the revision here, let's see the injuries right now, for which I'm actually teaching you here in detail. Okay. Now, the injuries of ulnar nerve, we can actually divide into 2 categories here. That is higher injuries and the lower injuries. Okay. So, if the ulnar nerve is involved here near the medial epicondyle, if there is a medial epicondyle fracture, or suppose if there is a cubital tunnel syndrome here, so ulnar nerve will be involved here. And this is included under the higher injuries of the ulnar nerve. Or if the ulnar nerve is injured near the wrist here, that is in Guyon's canal syndrome and all, that is actually the lower injuries of the ulnar nerve. So we can divide the ulnar nerve injuries into 2 categories here, higher or lower. Now, as a doctor, the first thing that you have to remember is, whatever, if ulnar nerve is injured here or here, whatever, sir, remember all these 15 muscles, out of the 20 muscles, remember, ulnar nerve is supplying to almost 15 muscles. All those muscles will be involved. And my hand is going to become something like this here. And that is actually known as the claw hand. Is it complete or partial? Partial claw hand. So when there is ulnar nerve injury, there will be partial claw hand. Now if this patient comes to you, okay, how are you going to differentiate the higher lesion from the lower lesion? Higher lesion and the lower lesion, how are we going to differentiate that one? So remember, if there is actually a lower lesion of the ulnar nerve, if there is a lower lesion, Of course, there will be partial claw hand, but the clawing will be more. The clawing will be more here. Why the clawing will be more? If the injury is here, only the muscles distal to that are gone. What about the proximal ones? In the forearm, they're still working. That means FDP and then flexor carpi ulnaris and FDP, that 1.5 muscle I told you, they're still intact, they're working. Now, because this FDP is working here, these two tendons, when they contract, the clawing will be more. Now, if there is a higher lesion, in the higher lesion, even that FDP is also gone there. Even these muscles are also gone in the hand there. So therefore, yes, there will be partial claw hand, but the clawing will be less. Why? Because this time even FDP is also gone. So therefore, when there is a lower injury or lower lesion of the ulnar nerve, the clawing is more. And when there is a higher lesion of the ulnar nerve, the clawing will be less. Okay. So therefore, my dear friends, remember this condition is known as ulnar paradox. It is known as what? Ulnar paradox. Higher injury, yes, the clawing will be less, but lower the injury, the clawing will be more. Understanding? This condition is known as ulnar paradox. Perfectly done. And apart from this clinical condition here, I told you remaining all the points that they are asking in the exam. Ulnar nerve, yes, of course. What is the nerve passing behind the medial epicondyle? Many a times, image-based question is given here. Ulnar nerve is passing behind the medial epicondyle. What is the nerve involved in cubital tunnel syndrome? Not carpal, cubital tunnel syndrome, ulnar nerve. Guyon's canal, ulnar nerve. Okay, all these questions are asked in the exam. I hope this is easier for you now. Now, after learning about the ulnar nerve, let us learn about the median nerve right now, sir. First, let us see the origin of the median nerve. Median nerve actually has got dual origin. It is going to originate from the lateral cord of the brachial plexus as well as the medial cord of the brachial plexus. Okay. So median nerve actually has got dual origin. It is going to originate from lateral cord as well as the medial cord of the brachial plexus. And because of the lateral cord, its root value will be C5, C6 and C7. And because of the medial cord, it will be having C8 and T1. So in short, the median nerve has got all the root values. Okay. So because of the lateral cord, C5, C6, C7. And because of the medial cord, it will be C8 and T1. So perfectly done. Now again the same thing, after learning the origin and the root value, let us see the entire course and supply of the median nerve. Okay. Suppose if this one here is your lower end of the humerus, and this lower end of the humerus will be having lateral epicondyle and the medial epicondyle. Okay. Now the median nerve will be entering from the arm into the forearm here. Will it supply to any muscles in the arm? Remember, median nerve does not supply to any muscle in arm. You know from our golden rule that musculocutaneous nerve here and the radial nerve here. So median nerve is not supplying to any muscle in arm. Now from the arm, it is going to enter into the forearm by passing between the two heads of pronator teres. Between two heads of pronator teres muscle. And sometimes what is going to happen, if the median nerve is compressed here between the two heads of the pronator teres, that syndrome is known as pronator teres syndrome. What is the syndrome? Pronator teres syndrome. Now the median nerve will actually give rise to a branch here. And this branch here will be the AIN, anterior interosseous nerve. Anterior interosseous nerve. Yeah. Now, after entering into the forearm, we know very well in the forearm, median nerve will be supplying to how many muscles? Remember, in the forearm, it is supplying to all muscles of anterior compartment. Except which one? Except the medial 1.5 muscle, which is taken care by ulnar nerve. So in the forearm, median nerve is supplying to all the muscles in the anterior compartment of the forearm, except for the medial 1.5 muscle. Why? Because that is taken care by ulnar nerve. In that also, remember my dear friends, the median nerve and the anterior interosseous nerve, the branch of the median nerve. Remember, out of these two, median nerve will be actually supplying to the superficial flexors. It is supplying to the superficial flexors, whereas AIN will be supplying to the deep flexors. Now, what is the meaning of this one? Remember, in the anterior compartment of the forearm, all these muscles are actually helping in flexion. So they'll be like flexors. And all these muscles are arranged in the two layers, superficial layer and the deep layer. So therefore, my dear friends, remember, the superficial flexors will be supplied by the median nerve as such, whereas the deep flexors will be supplied by the AIN, that is your anterior interosseous nerve cell. Perfect. Now, after this one, again the same thing here. You'll be having your flexor retinaculum here. Now, median nerve is the one which is going to pass beneath the flexor retinaculum. It is going deep to flexor retinaculum. And what do you have deep to flexor retinaculum here? There will be a tunnel, and that tunnel will be carpal tunnel, sir. So therefore, it is going deep to flexor retinaculum, and this tunnel here will be the carpal tunnel. That is the reason why the nerve which will be, yes, involved in the carpal tunnel syndrome will be the median nerve, sir. Now, after entering into the hand here, yes, median nerve, again it is going to divide into two branches here. And we know very well, in the hand we have got like 20 muscles. Majority of them will be taken care by ulnar nerve, but the remaining 5 muscles will be supplied by the median nerve. So median nerve is supplying to which 5 muscles over here? It is supplying to thenar muscles. But except which thenar, sir? Except the adductor pollicis. So median nerve is supplying to all the thenar muscle except adductor pollicis. And then along with that, it is also supplying to the lumbrical number 1 and the lumbrical number 2. So median nerve is supplied to the thenar muscle except the adductor pollicis and then the lumbrical number 1 and 2. Fine. That is easy. Everyone knows that. Now the concept that I want to teach here, listen carefully. Now it is actually giving one of the branch here. This branch is known as the digital branch. It will be supplying to the skin over the digits. Now the most important point here is that median nerve is going beneath the or deep to the flexor retinaculum. Fine. But just before going to deep to the flexor retinaculum, median nerve will actually give a branch, and that branch is going superficial to the flexor retinaculum. And this here will be known as the palmar cutaneous branch. Palmar cutaneous branch. Let me tell you more detail here. For example, if this is flexor retinaculum here, sir, and this is the median nerve. Median nerve is going below the flexor retinaculum. Fine. It is going below the flexor retinaculum. Fine. But just before entering into the flexor retinaculum, below that one, into the carpal tunnel, it will give a branch, and that branch is going superficial to the flexor retinaculum. And that is palmar cutaneous branch, sir. Okay. So therefore, why I'm telling you in so much of depth here? Why? Because if median nerve is involved in carpal tunnel syndrome, here, if median nerve is getting compressed here, will this palmar cutaneous branch is also involved? No, that will be spared. That is the reason why I'm trying to tell you this concept very clearly. Remember, if median nerve is involved in the carpal tunnel syndrome, remember my dear friends, palmar cutaneous branch will not be involved. It is given just before entering into the carpal tunnel. Fine. Now, once you have learned about these two branches here, what about the supply? So what is so much importance about this one? For example, little finger, ring finger, middle finger, index finger, and this one here will be your thumb. For example, manlo, this is like palmar surface. Now, in the palmar surface, I told you very clearly the 3.5 digits. Lateral 3.5 digits is supplied by median nerve. So the thumb, index finger, middle finger, and half of the ring finger will be supplied by median nerve. Fine. Now in that also remember, digital branch will be supplied to the skin covering the lateral 3.5 digits. So the thumb, index finger, middle finger, and half of the ring finger. That is about the digital branch. Yeah. Whereas the palmar cutaneous branch will be supplied to the lateral 3.5 palm here, sir. I hope it is very clear now. So digital branch is supplying to the skin over the digits here, whereas the lateral 3.5 palm here, palm will be taken care by palmar cutaneous branch, sir. I hope this concept is like crystal clear now. So that is about all the supply by the median nerve in the hand. So we are done with the arm and the forearm and the hand. So let us just summarize as we have done for ulnar nerve also. So first of all, remember, median nerve actually has got dual origins. It will be originating from the lateral cord as well as the medial cord. Okay, that is the reason why it is having all the root values, C5, C6, C7 due to the lateral cord, and then C8 and T1 due to the medial cord. Origin and the root value completed. Now the median nerve is passing from the arm. In the arm, will it supply to any muscle in the arm? No. Median nerve is not supplying to any muscle in the arm. Why? Because we remember from our golden rule, anterior compartment is supplied by musculocutaneous nerve, posterior compartment is supplied by radial nerve. Now this median nerve will enter into the forearm, from the arm into the forearm, by passing between the two heads of pronator teres. So sometimes the median nerve will be getting compressed there, therefore it is lead to pronator teres syndrome. Now after entering into the forearm, yes, your median nerve is actually giving rise to a branch here. That branch will be the AIN, anterior interosseous nerve. So remember, they'll be supplying to all the muscles in the forearm except the medial 1.5 muscle. That medial 1.5 is supplied by ulnar nerve. Okay. So anterior interosseous nerve is supplying to the deep flexors, and median nerve as such is supplying to superficial flexors. Now that median nerve is going to pass deep to flexor retinaculum, that is in carpal tunnel, and enter the hand. In the hand, it will give rise to muscular branches to the muscle. We know the muscle very well. It will be supplying to the thenar muscle except adductor pollicis, and then lumbrical number 1 and 2. But the most important thing is learning about the cutaneous supply. Digital branch will be supplying to the lateral 3.5 digit, whereas a palmar cutaneous branch will be supplying to the lateral 3.5 palm. But remember, palmar cutaneous branch is given just before entering into the carpal tunnel. Understanding? So by this, we have revised the entire median nerve in detail here. And now let's see the injuries in the median nerve. And again, my dear friends, we are going to learn in the same manner. We are going to divide the injuries of the median nerve into like higher lesion and the lower lesion. Higher lesion example here, very simple, my dear friends. The median nerve can be involved in pronator teres syndrome here. It can be injured here, you know, and even the supracondylar fracture also, the median nerve will be involved. But in the supracondylar fracture, remember, yes, the answer AIN, anterior interosseous nerve, will be more better when compared to the median nerve. Keep that in mind. Whatever, it can be involved in the higher lesion here, or it can be involved in the lower lesion. Lower lesion, the best example, carpal tunnel syndrome. Now, if median nerve is injured, what is going to happen? The first thing is, whenever the median nerve is getting injured, definitely what is going to happen, sir, your thenar muscles will be involved. So therefore, there will be atrophy of the thenar eminence here. And apart from that, remember, all the thenar muscles are gone except which one? Adductor pollicis. Why? Because adductor pollicis will be supplied by ulnar nerve. That is the reason why, remember, all the thenar are gone, but adductor pollicis is still working. That is the reason why the thumb will be no more in abducted position. The thumb will come in adducted position, and that is present along with the plane of the fingers. That is the reason why, my dear doctors, remember, this kind of thumb here is known as the ape thumb. It is not the feature of human beings like you and me. It is the feature of apes. Ape thumb deformity will occur. Number one. So remember, whenever there is a median nerve injury, there will be ape thumb deformity. But now how are we going to differentiate the higher lesion from the lower lesion? Let's see one by one. Now in the higher lesion, suppose if the median nerve is injured here, in the higher lesion, then what is going to happen? All these forearm muscles are also gone, which will include your FDP, FDS and all. If these muscles are also gone, now what is going to happen? You ask the patient to make a fist. Right now, you and me, we are able to make a complete fist here like this. Okay. But my dear friends, remember, if the higher lesion, these muscles are also gone, then you ask the patient to make a fist. Only this side of the hand will be folded, but this will not be folded here, because all these muscles are also gone here. So that is the reason why it is known as the pointing index. Okay. So what are we able to see here in the higher lesion? We are able to see the pointing index, as well as we are also able to see the ape thumb deformity. Two things. Then what about the sensory loss? Of course, all the nerves are gone. Even the palmar cutaneous is also gone, as well as the digital branch is also gone. So there will be sensory loss in the lateral 3.5 hand, complete palmar aspect, as well as the digits also. So all these three things you have to remember here. So in the median nerve injury in the higher lesion, remember, there will be ape thumb deformity. Yes. There will be pointing index Yes, as well as there will be complete sensory loss. Now let us see the lower lesion, that is your carpal tunnel syndrome here. Now when there is carpal tunnel syndrome, lower lesion of the median nerve injury here, then what is going to happen here? Will you be able to see the ape thumb deformity? Of course, ape thumb deformity will be there because the thenar muscles are involved here. Fine. But will you be able to see the pointing index in this one? No, pointing index cannot be seen in this one. Why? Because already this long flexors are still working. They are spared because the injury is taking place here in the lower lesion. So there will be no pointing index. What about the sensory loss? That is interesting here. When there is carpal tunnel syndrome, palmar cutaneous branch is actually spared because it is given before entering into the carpal tunnel only. So palmar cutaneous branch, because it is spared there, therefore, yes, there will be no sensory loss in the palmar aspect. The sensory loss will be only in the digits, lateral 3.5 digits. Now let us revise this neat and clearly. If there is a lower lesion of the median nerve, that means carpal tunnel syndrome. So in the carpal tunnel syndrome, will you be able to see the ape thumb deformity? Yes. Will there be pointing index? No, the pointing index will not be there. But what about the sensory loss? The sensory loss will be only in the lateral 3.5 digits, not the palmar aspect. Why? Because the palmar cutaneous nerve is actually spared here. Okay, that is how you're going to differentiate the higher lesion from the lower lesion in the median nerve injury cell. Perfectly done. Now, after completing about the median nerve, let's go ahead with another very important nerve, that is your radial nerve here. Now, whenever you're learning about any nerve, first thing is the origin and the root value. A radial nerve is going to originate from the posterior cord of brachial plexus. And the mnemonic for the posterior cord, we know very well, it is lunar. In lunar, R stands for radial nerve. And radial nerve has got all the root values, C5, C6, C7, C8 and T1. It is the largest branch. Okay. Now, before drawing the diagram about the radial nerve here, okay, let's first of all try to apply that on our body here. So, the radial nerve coming from the axilla here, it's actually a branch of the posterior cord. The posterior cord will give the radial nerve in the axilla here. Now, from the axilla, the radial nerve will enter into the arm. In the arm, the radial nerve is going to go behind the humerus bone here. And behind the shaft of the humerus, there is a groove known as radial groove, also known as the spiral groove. Now, in the spiral groove, it is going to take a turn here like this. And after taking a turn, radial nerve will come here on the lateral aspect. Then here, the radial nerve will divide into superficial branch and the deep branch. Superficial branch is going superficially here and supplying to the skin over dorsum of the hand. Whereas the deep branch is going to pierce through the muscle. Which muscle? Supinator muscle. After piercing the supinator muscle, the deep branch is going behind in the posterior compartment. Now it is known as PIN, posterior interosseous nerve. And that is going to supply to all the muscles in the posterior compartment of the forearm. That is, all your extensor muscles are supplied by the PIN only. I hope it is very clear. Now exactly whatever I told you here, let's draw this diagram over here, sir. Okay. So again the same thing, imagine here this one will be the lower end of the humerus here, lateral epicondyle, and this one here will be the medial epicondyle. Radial nerve is actually coming from the axilla. Now from the axilla, first the radial nerve is going to go behind the shaft of the humerus, and then after taking a turn in the spiral groove, it is coming towards the lateral side here. Right in front of the lateral epicondyle, it's again dividing into the superficial branch and the deep branch. Okay, superficial branch and the deep branch. Now first let us see in axilla. It will be supplying to which muscles? We all know from our golden rule that radial nerve will be supplying to posterior compartment of the arm and posterior compartment of the forearm. In the posterior compartment of the arm, you'll be having triceps. There is a long head, medial head and the lateral head of the triceps. Okay, and in the posterior compartment of the forearm, you'll be having your extensors. Now in axilla, from the axilla itself, it will be supplying to long head of triceps, and then it is also supplying to a part of medial head of triceps. The long head of triceps and the medial head of triceps. Then in the spiral groove now, sirs. In spiral groove, remember, it will be again giving like two branches over here, and one of the branch will be supplying to the remaining medial head of triceps, and then the lateral head of triceps here. I hope I'm not confusing you here, sir. It's very simple to remember. From the axilla itself, it will be supplying to the long head and a part of medial head. Now in the spiral groove, it will be supplying to lateral head and the remaining medial head. Then the lateral side of arm. This is very much important. In the lateral side of the arm, here the radial nerve will be supplying to, yes, number one, brachioradialis muscle. Brachioradialis muscle. Number two, it is also supplying to ECRL, extensor carpi radialis longus. Brachioradialis muscle along with extensor carpi radialis longus, ECRL. That is one important one. I'll tell you why. Why? Because from the name itself, you'll understand extensor carpi. It is going and actually inserting into the, yes, carpal side here. Okay, now the extensor carpi radialis longus, towards the radial side, longus, long muscle, and that is the one which is helping in extending the wrist joint. It's a very, very strong extensor at the wrist joint. Based on that, we are going to decide whether it is normal or there is a wrist drop. Okay, I'll tell you about the injuries. Don't worry about that. Now, after this, what is going to happen in the forearm? Yes, radial nerve is going to divide into two branches. One is superficial branch. One is the superficial branch. Another one will be the deep branch. Superficial branch and deep branch. Out of these two, from the name itself, we can understand that superficial branch, it will be supplying to the skin of dorsum of hand. I have already told you that in detail in the diagram also. Okay, the radial nerve superficial branch is going here, supplied to the skin of the dorsum of the hand, except those distal phalanges which are supplied by median nerve. Now deep branch is very much important here. Deep branch is going to pierce through a muscle. So remember, deep branch pierces supinator muscle. And after piercing the supinator muscle, it is actually going in the posterior compartment, and there it is known as your PIN, posterior interosseous nerve. And posterior interosseous nerve will be supplying to all the muscles in posterior compartment of forearm. And which muscles do you have in the posterior compartment of forearm? You'll be having your extensors. You have your extensors. So that is about your arm and the forearm here. And of course, thank God, we don't have any muscles in the posterior compartment of the hand there. So nothing like that. So by this, we had actually done with the radial nerve. Let us now revise this again neat and clearly, sir, once completely. Radial nerve is going to originate from where? The posterior cord of the brachial plexus. The mnemonic is actually lunar. R stands for the radial nerve. What is the root value? It is the largest branch. It is having all the root values, sir. C5, C6, C7, C8 and T1. Okay. Now the radial nerve is going to begin in the axilla, and from the axilla it is giving rise to two branches there. One is to the long head of triceps and the medial head. Then from here it is going in the spiral groove here. Obviously it is supplying to lateral head and a remaining part of medial head. Then on the lateral side here it is supplying to brachioradialis and extensor carpi radialis longus. Then it will be dividing into two branches, superficial branch and deep branch. Superficial branch, name itself is telling you, it will be supplied to the skin over dorsum of the hand here. Deep branch is piercing a muscle, supinator, going back and supplying to, is going back and continuing as PIN, posterior interosseous nerve, supplying to all the muscles in the posterior compartment of forearm, which are your extensor muscle. Crystal clear concept here. Now, once you are clear with this one here, let us see the injuries right now. Let us see the injuries right now, sir. Now, in injuries, remember one thing, my dear friends, you have to look at 4 locations here. Number one, what happens if the radial nerve is injured in the axilla? One of the examples for this one will be the crutch palsy. I think you remember in olden days, the handicapped people used to use like long crutches, and those crutches they are using in the axilla here, and that will be applying pressure. And because of that pressure, radial nerve will be damaged. crutch palsy. And sometimes the radial nerve will be injured in the spiral groove. In the spiral groove. And one of the example for that one will be Saturday night palsy. And Saturday night palsy, you know very well, people will be normally drinking on the Saturday nights, okay, evenings. And then after drinking, they're not even going back to their beds and sleeping. They're lying on the chair. And on the chair itself, they'll be just lying with their arm like this here. You know? So because of that, what is going to happen? A radial nerve will be compressed over there in the spiral groove. Saturday night palsy. Number 3, there can be a radial nerve injury here on the lateral aspect of arm here. It can be injured here. That is because of the fractures. And then after that, one more thing is PIN injury to PIN. Okay, now let us see one by one all these injuries. But before telling you about them, I will tell you one important trick here, sir. Whenever you are going to come across a patient suffering with a radial nerve injury, or suppose you are coming across some clinical question in your exam, how you are going to deal with this one. Whenever there is a radial nerve injury, keep like 4 landmarks in your mind, sir. Number 1. What happens if all these triceps muscles are gone? Triceps, when they are normally contracting, they're helping in extension at the elbow joint. When triceps will normally contract, they'll help in extension at the elbow joint. If the triceps are gone, there'll be loss of extension at the elbow joint. Loss of extension, these muscles are gone. So only the anterior compartment muscles are dominant. That is why the hand, so at the elbow, what is going to happen? It will be like flexed elbow. So either you say loss of extension or you say flexed elbow, one and the same thing. First landmark. Second landmark, you have to look for the ECRL. If ECRL, extensor carpi radialis longus muscle, is involved, then what is going to happen? You're not able to extend the wrist. If you're not able to extend the wrist, there will be wrist drop. A wrist drop will occur. ECRL. The third landmark you have to look for is PIN. Okay. If PIN is gone, then what is going to happen? See, PIN will be actually supplying to the muscles in the posterior compartment of the forearm. In the posterior compartment of the forearm, one of the muscle is extensor digitorum, which is going to extend the digits. This is the flexion of the digits here. This is the extension of the digits here. So extensor digitorum. If this PIN is gone, extensor digitorum is gone, then these fingers will drop. Please have a clarity. I'm not telling wrist drop. I'm telling finger drop here. Okay. So we have to look for the PIN. And the fourth landmark that you have to look here is about the superficial branch. Superficial branch will be supplying here on the dorsum of the hand. So if that is involved, if that is gone, obviously there will be loss of sensation. Sensory loss will be there. So whenever you are learning about the radial nerve injury, number 1, look for the triceps, about the extension of elbow. Number 2, look for ECRL, for the wrist drop. And number 3, look for the pin, that for finger drop. And then look for the superficial branch, that is for the sensory loss. Okay. Now let us see all these 4 injuries one by one. Number 1, what happens if the radial nerve is injured in the axilla? I told you the example, crutch palsy. Crutch palsy. Now that is something very worst injury. Why? Because if the radial nerve is injured in the axilla here, yes, entire thing will be affected. So if it is injured in the axilla here, first thing what is going to happen here, all the triceps will be gone. If all the triceps are gone, then the person is not able to extend the elbow. Elbow will be flexed. Done. ECRL gone. That is why there will be wrist drop. There will be wrist drop like this here. Okay. Then PIN is also involved. If PIN is involved, then there will be finger drop. Okay. And then finally, what is going to happen? Even the superficial branch is also involved. That means it will lead to what here? Sensory loss will also be there. So the patient is going to come to you with the upper limb in this manner here. And I hope you have seen many patients like this here. In one of the Hindi movies also you have seen that, there is a movie Lagan. In that you have a person like this with this one. So it is the highest radial nerve injury here in the axilla, and the condition is something like this here. Now welcome to the second thing. If a radial nerve is injured in the spiral groove, then what is going to happen? I told you the example, Saturday night palsy. Now one interesting thing here is that if radial nerve is injured here in the spiral groove here, my dear friends, remember, all the triceps muscles are not involved. All the triceps muscles are not involved. Which muscle will be spared, which is already supplied here, long head as well as the part of medial head. So if all the triceps are not involved here in Saturday night palsy, then what will happen? Will there be loss of extension at the elbow, or will there be weakness of the extension at the elbow? There will be just a weakness. So weakness of extension at the elbow. The remaining things will be as it is. ECRL is gone, there will be wrist drop. PIN is gone, there will be finger drop. and then superficial branch is gone, there will be sensory loss in the dorsum of the hand. Say. Then what happens if the radial nerve is injured here near the lateral aspect of arm, the lateral side of arm here? Will there be any effect on the extension of the arm, extension at the elbow here, sir? No. There is no effect on the extension of the elbow. Now the important thing here, yes, will there be wrist drop? Remember, there will be no wrist drop here. Wrist drop will not be there here. Why? Because if the radial nerve is injured here, then ACRL is also actually spared. If the ACRL is spared here, then there will be no wrist drop. There will be no wrist drop. Okay. Then will there be, finger drop? Yes. Will there be sensory loss? Yes. Perfect. Now welcome to the last and final one, the fourth one. If PIN is injured, then what is going to happen, sir? Everything will be perfect. Only what is going to happen, there will be finger drop. Will there be any problem with the extension at the elbow joint? No problem at all. Will there be wrist drop? No wrist drop. Why? Because ACL is spared there. Will there be sensory loss? There will be no sensory loss because even the superficial branch is also spared this time. So when PIN is gone, only and only there will be finger drop. So therefore, there was a beautiful question given in the NEET PG exam. Only finger drop but no wrist drop. Which nerve will be involved? I repeat again. Only finger drop but no wrist drop. Which nerve will be involved? It should be PIN. Posterior interosseous nerve will be involved. And yes, the sensory supply to the dorsum of the hand is also intact here. So this is the way how you are going to deal with all the radial nerve injuries. Crutch palsy, Sredenius palsy, and then injury to radial nerve in the lateral aspect of the arm, and then finally injury to PIN. I hope it is crystal clear here. And by this, my dear doctors, remember, we are done with all the three important nerves here. That is your ulnar nerve and median nerve and radial nerve. And even though it is like a rapid revision session here, I told you about all these three nerves in detail, the entire course, entire supply, their origin, and yes, injuries at every level. Okay. Why? Because in every exam, they're asking the questions from here. Fine. So please take care about that. Now let us go ahead with the remaining topics quickly here, sir. Brachial plexus. What is the origin of brachial plexus? It is going to originate from the ventral rami of C5, C6, then C7, and then C8, and then T1. Brachial plexus will originate from C5, C6, C7, C8, and T1. C5 and C6 will combine to form upper trunk, and then C8 and T1 will combine to form the lower trunk. And then C7 is the one which will just continue as your middle trunk here. So, So in short, we can say that we are actually having three trunks here. Upper trunk is formed by C5 and C6. Lower trunk is formed by C8 and T1. And the middle trunk is just the continuation of C7. Okay. Now, all these three trunks will give rise to two divisions. So there is anterior division and the posterior division. So upper trunk will give rise to anterior division and the posterior. Middle trunk will give rise to anterior division and the posterior. And then the lower trunk will also give rise to anterior division, and this is posterior here. Now, after this division, what will happen? They will combine together to form cords. The posterior division of upper trunk, middle trunk, and the lower trunk will combine together to form posterior cord. Perfect. And then the anterior division of upper trunk and the middle trunk will combine to form lateral cord. And finally, the anterior division of lower trunk will continue as your medial cord. Oh. So how many cords do we have, sir? There is a posterior cord, then the lateral cord and medial cord, sir. Perfect. And all these cords are going to give rise to branches. Lateral cord will give rise to three branches, and we remember with the mnemonic as LML. L for lateral pectoral nerve, M for musculocutaneous nerve, and one more L stands for the lateral root of median nerve. Medial cord will give rise to 5 branches, and we remember with the mnemonic as M4U. M for medial pectoral nerve, and then one more M stands for medial root of median nerve. And then we'll be having medial cutaneous nerve of arm and the medial cutaneous nerve of the forearm, and then U stands for your ulnar nerves. Posterior cord, for this we are going to remember the mnemonic as lunar. Lower subscapular nerve, upper subscapular nerve, and then N stands for nerve to latissimus dorsi muscle, which is also known as thoracodorsal nerve. A for axillary, R for radial nerve. So we know all these basics very well. Now, why I'm revising this quickly here, I want to concentrate mainly on the MCQs right now. So remember, you are going to get the branches from where? How many parts do you have in the brachial plexus? Totally 5 parts. There will be roots. Roots will combine to form trunks. Trunks will divide into division. Divisions will combine to form cords, and cords will finally give you the branches. Out of all of them, remember, we are getting the branches from the cords. Yes. We are also getting the branches from trunk. But the good news here is that only upper trunk will give the branches. It will be giving like 2 branches. One will be the suprascapular nerve. Another one will be nerve to subclavius. Suprascapular nerve and nerve to subclavius. And we'll also get the branches from roots also. From C5 there will be dorsal scapula. And then from C5 and then C6 and then C7, all of them will combine together to form long thoracic nerve, which will be supplying to serratus anterior muscle. That is your boxer's muscle. So long thoracic nerve or nerve to serratus anterior or nerve of Bell. Clear? So from here we can say that we are going to get the branches from the roots, from the trunk, as well as the cords, but there will be no branches from division. Already asked in the exam. All of them will give the branches, but divisions will not give any branches over there. Clear? Now what is going to happen if there is an injury here? Injury to upper trunk will lead to Erb's paralysis. Similarly, injury to lower trunk will lead to Klumpke's paralysis. And similarly, if there is an injury to long thoracic nerve, which is coming from C5, C6, C7, that will lead to winging of scapula. So let us see all of them one by one. In Erb's paralysis, there will be injury to upper trunk of the brachial plexus. If upper trunk is involved, then what is the root value that is involved? C5 and C6. Which nerves are mainly involved in the Erb's paralysis? Remember, that will be your axillary nerve and the musculocutaneous nerve and the suprascapular nerve. Remember with the mnemonic as SAM here. Suprascapular nerve, axillary nerve and musculocutaneous nerve. These 3 nerves are mainly involved. Achha, by the way, how this injury will occur? Number 1, birth injury. Number 2, fall on shoulder. What is happening in the birth injury is sometimes the head of the baby will come out, but the shoulders are still stuck inside. Shoulder dystocia. The head is coming out, but the shoulders are still inside. Now suppose if the doctor is like inexperienced doctor, what they will do? They'll just keep on pulling out the head. So there is an overstretch between the head and the shoulder. C5 and C6 will combine to form upper trunk. Because of this overstretch, upper trunk will be injured here. Birth injury. Or sometimes what will happen, like the players who are playing football, cricket and all, they'll be falling randomly. So they'll be falling on shoulder, and fall on shoulder will also lead to injury to upper trunk. So there are like 2 clinical cases here, birth injury and fall on shoulder. Now, if upper trunk is damaged, then what is going to happen? It will lead to policeman's tip hand, or else it is also known as waiter's tip hand, or else it is also known as porter's tip hand. What is happening in this one? Let us go step by step. First of all, arm. Arm will be adducted and medially rotated. Number 1. And then what is happening at the elbow? Elbow will be flexed or extended. Then at the forearm, what is going to happen? Supination or pronation? Remember, it is pronation, and finally the fingers are flexed. So this entire thing will give the appearance like a policeman tip hand. Okay. So let us repeat again. Arm here will be adducted and medially rotated. Elbow here will be extended, and the forearm will be pronated, and the fingers are actually flexed, and that will lead to the policeman tip hand. Okay. Now, what is Klumpke's paralysis? In Klumpke's paralysis, there will be injury to lower trunk of the brachial plexus. If lower trunk is injured, then what is the root value involved? C8 and T1 will be involved. Which nerves will be involved in the Klumpke's paralysis? That is ulnar nerve and the median nerve will be involved. And that is going to actually affect your intrinsic muscles of hand. Achha, by the way, this injury occurs due to what? It is due to hyperabduction of arm. And in the exam, the clinical question will be like, a boy aged about 10 years will be climbing up the tree. And while falling down, he is trying to catch something. So when you're trying to catch something, there will be hyperabduction of the arm. Lower trunk will be damaged there. Okay. So hyperabduction of the arm. So now what is the sign of Klumpke's paralysis? That will be claw hand. And how we are going to describe the claw hand? Look at my hand here. How is the claw hand made here, sir? First, at the metacarpophalangeal joint, will it be flexion or extension? It will be extension, and that too hyperextension. And then what is happening at interphalangeal joint? It will be flexion here. So hyperextension at the metacarpophalangeal joint and flexion at interphalangeal joint. That will lead to the formation of claw hand. Hyperextension at the metacarpophalangeal joint and flexion at interphalangeal joints. Acha, along with the Klumpke's paralysis, there will be even Horner syndrome. In Horner syndrome, what is going to happen? There will be ptosis, meiosis, and anhydrosis. Fine. But the reason is why? Why is there Horner syndrome associated with the Klumpke's paralysis? Because of the involvement of T1 here. T1 belongs to your sympathetic nervous system. So because T1 is also involved here, it is leading to Horner syndrome. Okay. Then the last one here is winging of scapula. Which nerve is involved in the winging of scapula? That will be the long thoracic nerve is involved in the winging of scapulas. If long thoracic nerve is involved, I told you very clearly it's going to begin from C5, C6 and C7. It is supplying to which muscle? Serratus anterior muscle. Serratus anterior muscle will be attached to upper 8 ribs here, and then it will be going and inserting onto the scapula, on the medial border of the scapula, and helping in keeping the scapula intact with the thoracic wall. Suppose if this muscle is gone, then what is going to happen? Ask the patient to push against something. So therefore, the scapula will be actually winging. Scapula being a triangular bone here, which border of the scapula will be actually becoming prominent here? Remember, medial border of the scapula becomes more prominent. Medial border of the scapula becomes more prominent here, sir. After completing about the brachial plexus, quick revision here, and all the 3 injuries we have discussed here: Erb's paralysis, Klumpke's paralysis, as well as the wing of scapula. Now let us see one more small topic here, that is about the clavicle. I'll tell you why I'm revising this one here. Clavicle is a long bone or a short bone? Remember, it's a long bone, but it is the only long bone in our body which is lying horizontally. All the remaining long bones, you can see they are present vertically. Clavicle will be lying horizontally. Even though it is a long bone, it does not have any medullary cavity. Normally in the long bones, you'll be having medullary cavity, but here there is no medullary cavity. Of course, it is the first bone to start ossifying. Yes, during the intrauterine life, almost like 5th week, it will start ossifying. Last bone to complete ossification by 22 to 25 years of life. Okay. It is the only long bone which ossifies in membrane. We have learned about ossification. There will be 2 types: cartilaginous ossification and membranous ossification. Long bones comes under the category of cartilaginous ossification, but clavicle will undergo membranous ossification, except for the medial end, which will undergo cartilaginous ossification. It is the only long bone which has 2 primary centers of ossification. Normally, a long bone will have 1 primary center of ossification, but it is having 2 primary centers of ossification here. Perfect. And now, this is the most important point here, sir. Most commonly, the clavicle is fractured between lateral 1/3 and the medial 2/3. So we are going to divide the clavicle into 3 parts here, sir. Medial 1/3, middle 1/3, and the lateral 1/3. Remember, the clavicle will be fractured here between the medial 2/3 and the lateral 1/3. Medial 2/3 and the lateral 1/3. But one of the updated thing in the Gray's Anatomy is that nowadays we are dividing the clavicle into the 5 parts. Therefore, the fracture of the clavicle will be at the junction of lateral 2/5 and medial 3/5. So please answer in the exam based on the options which are given to you, sir. Okay, so that's an important thing to be revised here. How can we forget this topic, sir? In the revision of upper limb, we have to learn about the anatomical snuff box. So when you're going to extend the thumb here, yes, this is actually the anatomical snuff box here. And if you're going to palpate here, my dear friends, you'll be able to touch the tendons present over here. On the lateral side, there'll be 2 tendons, that is abductor pollicis longus and extensor pollicis brevis. And the medial side will be having only 1, that is extensor pollicis longus. First, you got to learn the boundaries here. On the lateral side, there'll be 2 tendons here: abductor pollicis longus, extensor pollicis brevis. And on the medial side, we'll be having only 1, extensor pollicis longus. Roof will be formed by the cephalic vein as well as the superficial branch of the radial nerve. We have learned just now. The floor will be formed by, this is something important here, it is formed by the lower end of the radius bone here and the scaphoid and trapezium and the base of the first metacarpal. So these bones are going to form the floor of the anatomical snuff box. And out of this, remember, scaphoid is very much important here. Okay. Then what is the content of the anatomical snuff box? It is radial artery. Radial artery is the content of this one. Fine. Now, in your exams, recently there was a question given. A person falls on outstretched arm. When he's falling on the outstretched arm, then he comes to the clinic with the pain in anatomical snuff box. The pain in anatomical nerve box is due to the fracture of which bone? You know very well which bone is most commonly fractured, that is scaphoid. So scaphoid is most commonly fractured here. It is due to the fracture of scaphoid, the pain in the anatomical nerve box. Next, another very important concept for your exams is nerves related to humerus. We are actually having three nerves which are related to humerus here. Number one, axillary nerve here, which is going to pass behind the surgical neck of humerus. Number two, radial nerve here. And radial nerve is going to pass behind the shaft of humerus in the radial groove or the spiral groove. And number three will be your ulnar nerve here. Ulnar nerve is going to pass behind the medial epicondyle. Okay. So tomorrow if a patient comes to you with a fracture of surgical neck of humerus, which nerve will be damaged here, sir? That is your axillary nerve. If there is a fracture of shaft of humerus, which nerve will be damaged? Radial nerve. And if there is a fracture of medial epicondyle of the humerus, then ulnar nerve will be involved in this one. Then what about the supracondylar fracture? If the fracture occurs over here, if there is a supracondylar fracture, remember, anterior interosseous nerve is a better answer when compared to the median nerve, sir. In supracondylar fracture, anterior interosseous nerve is a better answer when compared to the median nerve. Perfectly done. Now welcome to carpal tunnel. In this diagram, we are able to see here, we have taken a section. Now in this section, you are able to see all your carpal bones over here, and they are covered by a fibrous band-like structure. And this fibrous band-like structure here is known as flexor retinaculum. Now if this one here will be the flexor retinaculum, we need to learn what are the structures passing superficial to that and deep to that person. I told you just now, out of all the structures, the nerve which is going to pass superficial to flexor retinaculum, that is ulnar nerve. Ulnar nerve passes superficial to flexor retinaculum. Along with that, you are able to appreciate the artery here, that is ulnar artery. And then along with that, there is a tendon, and that tendon will be the palmaris longus tendon. All these structures are going to pass superficial to flexor retinaculum. Ulnar nerve, ulnar artery, and the palmaris longus tendon, they are going to pass superficial to flexor retinaculum. Apart from that, try to recall, just now I taught you about the median nerve. Median nerve is going to pass deep to flexor retinaculum, but the palmar cutaneous branch is going superficial. So superficial, you'll also have the palmar cutaneous branch of the median nerve. Of course, ulnar nerve will be there along with that. Palmar cutaneous branch of ulnar nerve is also there, sir. Superficial. Now, can you appreciate this tendon here? This tendon here will be the flexor carpi radialis tendon. And flexor carpi radialis tendon, it's neither superficial nor deep. It's neither superficial nor deep. It is going through the flexor retinaculum. Through the flexor retinaculum. Okay. Then after that, what is going to pass? Deep to flexor retinaculum. And deep to flexor retinaculum is nothing but, yes, those structures which are going to pass through the carpal tunnel. Through the carpal tunnel. So you're able to appreciate like 4 tendons here. These 4 tendons are of FDS. Flexor digitorum superficialis. And then we have 4 tendons here which belongs to FDP, flexor digitorum profundus. FDS and FDP. Then you're able to see one more tendon here. This tendon is going to the thumb, flexor pollicis longus. And this one here will be the median nerve, which is going through the carpal tunnel. So all these structures are passing deep to flexor retinaculum. And deep to flexor retinaculum means they are going to pass through the carpal tunnel. Perfectly done. Okay. So in this manner, in this topic, actually, we have to learn the structures passing superficial to flexor retinaculum and the structures passing deep to flexor retinaculum. So, done. Apart from the flexor retinaculum, you also have to learn about, yes, extensor retinaculum. So here you'll be actually having, all these extensor compartments. All those tendons which are passing from here, they're actually placed in the compartments. And these compartments, of course, the name and numbering will be always from lateral towards the medial side. So from the lateral towards the medial side, sir, how to learn this one? The easiest way I'll tell you. Just now we have learned about the anatomical snuff box. In anatomical snuff box, I told you that laterally and medially, laterally and medially. Laterally, there'll be like 2 tendons, abductor pollicis longus, extensor pollicis brevis. That will be in the first compartment here. And in the third compartment, you'll be having extensor pollicis longus. So the first compartment here and the third compartment here. So in the first compartment, there will be abductor pollicis longus, extensor pollicis brevis. And in the third compartment, you're having extensor pollicis longus. These two are the boundaries of anatomical snuff box. Then what is going to pass in the second compartment here? In the second compartment, you'll be able to see like two more tendons which are actually crossing from here. So now which tendons will be coming on this lateral side here? Of course, there will be extensor carpi radialis. And extensor carpi radialis longus will be there, and extensor carpi radialis brevis. ECRL and ECRB, they are going to cross here. That is the second compartment. And after that, of course, after completing about these three compartments here, so then the next one here, there should be actually a muscle which is actually, dividing into the four tendons, and the four tendons are going to four digits here. Extensor digitorum. So the next compartment, that is compartment number 4, you can see having four tendons there, and that is for extensor digitorum as well as extensor longus. Then you'll be having compartment number 5, where you have a separate tendon going to the little finger, extensor digiti minimi, and then you'll be having on the medial side extensor carpi ulnaris in the compartment number 6. So therefore, all your extensor compartments are divided into 6 compartments, numbering from the lateral towards the medial side. So, okay now. And it's very easy to remember. First, you learn about the anatomical snuff box, and these compartments are going to become damn easy for you, sir. Okay, by this, we are done with all the high yield topics to be revised in the upper limb topic here, sir. And I hope the remaining topics are much easier topics that you can easily manage. The most important thing was all about the nerves. Ulnar nerve, median nerve, and the radial nerve we have discussed in detail, along with the injuries and along with the muscles of hand and all. So these are like very, very important topics to be revised before the exam. So, okay, hope this will help you. Thank you. Hello, my dear doctors. Now we are going to continue with our rapid revision. And now let us see the two important topics in the general anatomy. Number 1, we are going to revise about the types of joints. And number 2, we are also going to revise about the types of epiphysis. And in almost every exam, there will be like one question from types of joints. Whether you're writing the NEET PG exam or the FMG exam, is definitely one question will be coming from your types of joint topic. So let's get started with the types of joint. Now, first of all, you should know that all the joints are actually divided into 3 categories here. Number 1, the fibrous joint, which will be immovable joint. Number 2 will be the cartilaginous joint, that is slightly movable joint. And number 3 will be the synovial joint, that is a movable joint. Okay. Now, out of these 3 types, now let us see the subtypes of this joint. The fibrous joint will be in turn divided into 3 categories here. Number 1, the joint between the bones of the cranium, between the cranial bones, that is your sutures. They will be immovable, included under fibrous joint. Number 2 will be between the tooth and the socket, that is gomphosis, and then I'll tell you in detail about the syndesmosis. Now, cartilaginous joint are divided only into 2 categories here. One will be the primary cartilaginous joint, another one is the secondary cartilaginous. Please remember the another name of this one. Primary cartilaginous joint, it is also known as synchondrosis. And then secondary cartilaginous joint, it is also known as symphysis. And once you remember the 3 types of fibrous joint and the 2 subtypes of cartilaginous joint, remaining any joint that you know, it's all under the category of synovial. They're all movable joint. So whether it is ball and socket joint or hinge joint or saddle, ellipsoid, condylar, plane, pivot, all other are nothing but the synovial joints and the movable joints. So the best way to learn about the types of joints is please divide them into these categories here. So learn the 3 subtypes of fibrous, the 2 subtypes of cartilaginous, remaining everything comes under synovial. Now let us discuss about all of them in detail one by one. Number 1, starting with the immovable joint, that is fibrous joint. Fibrous joints, as I told you, number 1, they are divided into sutures. Sutures, yes, the joint present between the cranial bones is nothing but sutures, and of course they are not at all movable, they are immobile. The joint present between the tooth and the socket will be gomphosis. So remember, like gum, between the tooth and the gum, gomphosis. And number 3 will be syndesmosis. Now this is something important. Many times in your exam, this question is being given. Now what is the meaning of syndesmosis here? The meaning here is that between the 2 bones, the joint is with the help of interosseous membrane. Interosseous membrane. So you have to remember one example here. Now in this diagram, you're able to see this is your radius and the ulna, And in between the radius and ulna, the middle radio-ulnar joint will be the example of syndesmosis. In between the radius and ulna, totally there will be like 3 joints: superior, middle and inferior radio-ulnar joint. Out of that, superior and inferior, they'll be helping in the pronation and the supination. They're helping in like a radius moving around the ulna. That type of joint will be the pivot joint. We'll study about that in the synovial category. Now, the middle radio-ulnar joint will be an example of syndesmosis. Similarly, the inferior tibiofibular joint is also an example of syndesmosis. And finally, remember the sacroiliac joint. So, you just have to remember the 3 examples here. Number 1, middle radio-ulnar joint, inferior tibiofibular joint and the sacroiliac joint. These 3 will be the examples of syndesmosis that you have to remember here. Perfect. Now, let me show you one special category of suture. I told you the sutures are present between the cranial bones. Now, between the rostrum of sphenoid and the vomer, this suture is known as the shindylasis. So, this is also like suture only, but it is a special category of suture that you have to remember, that is shindylasis. So, shindylasis is actually between the rostrum of the sphenoid and the alley of the vomer. Clear? Done. So, by this we are done with the first category, that is fibrous joint. Now, let us move on to the cartilaginous joint. I told you very clearly they are divided into two categories here. One is the primary cartilaginous joint, another one is the secondary cartilaginous joint. Primary cartilaginous joint, it is also known as synchondrosis, whereas the secondary cartilaginous joint is also known as symphysis here. Perfect. Now again the same thing, in joints we need to learn about the examples of this one here. The primary cartilaginous joint is between the epiphysis and diaphysis of the long bone. Now my dear doctors, we know that very well. When you see the structure of a long bone, the end of the long bone is known as epiphysis and the shaft will be known as diaphysis. Now between the epiphysis and diaphysis, there will be a plate of cartilage and that is known as the epiphyseal plate of cartilage or growth plate. Now that growth plate is made up of cartilage. That is the reason why what is a joint between epiphysis and diaphysis? That is cartilaginous joint. And remember, it is primary cartilaginous joints. Number 2, second example will be costochondral joint. Yes, you are able to see here in this diagram, the joint between the rib and the costal cartilage. This one, between the rib and the costal cartilage. Costochondral joint is an example of primary cartilaginous joints. And don't worry about the chondrosternal joint. I will tell you about that in the synovial category. So please have a clarity here. I am telling you about the costochondral joint. That is an example of primary cartilaginous joint. Number 3 will be the spheno-occipital joint between the sphenoid bone and the occiput. Spheno-occipital joint is an example of primary cartilaginous. So mainly I request all of you to please remember the costochondral and the joint between the epiphysis and diaphysis. Now moving on to the secondary cartilaginous joint, that is symphysis, very much important. It's like a repeat question in your exams. And the easy thing to remember here is, yes, what is the examples of secondary cartilaginous joint? All the midline joints. All the midline joints. The joint between the manubrium sternum and the body of the sternum. The joint between the xiphoid process and the body of the sternum. Xiphisternal, manubriosternal. The joint between the vertebrae, that is your intervertebral disc, as well as the pubic symphysis. The joint between the sacrum and the coccyx. All the midline joints will be the examples of secondary cartilaginous joint. Okay, the manubriosternal, xiphisternal, intervertebral disc, as well as the pubic symphysis and sacrococcygeal. All these joints will be the examples of secondary cartilaginous. But now, my dear doctors, remember, one exception is very much important here, sir. In the midline joint, we also have symphysis menti. The mandible here, in the mandible, in this part here is known as the mental part. Now, symphysis menti, remember, it's very clearly mentioned in the Gray's Anatomy. So, this is actually a screenshot from the Gray's Anatomy. All symphysis will occur in midline except the mandibular symphysis or the symphysis menti. No, it's not considered as a secondary cartilaginous joint. Nowadays, it is considered to be a special category of the fibrous joint. So, please don't consider that into the secondary cartilaginous joint. That's an exception there. Clear? So, in this manner, we are easily able to remember the primary and the secondary cartilaginous joints. We are done with the second category. Now, welcome to the third category of joints, that is your movable joints. And those will be the synovial joint. Now, as I told you, synovial joints, we are having a variety of them. Ball and socket joint, hinge joint, saddle joint, condylar. There are so many of them. Now, the problem is, I have been observing that from many years. I have been observing that many students will learn the joints, like for example, ball and socket, and they'll write on all the examples. Now in our body, ball and socket, there are 4 of them. Shoulder joint, hip joint, and then talocalcaneonavicular joint in the foot, and then in the ear. Okay, incudus-tibial joint. Now it's like difficult to remember. It's very much difficult to remember the joints in this manner, examples in this manner. Saddle joint, again you're writing the heading there and memorizing or mugging up like 4 or 5 different types of places. That is the reason why what I have done is, instead of learning like all the examples at one place, better we do one thing here. Divide all the synovial joints into 5 images, like the upper limb and the lower limb and the thoracic cage here, then about the axial joint. So in this manner, I have actually divided them into totally 5 images. If you follow that images, easily you will be able to remember that one. Let me rapidly revise for you how to remember this one here. First, let us see in the upper limb here. Let's start from here. So between the sternum and the clavicle, sternoclavicular joint, and then you'll be having acromioclavicular joint, then shoulder, then the elbow joint, then in radius and ulnar, radioulnar, I told you there will be 3 of them, superior, middle, inferior, then the wrist joint, carpometacarpal, metacarpophalangeal, interphalangeal. You know the names. Now you try to apply the same thing exactly on your body. Number 1, the sternoclavicular joint is an example of saddle variety. It's a saddle joint. Acromioclavicular joint, that is a plain variety of joint, sir. Plain joint. Shoulder joint, everyone knows that very well. That is ball and socket joint. Elbow joint, everyone knows very well. Hinge joint, and it is going to move only in one plane. I told you just now, radioulnar joint, how to remember. Superior and inferior. Superior and inferior, they are actually helping in rotating movement here. So that is an example of pivot joint. But remember, middle radioulnar joint is not an example of synovial joint. No. That is a joint between the 2 bones with the help of interosseous membrane. It's an example of syndesmosis. Already asked in your exam many times. After that, the wrist joint will be the ellipsoid, and then carpometacarpal joint will be saddle joint, and then metacarpophalangeal joint will be again ellipsoid. So remember, like ellipsoid and saddle, and then again ellipsoid. And then finally, interphalangeal joint will be also helping in flexion, extension. Okay, the movement is only in one plane, same like your elbow joint. So remember, that is also an example of your hinge joint. Perfect. So in this manner, if you practice this in the same order once or twice on your own body, I hope this will make the things easier, much easier, rather than writing the list and mugging up, and you'll never be able to remember that one. Okay. Similarly, let us see now for the lower limb. In the lower limb, first hip joint, and then the knee joint, and after that, between the tibia and fibula, tibiofibular joint, then you'll be having your ankle joint and so on. Hip joint, everyone knows very well, it's an example of ball and socket joint. Knee joint. In knee joint, you have to be like careful. There is a joint between the femur and tibia, and then there is a joint between femur and patella. Fibula will not be involved in the knee joint. Fibula will not be involved in the knee joint, sir. Now, between the femur and tibia, I am able to clearly appreciate in the diagram, they are like condyles. That is the reason why it's a condylar joint. Femur and tibia, that will be a saddle joint. Tibiofibular, superior and inferior. Superior will be a plain joint. Inferior, we have learned just now in the fibrous category. It's an example of syndesmosis. Then ankle joint, again the same thing. You are able to move the ankle in the dorsiflexion, plantar flexion, and therefore it's an example of hinge joint. Metatarsophalangeal joint will be ellipsoid joint, and whereas interphalangeal joint is again an example of hinge joint. So in joints category or in joints topic, my dear friends, you just have to remember the examples here. So the main thing, what I can do is I can help you how to learn that. What is the trick for learning that one? So rapidly we are revising here. So we are done with our second topic here, or second image here. Welcome to the third image. I told you about this one in the lower limb topic already. When we are done with the rapid revision of lower limb, I taught you about the medial longitudinal arch and lateral longitudinal arch. Medial longitudinal arch, the main joint there will be the talocalcaneonavicular joint, and that is an example of again ball and socket joint. Whereas lateral longitudinal arch, the main joint here will be calcaneocuboid joint. Calcaneocuboid, and there the example will be the, yes, it's an example of saddle variety, saddle joint. So talocalcaneonavicular joint is an example of ball and socket joint. Calcaneocuboid joint is an example of what's a saddle joint. Clear, my dear friends? Now, similarly in the ear, we are actually having 3 ear ossicles, 3 bones in the ear: malleus, incus, and the stapes. Between the incus and the malleus here, this is incudo-malleolar joint. That is again example of saddle joint. Whereas between the incus and stapes, incudostapedial joint is an example of ball and socket joint. Now, why am I giving you this third image here is, I want my students to please concentrate on ball and socket joint. Ball and socket joint in our body, we are actually having at 4 places. Number 1, the shoulder joint. Number 2, the hip joint. The first thing this will come in your mind. Please forget about that. They will never ask you in the exam. Remember the 2 more examples. One in the foot, talocalcaneonavicular joint, and one in the ear, that is incudostapedial joint. And remaining 2 on the screen, they are also very much important, sir. Examples of saddle joint here. One is incudomalleolar joint, another one is the calcaneocuboid. I hope this concept is very much clear over here. Then moving ahead, my dear friends, now welcome to the 4th image here, that is about the thoracic wall. And in thoracic wall, first of all, posteriorly, the joint is between the rib and the vertebrae, costovertebral joint. And costovertebral joint is a movable joint, and that's an example of plane joint, sir. Plane type of synovial joint. Then in the front here, I told you between the costal cartilage and the sternum, chondrosternal joint. Cartilage is also known as chondrus. That is the reason why. What is the name here? Chondrosternal joint. Remember, all the chondrosternal joints here will be of plane variety only, except the first one. The first chondrosternal joint is an example of fibrous joint. I repeat this point again. It is worth repeating. All the chondrosternal joint will be the plane variety of synovial joint, except for the first one. The first chondrosternal joint is an example of fibrous joints. Clear? And according to our concept as we are learning here, welcome to the 5th and the final image. And in this 5th and the final image, my dear friends, you are able to see that there is a joint between the atlas and the axis, atlantoaxial joint. The first cervical vertebra and the second cervical vertebra, atlantoaxial joint, and that joint is an example of pivoid joint. You can clearly see here the odontoid process will actually come and fit here. So on this joint, what is going to happen? There is a rotation movement, and this type of movement is nothing but the no movement. So which joint is actually helping in no movement? When we say no like this here, sir, that is atlantoaxial joint, and it is an example of pivoid joint. So in pivoid joint, what is going to happen? One bone will be present there only, the other bone will be rotating around that one. That's an example of pivoid joint, atlantoaxial. Another one is between the atlanto-occipital joints, the first cervical vertebra and the occipital bone, atlanto-occipital joint, and that is an example of ellipsoid joint, where you'll be actually doing the yes movement. Are you clear with this one here? Now in this manner, my dear doctors, yes, you are easily able to remember the synovial joint. I think this is the best method, instead of writing all examples at one place and simply mugging up. So try this. Actually, this will help you a lot. And of course, from types of joint, definitely one question will be definitely coming in the exam, sir. So just to summarize here, all the joints we are dividing into 3 categories. One is fibrous and the cartilaginous and the synovial joint. Perfect. Apart from this, I want you to revise one more topic here, that is about the epiphysis. See, what is the meaning of epiphysis here? Epiphysis is nothing but the end of the bone. The shaft of the bone is known as diaphysis. Now this epiphysis, they have divided into like 4 categories here. Number 1, there will be pressure epiphysis. Number 2, there will be traction epiphysis. Number 3, you will be having atavistic epiphysis, and then the 4th one will be aberrant epiphysis. Again, the same thing, examples are important. But I'll tell you the trick here, the concept here, sir. Now the concept here is that pressure epiphysis will be the one which will be involved in the joint. So that epiphysis, that end of the bone which is articular. Pressure epiphysis is the one which is the articular one, which is actually involved in the joint, and it is the weight bearing one. It is going to bear the weight. Now what you do is, instead of just mugging the examples here, try to recall in your mind, okay, head of the humerus, is it involved in the joint? Yes. Head of the femur, is it involved in the joint? Yes. As well as condyles. Condyles are also involved in the joint. Yes. All this will be coming under the category of pressure epiphysis. Similarly, what about the traction epiphysis? Traction epiphysis will be the one which are not involved in the joint. They are non-articular. Why the name is given like this? Think about this one. They are formed due to the pull of the muscle. Traction. Okay. So when the muscle will be attached to that end of the bone epiphysis, and that is formed due to the pull of the bone. Now, number 1, in the upper end of the humerus will be having 2 tubercles, greater tubercle and the lesser tubercle. They are formed due to the pull of the bone. Okay. So they are included under traction epiphysis. Similarly, in the upper end of the humerus, you'll be having greater trochanter and the lesser trochanter. They are also formed due to the traction of the muscles, and that is also included in the traction epiphysis. And one more thing, my dear friends, remember epicondyle. Condyles will be involved in the joint, but the epicondyle, like lateral epicondyle, medial epicondyle, they are also formed due to the pull of the bone. So they also come under the category of traction epiphysis. So please keep a clarity in your mind. Condyles are examples of pressure epiphysis. They are involved in the joint, but epicondyles are an example of traction epiphysis here. Perfectly done. Next one, that is your atavistic epiphysis. First, what is the meaning of this one? Remember, atavistic epiphysis means phylogenetically, like during our development. I'm telling not about the intrauterine development, like phylogenetic development from ancestors and all. These bones used to be a separate bone. But during that, phylogenetic development, what happened? They have merged with the nearby bone. For example, one of the best example for atavistic epiphysis, coracoid process. Asked multiple times in your exams. Coracoid process, nowadays we studied that it is a part of your scapula. But yes, in our ancestors and all, that used to be a separate bone. But during phylogenetic development, what happened here? That is fused with the scapula. So these type of ends of the bone, this type of epiphysis is known as atavistic epiphysis. So one example here will be coracoid process, asked multiple times in your exam. One more example here will be the os trigonum. Coracoid process and os trigonum are the examples of atavistic epiphysis. After that, the next one here will be aberrant epiphysis. From the name itself, we can understand aberrant means which is not usually present in everyone. Aberrant epiphysis, that is the end of the bone, which is usually not seen in all the people, in all of them. Okay, aberrant. Sometimes it is present in some people. For example, the head of the first metacarpal, it's not seen in everyone, sometimes present, head of the first metacarpal. And similarly, the base of the remaining metacarpals. Base of the remaining metacarpals is an example of aberrant epiphysis. So my dear friends, just to recall here, easily you can remember here, epiphysis is nothing but the end of the bone. And how to remember this one? There are four categories. Pressure epiphysis, weight bearing, which is involved in the joint. And then the traction epiphysis, which is not involved in the joint and formed due to the traction, pull of the muscle. And the third one, atavistic. Important example, coracoid process, asked many a times. And then finally, the aberrant, which is not usually present. Okay, I hope this will help you in your exams. So these are the two important topics that I want you to revise in general anatomy category. One is about the joint, another one is about the epiphysis. I hope this will help you a lot. Thank you. Hello my dear doctors, now we are actually going to start with the rapid revision of lower limb topic. Okay, another very small topic here, but very important one. Many times the questions are being asked in your exam from here, sir. Now in the lower limb topic, again the same thing. The most important aspect here to discuss will be about the major nerves. Okay, so same like our upper limb topic, exactly in the lower limb also, the thigh and the leg and the foot, they are divided into certain compartments. So first we'll see our golden rule here, then we'll actually learn about the nerves. In the thigh, all the muscles of thigh, they are actually divided into three compartments. Anterior compartment, the posterior compartment and the medial compartment. And in the leg, again the same thing, it is divided into three compartments, anterior, posterior and the lateral compartment of the leg. Then in the foot, there are no compartments. It is not divided into any compartments. We just simply have the muscles of foot. Now in the thigh, all the muscles in the anterior compartment of the thigh will be supplied by femoral nerve. The medial compartment of the thigh will be supplied by obturator nerve, which will be having all your adductor muscles. Then the posterior compartment of the thigh will be supplied by tibial nerve, or to be more specific, the tibial component of sciatic nerve. Then in the leg region, again the same thing, the posterior compartment of the leg, that is your calf muscles, are supplied by the tibial component of sciatic nerve. Then in the leg, the lateral compartment is taken care by superficial peroneal nerve and the anterior compartment is supplied by deep peroneal nerve. And both of them are the branches of your common peroneal nerve. Then sir, finally, what about the foot then? Now in the foot, remember all the muscles present in the foot, they will be supplied by two nerves. One is medial plantar, another one is lateral plantar. So medial and the lateral plantar, these two are the branches from your tibial nerves. So tibial nerve is going to take a turn and then divide to medial plantar nerve and the lateral plantar nerve. Is it okay? I hope it is crystal clear now. So now out of all these nerves, let us discuss in detail about the sciatic nerve. Why? Because if you are done with the sciatic nerve, you'll be done with tibial nerve, common peroneal nerve, and then the deep peroneal nerve and the superficial peroneal nerve. So in the lower limb, make sure before going to the exam, you revise the sciatic nerve very well. Okay. So sciatic nerve, remember the first point that it is actually not a single nerve here, sir. It is like two nerves together. That is your tibial nerve plus the common peroneal nerve together. If it is tibial plus common peroneal nerve together, then what is the origin of the sciatic nerve? Remember, it is going to originate from L4, L5, S1, S2 as well as S3. Because tibial nerve is actually originating from anterior division of L4, L5, S1, S2 and S3. And common peroneal nerve is going to originate from posterior division of L4, L5, S1 and S2 only. So that is why, because it is a combination of these two, it is having origin from all the way from L4 to S3. Now, once you are done with the origin of the sciatic nerve, let's see about the course and supply of the sciatic nerve in detail. Okay. So I'm going to tell you again in the same manner as I told you in the rapid revision section of upper limb. When we learn about the ulnar nerve, median nerve and radial nerve, we learn about arm, forearm and hand. Similarly, in the lower limb, we are going to learn about the thigh and the leg and the foot one by one. Okay. So first of all, in the gluteal region, there will be a foramen here, and this foramen will be known as the greater sciatic foramen. So this foramen here will be the greater sciatic foramen. Okay. Now in this greater sciatic foramen, you will be able to appreciate one muscle here, and that muscle will be the piriformis muscle, sir. In the greater sciatic foramen, there will be a muscle here. This muscle will be the piriformis muscle. And sciatic nerve is going to exit from the pelvis. It is actually formed in the pelvis now, L4 to S3. After forming in the pelvis, it is going to exit via the greater sciatic foramen and enter into gluteal region. It is going to enter into the gluteal region behind, but remember via which foramen? Greater sciatic foramen and below piriformis. So it is going to enter into the gluteal region from the greater sciatic foramen, but below the piriformis muscle. Now this nerve here will be actually the sciatic nerve, and please keep in mind that the sciatic nerve is made up of two components here. One will be the tibial nerve, another one will be the common peroneal nerve, sir. Done. Now, will it supply to anything in the gluteal region, sir? Absolutely no. Remember, sciatic nerve is not supplying to any structure or any muscle in the gluteal region. Now, from the gluteal region, the sciatic nerve will actually move down into the posterior compartment of thigh. So, from the gluteal region, the sciatic nerve is going into posterior compartment of thigh. Now, in the posterior compartment of thigh, you know very well, we'll be having hamstring muscles. So, therefore, the sciatic nerve will be supplying to which muscles here, sir? It will be supplying to the hamstrings. So, in hamstring, I hope you know the names here. Number one, you'll be having semitendinosus muscle. Then there will be semimembranosus muscle. And then you'll be having biceps femoris muscle. Semitendinosus, semimembranosus and biceps femoris. From the name itself, we can understand that biceps means it will be having two heads. There will be a long head and then you'll be having the short head. And here comes the first exception. I told you in our golden rule that the posterior compartment, the entire posterior compartment, it should be supplied by which component? Tibial component. So remember, semitendinosus will be supplied by tibial nerve. Semimembranosus will also be supplied by tibial nerve. Long head of biceps femoris is also supplied by tibial nerve. But what about the short head? Remember, the short head will be supplied by the other option available here, that is common peroneal nerve. Extremely important, sir. So short head of biceps femoris will be supplied by common peroneal nerve, sir. Common peroneal nerve. Perfect. And one more exception, let me tell you here. There is a muscle known as adductor magnus. The moment you listen this name adductor magnus, what will come in your mind? It should be supplied by obturator nerve. In the thigh, we have like three compartments: anterior, posterior and the medial compartment. In the medial compartment, you have adductor muscles, adductor magnus. Now please concentrate on the magnus there. Magnus means it's a huge muscle, big muscle. It is present in medial compartment as well as a part of that is extending in the posterior compartment. Adductor magnus, it is present in medial compartment as well as a part of that is coming in the posterior compartment. Doctors have divided this one into two parts now. One, the adductor part, another will be the hamstring part. Adductor part of adductor magnus and the hamstring part of the adductor magnus. Now out of these two parts, you know very well, adductor part in the medial compartment should be supplied by obturator nerve, whereas the hamstring part should be supplied by tibial nerve. So therefore, yes, even adductor magnus is also included here. And which part of the adductor magnus, that is hamstring part, will be supplied by, of course, the tibial nerve. So remember, our entire posterior compartment of the thigh consists of hamstring muscles, and these hamstring muscles are supplied by tibial nerve. Exception here will be the short head of bicep femoris, that is supplied by common peroneal nerve. Achha, what is the criteria of calling it as a hamstring muscle? Remember the origin. All these hamstring muscles should be originating from the ischial tuberosity. Ischial tuberosity. Okay. So all of them are going to begin from the ischial tuberosity except for your number one short head here. And number two will be the adductor magnus here. That is the reason why these are not like true hamstring muscles. They're actually the modified hamstrings or the fall hamstrings. Done. By this, we are done with the posterior compartment of thigh. Now, after completing the posterior compartment of thigh, now the next thing, let us continue ahead. Now, the sciatic nerve is going to enter into the popliteal fossa. The diamond-shaped popliteal fossa here, behind the knee joint. Now, in the popliteal fossa, the moment it enters near the apex of the popliteal fossa, sciatic nerve will be again dividing into its two components. That is the tibial nerve and then the common peroneal nerve. Okay, so this will be the tibial nerve over here, and this on the lateral side here, this is the common peroneal nerve, sir. Perfect. Now first let us deal with the common peroneal nerve right now. Common peroneal nerve will further descend down on the lateral side, will enter into the leg region. Now in leg we'll be having two bones, the tibia and the fibula. Of course on the lateral side we'll be having the fibula. Okay. So now what is going to happen? For example, if this one here will be the tibia, okay, and then on the lateral side, this one here will be the fibula, the head and the neck here. So now what is going to happen here? The common peroneal nerve, exactly near the neck of the fibula. Near the neck of the fibula, that landmark is important. Near the neck of the fibula, it is going to divide into the deep peroneal nerve and the superficial peroneal nerve. Deep peroneal nerve will be supplying to anterior compartment and superficial peroneal nerve will be supplying to the lateral compartment of the leg. But important landmark here is common peroneal nerve divides where? Remember, it divides at neck of fibula. Common peroneal nerve will divide at the neck of fibula. Perfect. Now, let us see both these nerves one by one. First, let us look at the superficial peroneal nerve. Superficial peroneal nerve will be supplying to the lateral compartment of leg. Now, in the lateral compartment of the leg, you'll be having only and only two muscles here. So, one will be the peroneus longus muscle. Another one will be the peroneus brevis muscle. Peroneus longus muscle and the brevis muscle are present in the lateral compartment of the leg. And when these two muscles are going to contract, they are going to be helping in elevation of lateral border of the foot. And when they elevate the lateral border of the foot, that is known as eversion of the foot. So these two muscles are helping in eversion of foot. Perfect. Now welcome to the deep peroneal nerve. Deep peroneal nerve will be supplying to all the muscles present in anterior compartment of leg. Now, in the anterior compartment of leg, again you'll be having one more peroneus muscle, and that will be peroneus tertius. Already we are done with the two muscles here, sir. That is peroneus longus and peroneus brevis, and this one here will be the third one, peroneus tertius. Along with that, the three other muscles are very much important. Now think about the compartment. Where are we right now? We are in the anterior compartment of the leg. In the anterior compartment of the leg, we have a muscle in front of tibia. In front of tibia, that is tibialis anterior muscle. And then in the anterior compartment, do you have flexors or extensor? You'll be having extensor. So one will be the extensor hallucis longus. Another one will be the extensor digitorum longus. So one is going to extend the great toe. Another one is going to extend the other digits. Extensor hallucis longus, extensor digitorum longus here. So all these muscles are present in which compartment? Anterior compartment. Now think about them like this here. So suppose if this is the foot over here, extensor hallucis longus is going to extend the great toe. Extensor digitorum is going to extend the other digits. So therefore, these extensors are actually going to help in what? Yes, if this is the foot here, it is helping in dorsiflexion. So in the foot, if the foot is like this table here, if you do it like this here down, it is plantar flexion, and then this one is dorsiflexion. So these two muscles are actually helping in dorsiflexion, sir. These are dorsiflexors. Perfect. Now, once you are done with the superficial peroneal nerve and the deep peroneal nerve, now let us go ahead with the other one, that is your tibial nerve here, sir. Tibial nerve, I told you very well, it is going to continue down into which compartment? The posterior compartment of the leg. And finally, it is going to take a turn and divide into those two branches. We'll see that later on. First, let us complete about all the supply. Remember, tibial nerve is the one which will be supplying to all the muscles in posterior compartment of leg. Now, in the posterior compartment of the leg, we know very well there will be calf muscles. And what are these calf muscles over here, sir? Two muscles every student knows very well. That will be your gastrocnemius and the soleus, sir. So there will be a lateral head and the medial head of gastrocnemius. So there will be lateral head and medial head. Lateral head and medial head of gastrocnemius. Okay, and just beneath this gastrocnemius, you'll be having the soleus muscle. Okay, so first you're going to remember about these two muscles here. So the lateral head of gastrocnemius, medial head of gastrocnemius, and beneath that there will be soleus. Now these three muscles together, they will actually have a common tendon, and that common tendon is known as the calcaneal tendon, or else it is also known as the Achilles tendon. Point number 1 to remember. Then these three heads together, that is lateral head, medial head of gastrocnemius, and soleus. These three together, they are referred to as triceps surae muscle. Second point to remember. And third point is, remember that soleus muscle is referred to as the peripheral heart of the body. It is referred to as the peripheral heart of the body, sir. Then beneath these two muscles here, we'll be having like three more muscles in the deeper layer. And that three muscles you can actually compare with the anterior compartment. Just now we have learned that in the anterior compartment, there will be tibialis anterior. There should be a tibialis posterior here in the posterior compartment. And then we have learned extensor hallucis, extensor digitorum here. So in the posterior compartment, you should be having flexor. Okay. So there will be a tibialis posterior muscle, flexor hallucis longus here, and the flexor digitorum longus here. So tibialis posterior, then the flexor hallucis longus and flexor digitorum longus here. So. And along with this one, you'll also have like two small muscle that will be the plantaris muscle and the popliteus muscle, sir. Plantaris muscle and the popliteus muscle. Plantaris muscle will be actually along with the lateral head of gastrocnemius. The importance about the plantaris is it is the muscle which is having the longest tendon in our body. The longest tendon in our body is for which muscle? Plantaris muscle. And popliteus muscle, I hope you know about the locking and unlocking of the knee joint. Locking of the knee joint is done by quadriceps femoris, whereas unlocking will be done by popliteus muscle. The popliteus muscle is actually helping in unlocking of the knee joint. That is the importance of this one. Now, all these muscles are present in posterior compartment of leg, and they're all taken care by tibial nerve. Tibial nerve will be supplied to this one. And simultaneously, I told you the important points regarding all the muscles, what to remember here. Then what is going to happen here, sir? Tibial nerve is further going down. From the leg, it is going to enter into the foot. It will take a turn, enter into the foot. In the foot, it is dividing into two nerves there. One is your lateral plantar nerve. Another one will be the medial plantar nerve, sir. The name is very, very simple here. Yes, my dear friends, if this is the foot, this surface here will be the plantar surface. Lateral plantar nerve and the medial plantar nerve. And these nerves are the one which are going to supply to all the muscles of foot. And those muscles of the foot, I'm going to tell you separately here, sir. Clear? Don't worry about that. So that is the reason why I was telling you, if you learn the sciatic nerve in detail, slowly, aram se, okay now, if you learn the entire sciatic nerve in detail, my dear friends, majority of the lower limb topic will be completed here. So we are also done with the sciatic nerve here. We are done with the common peroneal nerve here, tibial nerve here, the deep peroneal nerve and superficial peroneal nerve. Many nerves will be covered here, sir. Okay. Now let us see the injuries here, sir. One by one, let us see the injuries here. For example, if the tibial nerve is injured. If tibial nerve is injured, then what is going to happen? These muscles are all paralyzed. If these muscles are gone, that means which muscles are gone, sir? They are flexor hallucis longus and flexor digitorum longus. They're actually helping in flexing the digits and the hallucis, the grade 2. That means they are actually helping in plantar flexion. If the tibial nerve is gone, the plantar flexors will be gone. If the plantar flexion will be gone, then dorsiflexor muscles will be like more dominant and the foot will be actually dorsiflexed. And the person will be walking on the heel, that is known as the calcaneal gait. What is the gait? Calcaneal gait, sir. So if the tibial nerve is injured, then the plantar flexors will be gone. Only dorsiflexors will be becoming dominant. And that is the reason why, yes, what is going to happen? That type of gait is known as the calcaneal gait, sir. Calcaneal gait. Similarly, if the common peroneal nerve is injured near the neck of the fibula, I told you here it is most commonly injured there. If the common peroneal nerve is injured there near the neck of the fibula, then what is going to happen? Remember, yes, which muscles are gone? Dorsiflexors are gone, sir. If dorsiflexors are gone, that means you're not able to do dorsiflexion. The foot will be actually dropped. The foot will be dropped. Achha, not only the dorsiflexors over here, remember even the lateral compartment, I told you very clearly, the lateral compartment will have the muscles which are helping in eversion of the foot. So that is also gone. So there will be loss of eversion of the foot. So the foot will be more inverted. So remember two things here. If the common peroneal nerve is getting injured, then deep peroneal nerve is also gone and superficial peroneal nerve is also gone. So superficial peroneal nerve will be supplying to everters, loss of eversion. Deep peroneal nerve is supplying to dorsiflexors, loss of dorsiflexion, that is foot drop. So just imagine loss of eversion. The foot is more inverted and it is dropped. How the person will walk right now? Left foot is normal, but the right foot he has to pick up high and keep it on the ground. Pick it up high and keep it on the ground. This type of gait is known as the high steppage gait. Okay. So that is about the clinical correlation of this sciatic nerve injuries. Common peroneal nerve injury as well as the tibial nerve injury, sir. By the way, if they give you like one-liner in the exam, what is the nerve involved in the foot drop? If they just give you like what is the nerve involved in foot drop? Yes, your answer should be, it will be common peroneal nerve. Don't mark the answer as deep peroneal nerve because common peroneal nerve is a better answer when compared to the deep peroneal nerve. So I hope all the points are very clear here. Now after completing this entire big nerve here, sciatic nerve here, sir, let us learn one small concept here. What is pes anserinus or guy ropes or goose foot? Actually, what is happening here? There is a muscle known as sartorius muscle coming from the anterior compartment of thigh, gracilis muscle from the medial compartment of thigh, and then the semitendinosus from the posterior compartment of thigh. All these three muscles, all these three tendons will be inserting at a common point, where they're inserting on the medial surface of the proximal tibia. So they're inserting on tibia on the medial surface. So sartorius, gracilis and the semitendinosus, all of them are inserting at one place on the tibia and that is appearing like the foot of a goose, of a duck. Okay, no? So that is like goose foot or guy ropes or the pes anserinus. Pes anserinus कहते हैं. So you people have to remember that it is formed by three muscles, sartorius, gracilis and semitendinosus. Okay, it is holding your hip bone onto the thigh there. That is why it is known as the guy ropes. Now, as I told you, the muscles of foot will be supplied by lateral plantar nerve and the medial plantar nerve. But there is something interesting here. Whatever muscles are there in the foot, they will be actually arranged in like 4 layers. And these 4 layers are arranged superficial to the deep. So if you are going to see the foot from below, you're able to see the first layer. Then inside there is a second layer, then the third layer and the fourth layer. So let us see all the layers of the foot one by one, sir. So in the first layer of the sole, you are able to see like 3 muscles here, and this will be your abductor muscle, sir. The one which is going to the grade 2, this is abductor hallucis. This one here will be the abductor hallucis, And this muscle which is going towards the little finger, that is abductor digiti minimi. And then you will also have like one more muscle in the middle here, that is a small muscle helping in flexion here. So that is why it is flexor digitorum brevis. Flexor digitorum brevis. Now, out of all these three muscles, remember, abductor hallucis is the one which will be supplied by medial plantar. On the medial side, makes sense, medial plantar. The abductor hallucis supplied by medial plantar there. And even the flexor digiti minimi, this is also supplied by the, yes, medial plantar. But whereas the flexor digitorum brevis will be supplied by medial plantar nerve. Now, I'll tell you one best thing how to remember this one. In the rapid revision of the upper limb topic, I told you about the muscles of hand. In the muscles of hand, there will be ulnar nerve and the median nerve. Now this ulnar nerve and the median nerve, you just make your hand like a foot here. So your hand is like corresponding to foot here. The ulnar nerve will be corresponding to the lateral plantar nerve here, whereas the median nerve will be corresponding to the medial plantar nerve here. The ulnar nerve, just now we have learned, it will be supplied to which muscles? It is supplying to the hypothenar muscle, the digiti minimi. And ulnar nerve is corresponding to lateral plantar. So it is supplied to the digiti minimi. Something like that. Abductor digiti minimi is supplied by lateral plantar nerve, whereas abductor hallucis as well as flexor digitorum brevis will be supplied by medial plantar nerve. If you remove this, welcome to the second layer of sole. In the second layer of sole, there will be like two tendons and two muscles. Now, what are the two tendons here? Number one, there will be a tendon which is actually going towards the great toe. Okay, now that tendon here will be the flexor hallucis longus tendon. So this one here will be the flexor hallucis longus tendon, and this one here will be the flexor digitorum longus tendon. Observe that flexor digitorum longus tendon. For example, if this is actually your sole here, your foot here, now flexor hallucis longus is actually coming straight here, going to the great toe. So when this tendon is going to contract, what is going to happen? The great toe will flex normally. But flexor digitorum longus is going obliquely. So when it is going to obliquely here, what is the direction of pull? It is going to pull in this direction. So when it is going to pull in this direction, these toes here, all the four toes over there, are they going to flex straight there? No. When it is going to pull in this direction here, the pull, it will be in this manner. So we need to correct the direction of pull. To correct the direction of pull, we are actually having one small muscle here, which is going to pull it properly in the straight direction. So that muscle is actually known as the flexor digitorum accessorius muscle. And flexor digitorum accessorius muscle, it's also known as the quadratus plantae muscle because it is quadrangular in shape, quadratus plantae muscle. After that, you're able to see the four lumbricals here. But remember, out of the four lumbricals here, only the first lumbrical will be the one which is unipinnate. And the remaining three lumbricals will be bipinnate. Okay. So now after that, let us see the nerve supply right now, sir. The quadratus plantae muscle, this one will be supplied by lateral plantar nerve. And in the lumbricals, all the lumbricals will be supplied by lateral plantar except the unipinnate one. And unipinnate lumbricals are supplied by median nerve. And median nerve is corresponding to which one? The medial plantar nerve here, sir. Perfectly correct. Now remove this. Welcome to the third layer of the sole. In the third layer of the sole, again you're having three muscles here. And these three muscles will be your flexor. So here, this one will be the flexor hallucis brevis. Flexor hallucis brevis. And this one here will be the flexor digiti minimi. And then this one here will be your adductor hallucis. So in the first layer, we have three muscles, and those three muscles, abductor. In the third layer, again, you're having three muscles, and here it will be flexor for the great toe and the little finger. Remember like this. In the first layer, you'll be having abductors. In the third layer, you're having flexors here. Now, flexor hallucis brevis will be supplied by medial plantar nerve. Flexor digiti minimi and the adductor hallucis will be supplied by the lateral plantar nerve, which is corresponding to your ulnar nerves. Now, welcome to the fourth layer of the sole, which will be having only the interossei. So, there will be three plantar interossei and the fourth dorsal interossei. Again, the same way, how to identify. Dorsal interossei will be bipinnate, whereas the plantar interossei will be unipinnate. And all the interossei in the hand will be supplied by ulnar nerve, And similarly here, ulnar nerve is corresponding to which one? Lateral plantar. So remember, all the intra-osseous are supplied by lateral plantar. Okay, I hope this is very clear. So after completing the sciatic nerve concept, we are also done with the muscles of foot here, so that the concept is entirely completed here, sir. Okay. Now, once you are done with this one here, let us go ahead with the next one, that is femoral nerve. Many questions are coming from here also. Let us discuss about the femoral nerve in detail now, sir. Okay, now in the femoral nerve, it is supplied to which compartment? We know that it will be supplied to the anterior compartment of the thigh. In the anterior compartment of the thigh, you'll be having sartorius muscle and the quadriceps femoris muscle. Many questions are coming from here. Let's look at that in detail, sir. So first of all, femoral nerve is going to originate from where? L2, L3 and L4. The two posterior division. Now posterior division of L2, L3 and L4 will combine together to form your femoral nerve, sir. Now for example, if this one here will be your ASIS here, anterior superior iliac spine, and this is the pubic tubercle here. Now between the ASIS and the pubic tubercle, there will be a ligament here. And that ligament will be the inguinal ligament. Now femoral nerve is just passing behind the inguinal ligament over here. Of course, it is not present inside the femoral sheath. There will be a femoral sheath present over here. But remember, the femoral nerve is not present inside the sheath. It is going outside the sheath. So now, first of all, in this region here itself, the moment the femoral nerve is beginning here itself in the iliac region, it will be supplying to one of the muscle, and that muscle here will be the iliacus muscle. So femoral nerve will be supplying to number one, iliacus muscle here itself. And then it is also giving like one more branch, but that branch is going behind the femoral sheath and supplying to one more muscle, that is pectineus muscle, sir. Okay, so pectineus muscle is getting a branch from the femoral nerve, but remember that branch is given in the iliac region only, but from there it is actually coming behind the femoral sheath and supplying to pectineus. In this pectineus muscle, remember, femoral nerve is supplying only to the lateral half of pectineus, whereas the medial half of the pectineus muscle will be taken care by obturator nerve. That is the reason why pectineus muscle also comes under the category of hybrid muscle or the composite muscle. Now after entering into the thigh, the femoral nerve will be actually dividing into like two divisions here, sir. One will be the anterior division, another one is the posterior division. But how it is divided? It is divided with the help of this artery here. That is your lateral circumflex femoral artery. Lateral circumflex femoral artery will divide the femoral nerve into two divisions here. One is your anterior division, another one will be the posterior division here. Now, out of this anterior and the posterior division, remember, anterior division is the one which will be supplying to, yes, sartorius muscle. Anterior division is supplying to only and only one muscle, that is your sartorius muscle. Okay. Now, apart from this, sartorius muscle, it is also going to give rise to like the two cutaneous branches, sir. Okay, I'll tell you about that cutaneous branches later on. First, let us see about the supply to the muscles here. So, anterior division is supplying to only and only, yes, one muscle, that is your sartorius muscle here. Sartorius muscle, many questions are coming here, sir. Remember, sartorius will be attached where? On the anterior superior iliac spine, and it is going all the way, crossing the hip joint and then crossing the knee joint and then inserting onto the tibia on the medial surface of tibia. I told you just now, it is one of the component of pes anserinus. Okay. So that sartorius muscle, it is also known as the Taylor's muscle and it is also known as the honeymoon muscle. Okay. Why it is known as like this here, sir, Taylor's muscle and all? Because you need to learn the action here. Sartorius muscle will be acting number one at hip joint, and number two, it is also acting on the knee joint, sir. Now, what is the action at the hip joint? At the hip joint, it is helping in flexion. Okay. Along with the external rotation also, sir, like lateral rotation here, and along with abduction. So flexion, abduction, and the external rotation. The sartorius at the hip joint will be helping in flexion at the hip joint here, and then the abduction as well as external rotation. Whereas on the knee joint, again it is helping in flexion as well as it is helping in medial rotation. So therefore, my dear friends, remember, in one of the exams they have asked the question, yes, which muscle will be helping in flexion at the hip joint and the knee joint simultaneously? So the muscle which is helping in flexion at the hip joint and the knee joint simultaneously will be your sartorius muscle. So remember the action of the sartorius muscle very well. And then the posterior division will be actually supplying to what? It will be supplying to another muscle, that is your quadriceps femoris. Now from the name itself we can understand biceps means 2 heads, triceps 3 heads, quadriceps it will be having like 4 heads. So what are the names of the 4 heads of the quadriceps femoris? They will be vastus lateralis, then vastus intermedius, and then the vastus medialis, and then you'll be having the rectus femoris. Vastus lateralis, vastus intermedius, vastus medialis, and then you'll be having the rectus femoris. So this is supplied by the anterior division and the posterior division. So that is about the muscles. Now when it comes to the cutaneous supply, remember femoral nerve, the cutaneous branches will be. What are the cutaneous branches of the femoral nerve? Number 1, they will be medial cutaneous nerve of thigh. Medial cutaneous nerve of the thigh. And number 2, there will be intermediate cutaneous nerve of the thigh. There will be intermediate cutaneous nerve of the thigh. But what I'm trying to tell you here is that it doesn't give rise to the lateral cutaneous nerve of the thigh. It is supplying to the medial side of the thigh and intermediate part, but not the lateral. Lateral cutaneous nerve of the thigh is a direct branch coming from the lumbar plexus. It's not a branch from the femoral nerve. Apart from that, the femoral nerve will also give rise to one more branch, that is your saphenous nerve cell. And this is important. Now, why this saphenous nerve is important here? Why? Because it is a branch given from your femoral nerve, fine. But it is not going to supply in the thigh here. That saphenous nerve will go all the way from the thigh into the leg, and then it will be going all the way up to foot, sir. And it will be supplying to the skin on the medial side of the leg and the medial side of the foot up to the ball of the great toe. Okay, so the saphenous nerve is going all the way up to the medial side of the leg and medial side of the foot up to the, yes, the ball of the great toe. Understanding your point here? So that is why it is the longest cutaneous nerve in our body. Saphenous nerve is the longest cutaneous nerve in the body. And second point that you have to remember is that the saphenous nerve is actually traveling along with the great saphenous vein. The saphenous nerve is also traveling along with the great saphenous vein. So these are all the points you have to remember about the femoral nerve here, sir. Okay. So it will be supplied to the 2 muscles over here, that is your iliacus and the pectineus. Pectineus hybrid muscle, remember that. And the nerve to pectineus will be coming from behind the sheath, that is your femoral sheath. It is divided into anterior division and posterior division by lateral circumflex femoral artery. And then you remember about the supply to the muscles and supply to the skin, sir. Cutaneous supply. I hope this topic is very, very clear. Okay. Now, after completing this one here, the sciatic nerve is done, femoral nerve is done. So majority of the nerves will be completed here, sir. So now we're going to identify all this, minor nerves over here. Now remember here, don't look at all the muscles. Just you have to remember only 2 muscles here, sir. Number 1, this muscle that you're able to see here will be the psoas major muscle. This is psoas major muscle here. And this muscle here will be rectangular shape, that is quadrangular shape. So it is quadratus lumborum muscle. What is the name of this one? Quadratus lumborum. So it is quadrangular in shape and it is present in lumbar region. Now once you are able to identify these 2 muscles here, I'll tell you how to identify the nerves right now. First, you're able to appreciate this nerve here. This nerve here will be the subcostal nerve. It is present below the 12th rib, subcostal nerve. So this is actually coming from T12 here. Then are you all able to appreciate like these 2 nerves coming in between the psoas major and quadratus lumborum? If the nerve is exiting out between these 2, then it is iliohypogastric nerve. And this is ilioinguinal nerve, sir. Iliohypogastric and ilioinguinal nerve, both of them are coming from L1. They are from L1, sir. And how to identify the iliohypogastric and ilioinguinal nerve? They are coming out between the psoas major and the quadratus lumborum. Then, can you see this nerve which is going to pierce through the psoas major and come out? The nerve which is piercing the psoas major muscle, this is genitofemoral nerve. And genitofemoral nerve is coming from L1 and L2. Then finally, this nerve over here, which is coming from the inner aspect of the ilium, and that nerve here will be the lateral cutaneous nerve of thigh. Lateral cutaneous nerve of the thigh, that is coming from L2 and L3, sir. That is a way how you identify all these nerves in this diagram here. Okay. Now, after identifying all these nerves here, let us see the importance of this one. First, let's get started with this one. I hope now you're able to understand here. The moment you look at this diagram, you can clearly see this nerve is piercing which muscle? Psoas major. It has to be genitofemoral nerve. Genitofemoral nerve will be actually having two components here. One is the genital branch, another one is a femoral branch. Now in this diagram, you can very clearly look at this nerve is going here, going here, going here. And this nerve is actually supplying to the skin over the femoral triangle. And this nerve is actually the femoral branch of genitofemoral nerve. Okay. So this branch, remember, it is femoral branch of genitofemoral nerve. And it is supplying to what? The skin over the femoral triangle. Already this question has been asked in the exam. Now the other branch that you are able to see here, this is genital branch. And genital branch is going through the inguinal canal here. And finally, it is coming and supplying to the cremasteric muscle here. That is the genital branch of genitofemoral nerve. Okay, so let me repeat this once more here clearly. The nerve which is piercing psoas major muscle, genitofemoral nerve. Genitofemoral nerve will have two components here, sir. One is femoral nerve, another one is the genital nerve. Femoral nerve is actually going to supply to the skin over the femoral triangle, whereas the genital branch is going through the inguinal canal, and finally it is supplying to the cremasteric muscle. Now, I hope all of you have heard about the cremasteric reflex. In any reflex, you should be having the afferent and efferent component. First, let us try to understand what is this cremasteric reflex. Whenever you scratch on the inner part of the thigh. So when you are scratching on the inner part of the thigh, what is going to happen? Ipsilateral side, the testis will actually ascend up. Ipsilateral side testis will ascend up. So which is the afferent component here and which one will be the efferent component here, sir? So remember, the femoral branch of genitofemoral nerve is going to carry the information. So that is the afferent branch. Genital branch of the genitofemoral nerve will be carrying the efferent component. Okay. So afferent will be the femoral branch of genitofemoral 1 and the efferent will be the genital branch of genitofemoral nerve. This is already asked many times in your exams. Please take care about this one here. Okay. So you're able to identify the nerve here and all the points are completed. Now, in recently one of the exams, they have given one more point here. Yes, which nerve is actually anesthetized in the femoral vein cannulation? Now, in this diagram, we are not able to see the vein here. You know the very famous mnemonic here. There will be femoral vein here, then femoral artery here, the femoral nerve here. All the structures are arranged in the form of van. So, femoral vein, femoral artery, and there will be femoral nerve. Now, when you are going to do the femoral vein cannulation, which nerve has to be anesthetized? So remember, again the same answer, the femoral branch of genitofemoral nerve. This nerve will be anesthetized in femoral vein cannulation. Okay, next one. Now this is like a repeat question in almost like, it has been asked in NEET PG also as well as your FMG exam also. This has been asked, sir. Meralgia parasitica. What is this one? First, the moment you look at this diagram here, I hope now you're able to identify this nerve, sir. This nerve is coming from the inner aspect of the ilium there. That is nothing but your lateral cutaneous nerve of the thigh. And the name itself is telling you that nerve is coming from the lateral aspect and supplying to the skin over the lateral aspect of the thigh. Now, sometimes what will happen, number one, during obesity or during pregnancy or in tied clothing, when the people are wearing like tied clothing over here, what is going to happen there? Lateral cutaneous nerve of the thigh will be compressed beneath the inguinal ligament here. The lateral cutaneous nerve of the thigh will be compressed here. If it is compressed here, the patient will come to you with the numbness or tingling sensation or the burning sensation or pain or stabbing on the lateral side of the thigh. Recently, this question was also given in the FMG exam as a clinical question. A pregnant female comes to the hospital with a complaint of, pain on the lateral aspect of thigh. Then which nerve will be involved? It is a lateral cutaneous nerve of the thighs involved. What is this condition known as? It is known as meralgia parasitica. What is this condition? Meralgia parasitica. Perfectly done here. So by this, my dear friends, we are also done with the minor nerves in the lumbar plexus here. Okay. So once you are done with this part here, so this segment is done here. That means majority of the lower limb topic is completed here. Okay. Now we are going to start with the gluteal region. Another very important topic. And many of the time the questions will be asked from this one here. Definitely like one question will be coming in every exam. Now in the gluteal region, first of all, it will be covered by the largest muscle in our body, that is gluteus maximus. Remember, the longest muscle in our body will be the sartorius. That is the longest lengthwise. Size-wise, the largest muscle in our body will be the gluteus maximus. Now after removing the gluteus maximus from here, this muscle here will be the gluteus medius muscle, and this one here will be the gluteus minimus muscle, sir. So the largest muscle, gluteus maximus, we have removed that one from here, and after that you are able to see the medius and the minimus. First, let us learn about all these three gluteal muscles. Gluteus maximus, the first point that you have to remember is it is the largest muscle in our body. Okay. Now the next thing that we have to learn is nerve supply. What is the nerve supply into gluteus muscles? The gluteal nerve. But in that you have to remember that gluteus maximus will be actually supplied by inferior gluteal nerve. Gluteus maximus will be supplied by inferior gluteal nerve, whereas medius and minimus, these two will be supplied by superior gluteal nerve, sir. Not only learning about the nerve, you should know the root value also. Superior gluteal nerve will be originating from L4, L5 and then S1. Whereas inferior gluteal nerve will be one segment below L5, S1 and then S2. Done? After learning about the nerve supply, let us learn the actions right now. Gluteus maximus will be helping in extension at the hip joint. It is helping in extension at the hip joint and external rotation. So right now you and me, we are actually in a sitting position right now. In the sitting position, our hip will be actually in the flexed position. Now from the sitting position, if you are standing up, that means you are actually extending the hip joint, and extension at the hip joint will be done by gluteus maximus muscle. Along with that, it is also helping in external rotation also. Now gluteus medius and minimus, these two muscles will be helping in abduction at the hip joint. Now not only abduction at the hip joint, it will also help in stabilizing the pelvis while walking. It will stabilize the pelvis while walking. Now these two muscles, that is, gluteus medius and minimus, are very much important. Let us learn one clinical correlation here. Okay. Now please look at this diagram here. In this diagram, please look at the first diagram here, my dear friends. Right foot is on the ground, whereas the left foot is off the ground. So because the right foot is on the ground over here, what is going to happen? The right side of the pelvis is like well supported, whereas the left side of the pelvis is not supported. So because it is not supported, due to gravity, what is going to happen? The left side of the hip or the pelvis will actually sag, or it will sink. So when the left side of the pelvis is trying to sink here, what is going to happen? The contralateral side, opposite side, I mean to say the supported side, the gluteus medius and minimus, they are going to contract. And when these muscles are going to contract, they're actually helping in abduction of the pelvis or the hip joint. And then it will be actually stabilizing the pelvis while walking. Your hip, your pelvis is neither falling here nor falling there. Understanding? So that is how normally we are walking right now. Now suppose that on the right side, the superior gluteal nerve is injured. If the superior gluteal nerve is injured, then gluteus medius and the minimus, these two muscles are actually paralyzed. When these two muscles are paralyzed, now how the person will walk? Again the same thing, right foot on the ground and the left foot is off the ground. And the left side of the pelvis now actually sinks. It is going to sink here. Why? Because what is going to happen? Contralateral side, on the right side, the gluteus medius and minimus muscle are not working. They are actually paralyzed. So if this pelvis or the hip will sink here, now how the person will walk? Now the person will actually take the help of upper half of the body. He is going to lurch the upper half of the body on this side here. And because of that, what is going to happen? The pelvis comes up, the hip comes up, and that is the reason why he'll be able to clear the ground. Understanding? So please remember that this type of gait where his body is lurching on one side is known as the lurching gait. It is known as lurching gait. But please keep in mind, in lurching gait, what is going to happen? If the hip is sinking on the left side here, it means the superior gluteal nerve on the right side is actually getting damaged. So please remember, the nerve damage will not be on the same side where the hip is sinking. It is actually on the contralateral side. Or else we can use the word there as the nerve will be injured on which side? The leg which is actually having full support, supported side. Whereas the hip will be sinking on the unsupported side. Keep that in mind. Okay. I repeat again, the hip will be sinking on the unsupported side, whereas the nerve will be injured on the contralateral side, which is actually well supported. And all these things I have actually written over here. Okay. And remember, when this is happening here, when the lurching gait is happening over here, this sign is actually referred to as your Trendelenburg sign. So which sign will be positive here? That is the Trendelenburg sign will be positive. If the hip is sinking only on one side, unilateral sagging will be there. That is known as lurching gait. And if the hip is sinking on both the side, if both the side nerve is getting damaged, that is known as the waddling gait. The person will be waddling the body on both the sides. Understanding? So Trendelenburg sign is positive. This question has been asked many times in your exams. So please take care about this one. Okay. So for the last and final time, let me ask you again here, if you're able to recall, Trendelenburg sign, if it is positive, then which nerve will be involved? Superior gluteal nerve will be involved. Then which muscles are actually involved here? The gluteus medius and the gluteus minimus muscle. These two muscles are actually paralyzed. Apart from these three gluteus muscles, we also have other muscles in this gluteal region. Let us see all these muscles right now. In this diagram, you're able to see here that this is the greater sciatic foramen. And from the greater sciatic foramen, there is a muscle coming here. This is piriformis. Piriformis comes out of the greater sciatic foramen. We have also learned this along with the sciatic nerve. I hope you recall that one. Sciatic nerve is going to pass below the piriformis. Okay. Apart from this small muscle that you're able to see here, it is gemellus superior. This is gemellus superior. Now below the gemellus superior, this muscle here will be the obturator internus. This is obturator internus muscle, sir. Then below the obturator internus, again one more small muscle is visible here. This is gemellus inferior. Gemellus inferior. And this muscle over here, which is rectangular in shape, this muscle here will be the quadratus. Quadratus femoris. Please be very careful with the name. It is not quadriceps femoris. We have seen the quadriceps femoris. Quadriceps means how many heads will be there? There will be totally like 4 heads. But this is not like having 4 heads here. It is quadratus. It is quadrangular in shape. So you should be able to actually identify all these 4 muscles in the exam. Already this image-based question has been given. Let us try once more here. The muscle coming out from the greater sciatic foramen will be the piriformis muscle. And then there will be gemellus superior. Then there is gemellus obturator internus, gemellus inferior, and then there will be quadratus femoris. Now all these muscles are also belonging to which compartment? The gluteal region only. Now one thing that you can easily understand from here, all these muscles, when they are going to contract, they are going to contract in this direction. When they are going to contract in this direction, what is going to happen? It is going to help in lateral rotation at the hip joint. So all these muscles will be helping in lateral rotation at the hip joints. So let us write about them here. Gemellus superior and obturator internus, these two are supplied by nerve to obturator internus. Gemellus inferior and quadratus femoris will be supplied by nerve to quadratus femoris. Wow, the name of the nerves is very much easier. I repeat again, gemellus superior and obturator internus, nerve to obturator internus. Gemellus inferior and quadratus femoris will be supplied by nerve to quadratus femoris. And I already told you all these muscles are going to help in lateral rotation at hip joint. These are all going to help in lateral rotation at the hip joints. Done. So this is all about the muscles and their nerve supply in action in the gluteal region. So now after completing this one here, let us go ahead with the next topic. That is, what are the structures which are going to pass through the greater sciatic foramen and the lesser sciatic foramen? So first, let me tell you about the greater sciatic foramen. One thing which my student knows very well, greater sciatic foramen, there is a muscle coming out here, that is your piriformis muscle here. So from the greater sciatic foramen, which muscle is coming out here? Piriformis. Now there are certain structures passing above the piriformis and there are certain structures passing below the piriformis. Let us see one by one. First, let's see above the piriformis. So above the piriformis here, you're able to see here that there will be superior gluteal nerve, artery and vein. So there will be superior gluteal nerve, superior gluteal artery as well as vein passing from above the piriformis. Wow, it is such an easy thing to remember here, my dear friends. It is just above the piriformis. So please remember superior gluteal nerve, artery and vein are going to pass above the piriformis. Done. Now what about the structures passing below the piriformis here? Everything else. So below the piriformis, you'll be having inferior gluteal nerve, artery and vein. What else is required in the gluteal region? Nerve to obturator internus, and then nerve to quadratus femoris. And yes, in the very beginning, I taught you about sciatic nerve. So sciatic nerve is also going to pass through greater sciatic foramen, but below the piriformis. Perfectly right. So this is like easy thing. Don't try to, actually make some mnemonic A, B, C, D and all those things, and don't try to mug up. It is very conceptual. The structures are actually coming from the pelvis into the gluteal region. And when they are coming into the gluteal region, above the piriformis, there will be superior gluteal nerve, artery and vein, and everything else is passing below the piriformis. Now, along with these structures, please include two more things. Pudendal nerve. Along with the pudendal nerve, there will be internal pudendal artery and vein. Simply internal pudendal vessels. Okay. Now, pudendal nerve, internal pudendal artery and vein. What is the story regarding this one? Listen here. This is actually going to pass through the greater sciatic foramen. Fine. After passing through the greater sciatic foramen, these three structures, pudendal nerve, internal pudendal artery and vein, these three structures are going to take a turn. And they are going to turn around the ischial spine. And after turning around the ischial spine, they are going to again come via lesser sciatic foramen. And then from there, they'll be actually reaching the perineum region. Okay. So from here itself, we can actually remember, like, what are the structures passing through lesser sciatic foramen? Of course, it will be the same thing. Pudendal nerve, internal pudendal artery and vein. The only one thing that you have to add there is even obturator internus muscle tendon will also pass from there, sir. So obturator internus, the tendon of that muscle will also pass from the lesser sciatic foramen along with the same thing, sir. Okay, so in this manner, please try to learn this conceptually. Now, why I'm telling you this, like, very conceptually over here is, in your exams, the question that is being asked is, what are the nerves? What is the nerve which is winding around the ischial spine? So which nerve is winding around the ischial spine? Remember, it is pudendal nerve. Other structures will also be there. I'll tell you later on. But for now, remember, pudendal nerve is winding around which structure? Ischial spine. Now, why do we have to know this one for your exams? Why? Because, my dear friends, remember, pudendal nerve block. Pudendal nerve is the main nerve which is actually supplying to your perineum region. Suppose if you have to block this nerve, pudendal nerve block, the only site where you can block this one will be the ischial spine. So you can easily identify the ischial spine and there you can actually block the pudendal nerve. So pudendal nerve block will take place at ischial spine, sir. Clear? So for these 2 points, you have to remember. I repeat the 2 questions once more here, already asked in your exam. The nerve which is winding around the ischial spine will be the pudendal nerve. And then pudendal nerve block will be done at the ischial spine, sir. Perfectly done here. Now after this, one of the most important topic, attachments on femur. You can always expect a question from here anytime in your exam. Whether it is NEET PG or INS-SET or FMG, many times the questions are coming from here. That to image based question they are giving. And that too in the FMG exam, they have given the X-ray image of the femur and they have marked the lesser trochanter. What is the attachment to lesser trochanter? So we have to remember about this image. Let us deal with this one in detail. Now, first of all, in this diagram, the first diagram given here is actually the anterior aspect. In this anterior aspect, you can see here, there is ASIS, that is anterior superior iliac spine. And then there will be AIIS, that is anterior inferior iliac spine. So anterior superior iliac spine and then anterior inferior iliac spine. Now, what will be attached at anterior superior iliac spine, so ASIS? Already I told you about the sartorius muscle, the Taylor's muscle or the honeymoon muscle. So sartorius muscle is getting originated from ASIS and it is going all the way crossing the hip joint and the knee joint, and then it is inserted onto the medial surface of tibia. And we have learned about that one in pes anserinus. Sartorius muscle attachment done. Apart from that, even the inguinal ligament is also attached at ASIS. The inguinal ligament will be extending between the ASIS and the pubic tubercle here. So even inguinal ligament is also attached at anterior superior iliac spine. Then what will be attached at anterior inferior iliac spine? It will be the rectus femoris muscle. Now, where did we come across this rectus femoris? Try to recall. It is one of the head of quadriceps femoris, vastus lateralis, vastus medialis, vastus intermedius, and then in the front you'll be having rectus femoris. Remember, rectus femoris will be attached onto the anterior inferior iliac spine. It's going to originate from here. Now, once you are clear with these two things, let us learn about the gluteus maximus, medius and minimus. On the posterior aspect, you are able to see here, this will be the gluteal tuberosity here, sir. And on the gluteal tuberosity, there will be attachment of gluteus maximus muscle. Already I taught you the action about that one. Gluteus maximus is helping in extension at the hip joint along with external rotation. Fine. But the important thing to remember here is all the fibers of gluteus maximus are not attached here. Some of the fibers are also attached onto the iliotibial tract. Now, what is this iliotibial tract? Remember, iliotibial tract is actually the modification of fascia lata. The deep fascia in the thigh, fascia lata, it is more thicker on the lateral aspect of the thigh. So there what will happen, the gluteus maximus, some of the fibers will get inserted. Okay, now if you just want to remember completely, you can remember from here itself that what are the two muscles attached onto the iliotibial tract? One is gluteus maximus, another one is tensor fasciae latae. The gluteus maximus, some of the fibers are attached onto the iliotibial tract, and even tensor fasciae latae is also attached onto the iliotibial tract. Then after that, what about the gluteus medius and minimus? Both the muscles are actually attached onto the greater trochanter. Both of them will be attached onto the greater trochanter. But the difference here is gluteus medius will be attached onto the greater trochanter on posterior aspect here, whereas gluteus minimus will be attached onto the greater trochanter only, but on the anterior aspect. And remember, both of them has got the same action. They're helping in abduction as well as they're helping in internal rotation. Abduction as well as internal rotation also. Fine. And we have learned that these two muscles, medius and minimus, are supplied by superior gluteal nerve, and if that nerve is injured, it will lead to lurching gait, in which the Trendelenburg sign will be positive, sir. Okay. Next one. Now on the lesser trochanter, there will be attachment of iliacus and psoas major. Together iliopsoas. Iliopsoas tendon will be attached here. Now, this is what I was actually speaking few minutes back. Ischial spine. Ischial spine. You should be able to identify in the image also. It was an image-based question given in the exam. So what is the nerve which is winding around the ischial spine? That will be the pudendal nerve. Pudendal nerve is going to wind around the ischial spine, along with internal pudendal artery as well as the internal pudendal vein is going to wind around the ischial spine. Pudendal nerve, internal pudendal artery and vein is going to wind around the ischial spine. Along with that, there will be nerve to obturator internus also. And we remember these structures as pin structures. So what are the structures winding around the ischial spine? That is your pin structures. Pudendal nerve, internal pudendal artery and vein, and then the nerve to obturator internus will be winding around the ischial spine. Okay. So this is all about the attachment on the femur. Please remember this topic very, very carefully, my dear friends. Anytime the question can be asked from here. And remember, it will be an image-based question. Moving ahead with the next concept now, that is tarsal tunnel. And this is one topic which is like repeatedly asked in your exams nowadays. Recently, this was also asked in the NEET PG exam also. NEET PG 2024 exam, I'm telling. Okay. And now in this tarsal tunnel, you're able to appreciate here, this is the medial malleolus. And this one here is the calcaneus. Between the medial malleolus and the calcaneus, there will be a band of fiber. This fibrous band here is known as flexor retinaculum. And because of this flexor retinaculum here, you'll be able to find a tunnel formed here, and this tunnel here will be referred to as your tarsal tunnel. And again the same thing, you got to remember all the structures present in tarsal tunnel. First, you'll be able to appreciate that there is a tendon here, the tendon of tibialis posterior muscle. Present in which compartment? Posterior compartment. Flexor digitorum longus and then flexor hallucis longus. These two tendons are also coming from which compartment? Posterior. So please make a concept in your mind. So which muscles or which tendons are we able to see here? The tendons which are actually coming from which compartment? Posterior compartment. Along with that, there will be an artery. Of course, there will be posterior tibial artery. Along with that, there will be a nerve. And of course, that is your tibial nerve. I'm telling you from the very beginning of our rapid revision session, tibial nerve is going to take a turn and divide into medial plantar nerve and the lateral plantar nerve. So yes, we do have a tibial nerve. Now, after learning all the names of the structures and how to remember them, now the thing, how to remember them in order. Okay. So remember, there is one mnemonic here to remember them in order. That is The mnemonic here will be the Tom, Dick and Harry. Tom, Dick and Harry. They're actually arranged in the same order, sir. Now in this Tom, Dick and Harry, remember T stands for the first tendon here, that is tibialis posterior. And then D here stands for digitorum longus. And of course it can't be extensor, it should be flexor only, flexor digitorum longus. And look at this and here, A stands for artery, that is posterior tibial artery. And then N here is the nerve, that is your tibial nerve. And then here H stands for the hallucis longus, that is your flexor hallucis longus. Understanding? So all the structures are actually arranged in the same order. Now, two important MCQs here. Sometimes the tibial nerve will be getting trapped here. It is getting compressed over here, and that condition is known as tarsal tunnel syndrome. What's the condition? Tarsal tunnel syndrome, sir. And one question which is asked from here is measuring the peripheral pulse. A doctor keeps his finger in between the medial malleolus and the calcaneus. Then what is going to happen here? He will be able to measure the peripheral pulse by which artery? That is the posterior tibial artery. So posterior tibial artery is the one by which we are able to feel the peripheral pulse over here. Then, now after understanding all the structures and that too in order, and I told you the clinical aspect of this one, recently in the NEET PG 2024, they have asked about the tendons which are going to pass just behind the medial malleolus also. So according to the feedback from the students, they have asked about this tendon which is going to pass just behind the medial malleolus. So please take care about that one also. Even the questions are asked in this manner from here. Okay, I hope you'll be able to take care about this one. Now moving on to the next topic, another topic, a small one, that is your ankle joint. Ankle joint, it is one of the variety of hinge joints because we are able to do the dorsiflexion and the plantar flexion. You know, dorsi and plantar flexion. It's an example of hinge joint, fine. But here I'm actually concerned about the tendons, sorry, the ligaments here, sir. Okay. Now there is one ligament on the medial side, and this medial side ligament, it is appearing like, deltoid shape. That is the reason why it is also known as deltoid ligament. Then there is a ligament on the lateral side, the lateral ligament of the ankle joint, it is also known as collateral ligament. So medial ligament of the ankle joint, that is deltoid ligament, lateral ligament of the ankle joint, collateral ligament. Okay. Now we need to learn its components here. And the component names are like so easy here. Just remember, in the leg region, we'll be having two bones, tibia and the fibula. On the medial side, we'll be having tibia. Now, whatever components are there in the deltoid ligament or the medial ligament, all those ligaments should be having tibia in their name. Why? Because all of them will be attached to the tibia here. So therefore, my dear doctors, remember there will be one anterior tibiotalar and then there will be one posterior tibiotalar ligament between the tibia and the talus. And then there will be tibiocalcaneal ligament. And then there will be tibionavicular between the tibia and calcaneum and the tibia and the navicular. Perfect. So these are all the components of deltoid ligament. In the exam, they'll be giving you like the same question. Which of the following will be the component of deltoid ligament except one? Please don't start searching here. Deltoid. Deltoid ligament is a medial ligament of the ankle joint. In the name, you should be able to see the tibia there. Similarly, in the lateral side, you'll be actually having fibula. So all these ligaments, all these components will be having fibula in the name. And again, the same thing, anterior talofibular, and then there is a posterior talofibular. And then you also have calcaneofibular. But remember, there is no ligament similar to that of your, between the fibula and the navicular. So there is one additional one here in the medial ligament here. Fine. So in this manner, you will be able to easily answer in the exam about the medial ligament and the lateral ligament of the ankle joint. Okay. Now the most important thing, that is about the arches of the foot. In the foot, you'll be having like longitudinal arches as well as the transverse arches. Whenever you're keeping your foot on the ground, you know very well, it is not like flat. In fact, the flat foot is one of the abnormality. So it will be a bit arched. And that will be actually helping in, moving on the uneven surfaces and all. Right? Now, the arches, there'll be like longitudinal arches are very much important. So there is one medial longitudinal arch here and there'll be a lateral longitudinal arch. Medial longitudinal arch will be like more arch, it's very high, whereas lateral longitudinal arch is not that much high in comparison with the medial one. And now let us see all the components of this medial as well as the lateral longitudinal arch one by one. So you need to just imagine it is like an arch there. So we need to see all the components of that one. The first, which bones are going to form this one? Remember, the medial longitudinal arch will be formed by the calcaneum and the talus and navicular, and then the three cuneiform bones, as well as the first, second, and third metatarsals. Whereas the later longitudinal arch is formed by calcaneum, cuboid, fourth and fifth metatarsals only. Fine. And you can actually easily remember this one if you just draw one small diagram here. So let me help you with that one. For example, if this one here will be the talus, and this is the heel bone, that is your calcaneum. Right in front of the talus, there will be a boat-shaped bone, that is your navicular. Then there will be cuboid here. Then there will be the three cuneiform. Perfect. Cuneiform. And then right in front of this one, you'll be able to find the metatarsals here, sir. First, second, third, and the fourth and the fifth one here. Perfect. Now the medial longitudinal arch will be contributed by calcaneum, and then the talus, and then the navicular, the three cuneiform, and then the first, second, and third metatarsal. It makes sense now. Okay. So instead of just writing this one here and mugging up here, the better thing is this one here, sir. Then what about the lateral longitudinal arch? It is formed by calcaneum, the cuboid, and then fourth and fifth metatarsal. Easy to remember now. Perfect. After that, what is forming the summit? See, whenever you have an arch or something like dome, so in the arch, there will be one highest stone, you can actually recall one of the arches if you have visited some places, where you have like arch kind of thing above the door or something. So in the arches, what will happen? There will be a highest stone to support the entire arch. That is known as the summit. So in medial longitudinal arch, which bone is acting like the summit here, sir? The highest one. It is the talus. Whereas in the lateral longitudinal arch, it will be the calcaneum. The summit is actually the highest bone which is supporting the entire arch in the middle. Then what is the main joint of the medial longitudinal arch? The main joint of the medial longitudinal arch will be the talocalcaneo-navicular joint. Talocalcaneo-navicular joint. And this joint is an example of ball and socket variety. Is an example of ball and socket joint. Whereas the lateral longitudinal arch, the main joint will be the calcaneo-cuboid joint, and calcaneo-cuboid joint is an example of saddle variety. So talocalcaneo-navicular joint is an example of ball and socket joints, whereas calcaneo-cuboid is an example of saddle joint. Perfect. Now, which is the ligament which is going to support the medial longitudinal arch? Remember, the medial longitudinal arch is mainly supported by the spring ligament. Now, where exactly you have the spring ligament? Please look at this diagram here. The spring ligament is actually between the calcaneum here, and this one here will be the navicular. Above you'll be actually having talus. Okay. Now this calcaneum bone, this part, this extension over here will be known as sustentaculum tali. That calcaneum bone will be having sustentaculum tali. Sustentaculum tali, the name is given like that. Why? Because it is going to suspend the talus above that one. That is sustentaculum tali. In the front there is navicular. So calcaneo-navicular, that is another name of the spring ligament. Plantar calcaneo-navicular is another ligament, another name of the spring ligament. Then the ligament which is supporting the lateral longitudinal arch will be the short and long plantar ligaments. Short and long plantar ligaments. You can actually appreciate them in the plantar region here. The lateral longitudinal arch is supported by short and long plantar ligaments. Then what is forming the tie beam? See, tie beam means, for example, if this is arch, the arch and the bow. Suppose if there is an arch, in the arch, the two ends will be tied by that thread or whatever, string. So that is known as the tie beam. Okay. So what is connecting the two ends of this arch? That is known as the tie beam. So here it will be the same thing, plantar aponeurosis. But on the medial longitudinal arch, there will be tendon of flexor hallucis longus. Flexor hallucis longus, that is also acting there, and the medial half of FDP, flexor digitorum brevis. And then lateral half of FDP will be forming the tie beam for the lateral longitudinal arch. And then last and final thing is the sling. Sling is those tendons which are going to pull the arch up and maintain the arch actually, For example, if this is the foot here, the foot is arch, so there will be like one tendon coming here and then tendons pulling up and maintaining the arch. The tendon is pulling up and maintaining the arch, and those tendons are referred to as slings. Slings, okay. So on the medial side, which tendons or which tendon will be acting like a sling on the medial side? tibialis anterior and the tibialis posterior. That is the reason why this will be actually helping in what? Inversion of foot, elevation of the medial border of the foot. Okay. Whereas peroneus longus and the peroneus brevis, these two are actually acting as sling for lateral longitudinal arch. So when they are going to pull up, they are the one which are going to help in elevation of lateral border of the foot. So therefore, they are actually helping in eversion of foot. Is it very clear now? So peroneus longus and brevis will be helping in eversion of the foot, whereas tibialis anterior and the posterior will be helping in inversion of the foot. Okay. Now out of these two, if you have to select the one best answer, that is tibialis posterior. Out of these two, if you have to select one best answer, then it will be peroneus longus. I hope it is very, very clear. We have covered like many points over here, sir. Medial longitudinal arch and the lateral longitudinal arch is completed here. Okay. Now after completing this, welcome to this diagram over here. In this diagram, yes, you should be able to identify this ligament here. This ligament is known as the bifurcate ligament. Bifurcate ligament. And bifurcate ligament, you can clearly see it is made up of two of them. One will be the calcaneonavicular ligament. Another one will be the calcaneocuboid ligament. Calcaneonavicular ligament and calcaneocuboid ligament, together they are actually going to form that bifurcate ligament. You got to remember about this ligament also. Once in the previous year exams, this image was actually given and asking you to identify that ligament here, sir. Okay. And my dear friends, the next thing will be about the dermatome. Okay. Of course, our lower limb will be supplied by the lumbosacral plexus. So let us see the dermatomes here, sir. And in this lower limb, mainly the anterior surface is only important here. And you can clearly see here, there will be L1 here. And then there will be L2 here, then L3 here, up to the level of the knee joint. So remember L1, L2 and L3 up to the knee joint. And followed by L4 will be on which side here? Medial side. Then L5 will be towards the lateral side here. Further L5 will continue here into S1, S1 towards the lateral side here. And then the S2 will be towards the medial side here. It's not visible in this diagram, but it will be there on the medial side. Fine. I hope it is very clear right now. So these are all the, dermatomes that you have to actually remember in the lower limb. Up to knee joint, it will be L1, L2 and L3. And then after the knee joint, there will be L4 on the medial side and L5 on the lateral side. That was arrow marked and asked in the exam. So please remember this dermatome also, sir. And by this, my dear friends, we are done with all the higher topics required to be revised in the lower limb topic here, sir. And by this, we finish this topic over here. I hope this revision will be helpful to you. All the best.